Can you hear us? Yes. Hello.
Yeah. Doctor, good morning, Dr. Bhupesh.
Good morning, sir.
I am Dr. Sarkar, and along with me, I've got Dr. Deep. We are moderating the surgery.
Thank you, sir. So we have just started. We have not yet done the graft harvest.
Yeah.
So my boss, Dr. Rajiv, says we have to show graft harvest. So we will show graft harvest. 15 blade.
Yeah.
15 blade. One more Langenbach to this side.
So can you just give us an idea about the patient?
This is a 23-year-old boy who had a football injury, gauze and curved artery. So he had a football injury. Right now his main complaint
Recording in progress.
He's got locking and instability. He's not able to play football again. So the MRI shows a torn ACL and a bucket handle tear of the medial meniscus. So in graft harvest, one tip for beginners is, can this part be seen? So what we can do is we can take a curved artery like this, and then a gauze like this, and then just push it in. This will auto dissect the anterior aspect of the pes anselinus. So once you do that and remove it, you actually don't have to do anything. You will have fantastic vision of the whole pes anselinus.
Okay, that's very good technique.
One more Langenbach here, Can I have one more Langenbach here, please? For time being enough, can we just shift this to the side?
Good morning, Dr. Bhupesh, Dr. Deep here.
Hello, sir. Hello. Please tell.
So, just for information, do you routinely go for graft harvest at the first spot or do a diagnostic?
I have finished a diagnostic. You can see the portal here.
Right. All right.
I have seen the ACL tear.
So, that is routine. That is routinely what you do.
Yeah. I never harvest the graft without doing a diagnostic. 15.
That's a great thing.
Give me vicryl next. The free threads that I have, vicryl right angles. So I am going to make a inverted L-shaped incision like this, so that I get the maximum length of semity and gracilis. Okay. This is my vertical limb. Show me up.
Dr. Bhupesh, actually just one question.
Actually,
there are 3 tendons there.
Yeah.
Starting with sartorius, gracilis, and ST.
Yes.
So first difficulty arises how to identify gracilis and ST from the sartorius. So how do you do it?
Yeah. So I will show that right now. So we will just put this just to hold Arna. Sir, with this you will make a pocket for me like that. Both of them. And then this. So if you see this layer, can this be seen? Yeah. This layer is your sartorius, what you see superficial most. Okay? And then I am going to continue my inverted L, and once I do this inverted L, I need a cocker, come down a little bit. I am going to hold this corner of the L and I am going to start dissecting in the periosteum like this. Don't worry about seeing any tendon. If I start dissecting in the periosteum like this, I will suddenly find a hole. Can you see this hole?
No, it's not very
Can you see
clear,
this?
the picture.
Cameraman, can you see this? Okay, take the camera, lens system. Somebody be a cameraman for me here. Can you? Excuse me, Arun, come here, hold this for me, please.
Use the arthroscope to show us better, yes.
Yeah. So, give me the 15 blade again, sir. Come down. Don't hurt anybody. So, out. Little out, zoom out. So, can you start seeing the hole here?
Yeah.
Yes, relatively clear.
Yeah. So, I was just going on, dissecting onto the periosteum till I saw this hole here. And then I continue doing that. Arun, give me some space. We'll show them again. I'll just come inside. Just give me a cocker. Come down. Now, 11 blade again, sir. Sorry, 15 blade again, sir. 15 again. So now I have got the, show me around. I have got the upper end of the L and I'm reflecting this whole thing outward. And then this shiny thing that you can see here is the MCL. So be away from the MCL and continue to work above right angle. Now, sir, show me. Now, if you see the inside of the sartorius, the rounded superior one is the gracilis, the flat inferior one is the semite. Can you see that, sir? Is it visible?
Please show the sartorius first. Please point the artery.
This is the sartorius. Okay? The outer side of the pes is covered by the sartorius. Sartorius becomes flat and becomes paper-like.
Oh, so you have taken the entire pes tendon
Yes.
out and now
Now,
selectively dissecting
after
it.
I harvest these two, I will reattach this entire thing back here. So there will be zero donor site morbidity.
Okay, okay.
Sounds
Okay?
fair, sounds fair.
So I have made an inverted L-shaped incision like this, reflected the whole pes for us to see everything. This is the gracilis, this is the semite, and this is the MCL.
Okay.
This is MCL, shiny. So I'm going to first take the gracilis, hooked, pre-thread. Okay? And then that fellow will come out like that. One more gracilis, one more cocker. Cocker, do you have a cocker?
Yes.
Slowly, don't be in a hurry, slowly.
So, Dr. Bhupesh,
Yeah,
I see that you have painted the knee alone. Do you ever prefer to keep the ankle also free in case funny
sir, we
things
have
happen? in the
painted from the toe all the way to the groin.
All right, all right. It
Ah.
looks straight. No, in case any funny things happen, there are times with us it has happened, our semite just dropped off. Then we have to again rethink and recalibrate our strategy for the whole surgery. Does this thing happen?
Sir, as a rule, I always paint the whole limb. There is no shortcut here.
There is no shortcut.
Right angle again. Very thin printing, sir.
Cocker. Is there a cocker like this?
So, as you are saying, it is always safe practice. Scissors, give me scissors. Yeah, thank you. Scissors.
So as a rule, you get the gracilis out first or semite out first?
Always 70, sir, because
Always
even without the gracilis, you can complete the surgery. But if you don't have semite, it becomes difficult to complete the surgery. So as a rule, I always want my semite out first. Then even if something happens to the gracilis, it doesn't matter. So what I'm doing now essentially, one second, is a loop in loop technique. You see they have made one loop and I'm making the second loop and then doing this. When you have, when you have good assistance, you can do this because you don't have to waste time doing hip stitch on table.
Right.
They can do it in the back of the table. Now this is supposed to give as good as a pull-out strength as a whip stitch itself.
Whip stitch itself, yes.
Yeah, this is very important step because first step is the identification of the tendons. The second
Right angle
step,
and then sir.
the second step is that you hold the tendons in a firm grip. But because I have had instances where you lost the tendon got pulled up inside the thigh. So you must have a very firm grip on the tendon.
Can you see this? There is a very deep vinicula that we have identified and we are cutting it. Failure to do that will cause premature graft amputation in life surgery. Yes.
Yes, this is the third important step in graft harvest. You remove all the vincula, otherwise there is a very likely you may amputate the graft and then you're back to square one.
Stripper? Thank you. So gently allow things to take their own path, and then usually that looks like a good graph. And Arun, prepare this. Right angle again for me. So now I am going to see the next tendon, which is our gracilis. So this is gracilis, scope. So this is gracilis. Can you see this?
Absolutely.
I have taken the semity which was here. Now I am taking the gracilis which is here. The MCL is here. And then I will close everything like this, so there is no donor site morbidity. Correct? So I am going to harvest the gracilis which is here.
So do you wait up for your assistant to confirm the diameter of the semity alone, or you straight away go ahead and...
So it depends on what I am doing. If I am doing a straightforward ACL, I will not wait. I will do a tripled semity and a doubled gracilis, and there is no problem at all in achieving the required length. But if I am doing, one more cocker please. But if I am doing ACL with something else, then I want to save the gracilis for something else, then I will wait for him to tell me about the length of the semity, so that I can do a quadruple ST and do something else with my gracilis. Scissors. Pre-thread. First loop, yes. And don't tighten this. Leave one hand to me. Just hold these two together. Hold the free ends together. What I will do? We'll do it again. Yeah, give me the loop. Yeah. So can you see this? One loop. And then pull that out, and then bring this down, and then the second loop. Okay. Now open this. Leave it. Vehicle. Hey, fast 10 vehicle. Hold this somebody. Okay, thank you. Don't relax. So what I'm going to do now is try to stitch this back so that can you see this, sir? Donor side.
Yeah, yeah.
It looks absolutely fantastic.
One vicryl, 102, something. Quickly, we have a lot of work to do. Quickly. The next step that I'm going to do after this is put the scope in. It's okay, give it to me. Don't touch betadine, just give it to me. Sir, just give it to me. So one bite from here, another one from there. Okay. Then turn this around. One bite from here, and one bite from here. That's like a mattress. Arnab, can you hold this? I'm lucky that Arnab is around, so half my work is done already. Out. Thank you. So that's it. Just take. Thank you. So one more quick knot and then we are come down. Show me here. So one into that, one into this. Here a simple is enough. And this makes sure that there is no bleeding from this side, and the chances of regeneration of the semitigracilis is high. Thank you. So we'll go with the graph. Scope, please. Prokar.
Dr. Bhupesh, one question.
Yes, sir.
So how old is the injury?
Injury is 6 months old, correct? Yeah, injury is 6 months old. Here, somebody here. So that is our ACL, which is torn. You can see the notch is empty. Top light. This is our bucket handle tear of the
I
middle
think you
meniscus.
can show the scopy view right now, no need to.
Yeah, scopy view, outside needle, long needle. Arun, do you want anybody else to help you with the graph?
Copy view.
So I am bringing my needle in. I am trying to be close to the patella tendon, and I am just above the meniscus here. Can you see that?
Yeah.
So I am entering here because now I have to do a lot of medial meniscal work. I am entering here. I will make an accessory portal which is lower and little more higher, little more medial after that for my ACL drilling.
So just tell me, which zone is the meniscus tear when you did your diagnostic scopy?
Sir, come again? I couldn't hear you.
No, which zone is it in a red white zone? Which zone is it?
No. This is a complete bucket handle tear.
Uh-huh.
It looks little complex. I will look into the tear configuration and site now in detail.
Sure.
I was mainly looking if my ACL is absent when I did the diagnostic, so that my graft harvest is not a mistake.
Right.
Now is the time to go and unfortunately, because there is a marathon going on, we all reached the hospital late. So we just started when we went live, so we have not yet done all the work.
No need to worry. We are still fresh.
No, we could at least see your graft harvest that way.
Yeah. Usually graft harvest was not part of the plan to go live, but so now I am going to try and do few things to improve my visualization of this injury. Okay. Now there are factors to decide. Needle again. So this is my entry now to do the meniscus work. I will do an entry later from here after the meniscus work is done to do transportal drilling into that. Can you see that, sir? The trajectory?
Exactly, yes.
Yeah. So, but first I will reduce the meniscus, assess it, then the plan is to do a femoral tunnel for ACL. By the time they will tell me the graft size, because you need hyperflexion for that blunt repair. And after that, I will start working on meniscal repair and then the tibial tunnel of the ACL, and then we will end the procedure. Give me a switching stick or the depth gauge of the ACL set. So, hold this for me. Open the knee for me, medial side. External rotation, you come here, you come here, you come here. Yeah, your forearm on this one. External rotate, hand on. Yeah, yeah. So, cameraman, can you show what Dr. Arnab is doing for me? So he is using his forearm to external rotate the foot. Can you see that? And he's giving me a valgus. So with that, I'm able to reduce this meniscus.
So knee is in full extension, is it?
Yeah. I'm going to flex it a little more. Okay. So this is a meniscus which doesn't want to go back. Can you see what is happening to the meniscus? Okay. So now, yeah, hold the scope for me. So what I'm doing essentially now is, can you see the outside view? Pen. Give
Yes,
me the
yes.
pen. I'm palpating the shin of the tibia, neutral. The posteromedial border, I'm keeping a straight line. Okay?
The cameraman
Pen,
can
pen,
do a
pen.
better job.
Pen for me, please.
The head is in the way.
And I am putting a straight line along it. This line is along the posteromedial border of the tibial shaft and then all the way up. So this is called the TU line described by Bancha. And scale for me, scale. Needle and scale for me, please. Needle and scale.
Please show the outside view.
Needle. Needle. Okay, hold this one. So I have to see where the joint line is, which is around there. Can you see the joint line? With the needle, I'm making sure the joint line is there.
Requesting the cameraman to focus in the operative. Yes.
Focus here. And along that line, pen. 1.2 centimeters from that joint line is where I will do my MCL pie crusting. Could you see that?
Yeah.
That is my point. Now, I guess. Yeah. I guess open. Yeah. You can actually feel the opening here.
You are using a needle or a blade, No,
just a needle.
Just
Can you show this side? Cameraman from here. And now my middle compartment is beautifully opened up. Can you see that?
Yeah. I can see the meniscus much better now.
Yeah, now the meniscus is floating,
Yeah.
which was not happening before. Okay? So I'm just going to remove the dust here. Saline, can somebody pump a little bit? So this took exactly 20 seconds of my time, but rest of the surgery becomes pain-free for me and the patient. Because the idea of doing the surgery is to preserve the knee. If we do cartilage cuffing during it, then it doesn't make sense.
Right. So this is a good technique you have shown.
Yeah, you can see that the middle compartment is now nicely, widely open. Yes. Okay. And all that was required was only this needle, nothing else. Now I'm going to try to evaluate it better. So as we discussed in the morning with some of our fellows, this is a complex tear with a tear in the back and a bucket in the front.
Yeah.
Is this understood?
Please show the.
And this bucket doesn't want to go back even after opening the joint this much. So this is a bucket that is not going to survive. It is rounded off. So I am going to remove this thin bucket because this is anyway in the white-white zone or red-white junction. But this tear we will try and repair.
There is a sort of radial tear, I think.
Can we understand what is happening? Can we see what is happening, sir?
Yeah.
Yes,
This is a double bucket kind, not a double bucket. This is a complex tear here with a bucket here. Okay, maybe a double bucket. You can see one bucket.
Looks like a double bucket, yes.
Yeah, first we will excise this, then we'll understand on what to do with this rest of the thing. So biters, no stress, just give me straight, white punch, not the narrow one. So and then give me a grasper. Okay, so what we have to do first is try to go shaver and form two tunnels. Today, this is a very important step. I am removing some synovium from the PCL here because the tibial spine is quite prominent in this patient here. Can you see this tibial spine?
Yeah, yeah, you can see the tibials.
So I need two angles of attack, one for my scope to come in and the other for my instrument to come in. So now in this attack, I will go and see my posterior horn root area like this. And yeah, thank you so much. And through the medial compartment, I will bring my instrument like this. Can you see how nicely I am able to see where I am going to cut this bucket?
Yeah.
This kind of view is very important and then the bucket is done. And then now I will leave the knee down so that this doesn't go back 90 degrees. Come in and remove this fellow from here. Take a mosquito or a grasper. Give me a blade. We'll just extend this a little more. And then pull it off. So always try to remove the posterior arm of the bucket first. It might look juicy to remove this one first, artery forceps.
It will save a lot of time and the surgery becomes relatively simpler when you get the posterior horn and
exactly.
Removal becomes really easy.
Yeah, green sheet down. Thank you.
So the question from the audience is?
So what I am doing here intentionally is, I am leaving a small twig of meniscus still attached here. And then, because I don't want it to run away, and then I hold it. And then I try to see where it is completely. Come and hold this tip. Okay.
Dr. Bhupesh, there is a question from the audience.
Sir, just one second. I'll just show this for
Please.
a second. I'm holding it in this end. It is not holding. And okay, give me something that holds. Okay, there's a grasper, arthroscopic grasper. So I'm going to hold this. Where is it? Here, bite it down, lock it, and then do what is called as the death roll. The crocodile's death roll. Okay? And that will remove that, and the whole thing, can you see this? Outside view? Whole bucket has come out in a single piece. Yeah, shaver. Sir, please ask me, sir.
Yeah.
Some question from the audience?
Yeah. So the question was, what is the harm in removing the posterior attachment first of the bucket handle?
Anterior.
What is the advantage?
No.
Yeah.
I will just
Sir,
reframe
if
the
you don't
question.
do the-
Sorry, anterior attachment.
part, yeah.
Anterior part.
What is the harm? So what happens is, if your anterior becomes mobile and the posterior is intact, it will flip into the back of the knee into this part. It will flip into this. And then you have to make a posteromedial portal and play with it, and it is always a headache. So you go in and remove that first, and then this will be in the front of the knee. Removing that is easy.
Right.
Okay? Werewolf?
Sir, do you have your answer?
Werewolf?
Sir, we'll wait for at the end. Let's ask the question.
Pardon? Probe.
Give the mic, please.
Probe. So you can see the amount of condyle damage that has already happened because of the bucket handle. Okay? Probe. Just give me a regular probe, please, somebody. Probe, please. Just arthroscopic probe, please. My scoop. Arun, scoop. Can you hold this, sir, for me? Yeah, just put it up like that. So the MRI showed a normal lateral meniscus. Lift it up, sir, please lift up. Yeah. There's a small tear here, which can be managed This looks fine. I will go in and see it well. Yeah, looks fine. Okay, so narrow punch for me. Just take care of this immediately. Narrow punch. Yeah. Dr. Arnab will press. You can lift it some more, sir. Lift it some more. Lift. So, knees which have big tibial spines like this are always a headache. Knees with shallow tibial spines are relatively okay. Saline. So there are two things that I can do here. Flyer, somebody's got the flyer shaver. So I've just saucerized this little bit. Okay, there's one more small twig. I'll remove that and then make sure it is properly balanced.
Jal, pump.
Can somebody see if water is coming in? Sir, can you lift up a little more, sir? Yeah. Flyer is ready? Yeah. Thank you. So this is a new shaver from Smith & Nephew. It's a fantastic shaver, quite low profile. Now what this will do is, it acts like a torpedo. Can you see this? And then it will balance the meniscus very well. Can you see what it is doing exactly? Yes. And that is done.
So what is the diameter of this new shaver you're speaking about?
I think it is 4 mm. So we have taken care of that in a matter of few more seconds. We are done with this.
The damage is also less.
Yeah.
The cartilage.
Exactly. This is called the flyer. Yeah. So sometimes another trick for everybody, sometimes when you have difficulty in opening the lateral compartment like this, just an extension of varus stress will sometimes open it well. Just give a varus stress like this. No. Hand always should never go back. I'll show you. Keep it here. Yeah. And can you see? Beautiful. That's it. And that is quite well balanced. Okay? So we'll leave it with that. Okay. So when you have difficulty in opening in figure of 4, sometimes the varus stress will do the trick. Now scoop for me. RF foot pedal, okay. Hand operated. No work for foot. Good. So I'm just going to look at the ACL footprint now.
Dr. Bhupesh, can you show us the menisci again? What is the final state?
Sir, I'm not able to hear you, sir. Can you be a little louder?
Can you show the menisci again? The lateral and medial menisci?
The medial meniscus?
Yes.
Sir, we are going to deal with that in detail after I complete the ACL femoral tunnel, because I don't have to hyperflex the knee after I do a meniscal repair. So we'll first finish this step where hyperflexion of the knee is required, then come back and do the medial meniscus in detail, because we will otherwise be wasting time.
Okay.
Thank you, sir. So that is your ACL footprint. Because it is chronic, there is no landmark. But what you can see is this ridge here. This is your residence ridge. So your ACL is everything behind that, nothing above it, in front of it. So this is where I want my ACL to be.
Yeah.
That is exactly where I want my ACL to be. So we have moved to single tunnel now from double bundle. Single bundle is what we all do now. So
can you show us the center of the anatomical footprint?
Yeah, in a minute, sir, in a minute. I'll just remove this debris shaver now. You can shift it to regular shaver also. Shift it to the regular shaver next.
suction like that.
Suction working?
Suction.
Yeah.
What?
Give me the needle now. Give me the needle now. Universal handle and chondropic. So outside view please. Camera outside view. I'm going to come from here. Quite low, just above the meniscus. Can you see this entry point? And reasonably away from the medial femoral condyle. I'm going to make another portal here so that I can go down and attack it there.
Yes.
That will be my footprint. Can you see that, sir?
Okay. So it
So
is
this is
about,
my residence ridge. Okay? And this is the area of ACL. I will want to be in the center.
yeah, about 30% from the behind, 28% from below.
So are there any situations you will be using the offset guide for the femur?
I always use it,
Always
sir.
use it.
And I also chondropic, mallet, and I would suggest first chondropic, straight chondropic, just to make a hole. Mallet, green color guide. So one more trick is when it is a chronic case like this and a lot of things are not seen. This is the top of the notch, if you come out. This is the bottom of the condyle. So I will want to stay 50% and stay there. Can you see that?
Yes, yes.
So that is where I want my tunnel to be. The height will be decided by this method. The offset from the posterior wall will be decided by the graph diameter and the offset guide that I am going to use. Mallet, please.
So which offset guide to use?
So as a rule, 9.5 and above I use the yellow offset, which is 7 mm. 9 and below I use the green offset, small taps, gentle taps. Yeah. Go. Thank you. So that is my pilot hole. Okay? Green? Yeah. Put it in the put it by the side. I'll show you. No. Give it to me. Put it by the side. Yes, thank you. Correct. You are right. Press that. Yeah. Can I do it? Yeah. Thank you. Alright. Graft. What is the size? So we will quickly go and see the graft side before we start.
Yeah, please detail us about what kind of graft, what diameter, what length we have achieved till now.
Camera to the graft. Gracilis, huh? What is gracilis and semity. So we have gracilis and semity. So if you see, semity is around 31 centimeters, and I have asked Arun to keep the gracilis to 220. Can you see that?
Yes.
So what we are going to do is, hold this. Open both. I am going to, not too much, no, just, I am going to triple my gracilis. Knife. Hold it here. Where is the free thread? One more free thread. Yes. Okay, thank you. Keep both equal. Yeah. Can you see this, sir? I have tripled my gracilis.
Yes.
Sorry,
yes.
semity,
Very nicely.
and doubled my gracilis. So this is a 5-strand STG. And now we will size it. Size it. Hold it. Leave it. So this is 8.5. 8.5 tibia looks a little tight. 8 looks, see, I'm struggling to bring it out. Okay. Again, show me like this, show me like this. The surgeon should see the end on view. Okay. So 8 looks very tight, but I want to go with 8. 8.5 is very tight for the tibia, but I'll stick with 8 and 8.5 because I want a very good tight snug fit graft. So hold this. .5 reamer, first breathe pin, then mosquito. 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 I always put my graft in the traction board because late elongation of graft is something that is not in our control and we don't want that to happen. Done. Relax, relax, leave it, leave it. Mosquito, please. So this is my graft, looks robust and nice, okay? So 8, 8.5 is tight, we'll do 8, 8.5. Okay, so just lift it and, so do we have another sheet here? One more sterility, we can lift the leg. Somebody can, where's a technician in the morning? Can you lift the, you should come from that side, huh? Not from here. Come from behind. Give me a sheet, give me a good sheet. Sterile sheet, 1 second, sterile sheet please. Give me a sterile sheet. So this is a 6 mm offset. So when I have a 4 mm diameter around, I'll still have a 2 mm posterior wall. With human error, it will always be 1 mm. So I will not have a posterior blowout. I will err 1 mm on the other side, on the safer side, than having a posterior blowout.
Yeah, that's safe.
So what I recall is, you said if the graft diameter is less than 9, so you will go for 6 mm offset, and if more than that, then you'll go for the...
Yeah, 9.5 and above, I'll go with the 7 mm offset.
7 mm offset.
Scroll this. Yeah. Leg support up. Yeah. Sir, technician, sir. Up, up, up. Give him space, give him space. Go from under. Just one step. We will keep it up and then again you will have to bring it down. Yeah, hold the leg. Thank you, thank you, thank you, thank you. Thank you, thank you. You can come out. You just hold the leg. Can this be removed from here? Can this be removed from here? One more green sheet, just to be safe. One more green sheet. should never compromise on sterility because. Okay, thank you. Flex, flex, flex. Can you hold it like this?
Yes.
Yeah. Blender cannula scope. Yeah. 4.5 ready, Arun. Breathe pin ready, Arun. Then give a 8 mm flower tip. Okay, shiver, shiver.
Water.
Sir, you only hold the leg, sir. Everything else we will take care, huh?
You want the table to come down.
Yeah, if the table can come down, I'll be happy.
Table next to down, Scott, slightly.
Dr.
Somebody
Bhupesh,
check.
can you hear me?
Yes, sir, please tell me.
So what is the direction of your guide wire while you're drilling the lateral femur?
Height is enough.
You come out totally laterally or you slightly superolaterally?
Sir, can you be louder, sir? We are not able to hear you.
What is the direction of your femoral drilling?
Yeah, femoral drill, direction.
Yeah, direction. Is it lateral or slightly superolateral?
So the femur drill will be from down upward.
So superior, slightly superior.
Yeah, from down upward, and I will want to exit exactly as a second indicator that I am doing the right thing. I will want to exit exactly in the mid half of my thigh, laterally.
Yeah. So what would be the expected thickness you would
Length
get?
will usually be around 36. Okay, slowly flex Arnab. Arnab will flex, Arnab will flex. Arnab will hold the thigh and this one together. Yes, thank you, Arnab, perfect. Now somebody will bring the drill from this side and go. And that is our mark, can you see? That mark will decide in the superior inferior plane. The distance from the posterior cortex will be decided by the offset guide.
Right.
Okay? Yes, go all the way. Second cortex. Exit, 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 exit. Come on. I am exiting exactly where I want to be. That is the mid half of the thigh in the lateral aspect.
Right.
Give me the. You keep a drill. Keep a kidney tray ready. 8 mm flower tip primer ready, and give me a free shaver outer cannula alone. Put it in, put it in, put it in. Not now. For 8.5, not now. For 8.5. So I think 36 was the number. Depth gauge. Never skip steps. Always check, even if you are sure. Depth gauge.
Depth gauge.
No. Behind that. See that? No. You used it for marking during the first step. That one. Thank you. 36 it is. Okay, sir?
Yeah. Sir, right. Very right. You had said
So we will
36.
go with the 8.5 big pin.
Big pin.
8.5 flower tip, please. Same hold. Careful, don't. 8.5. Kidney tray, shaver handle.
So what
No,
have you
really,
decided?
sorry,
What are you
8.5,
planning for the
8.
fixation in the femoral
8.
side?
What is the size? 8. I want 8. Sorry, my mistake. Femur 8 to be 8.5. Sir, for femur I am planning endo button which is a fixed cortical device.
Fixed loop
If I
device.
have 36, I will usually use 15 endo button and I will ream up to 31. There is a quick easy math that you can do. If you are using 15 endo button minus 5 knife minus 5 from the total length. If you are using 20 endo button minus 10 from the total length. These are the only two clinically relevant numbers because we very rarely end up using 25 nowadays after we have shifted to transportal.
So what
So
will be
this
the
is 15
length of
endo
the,
button, so minus 5, that's all.
so what will be the length of the femoral tunnel finally?
So if I, length of femoral tunnel is 36, graft inside will be 21 and loop inside will be 15. Arun, move around. So I have to ream up to 31. Hold this. Kidney tray, kidney tray, kidney tray.
So,
A simple trick is to,
so you tend to,
a simple trick is to put this shaver inside and it will clear the debris and make us, give us a fantastic view like this.
so you are exactly drilling 1 centimeter more of the socket, is it? If 21 is the graft.
Exactly. 10 mm is the size required for a 12 mm 4.5 button to flip over from a 4.5 hole. Okay, so I will go 31. So that is 31. Can you see? I can be really precise if I put a shaver inside.
Yeah.
The shaver blade will go and dissect this place and I can be really precise. So I am happy with that. Free thread, free thread, free thread. Give me free thread. Yes, thank you, thank you, thank you. Mosquito. Mosquito for me. Pull. Just pull it. Pull. Mosquito for me. And technicians are down. No. That's okay. Down. Table height up, please. Table height up, please. Can you hold like this, sir? Yeah. So don't touch it. We'll just drop it down. Yeah, table height up, some more up, some more up. Thank you, thank you, thank you. So, shaver again. Shaver. Quickly. Now we will turn our attention to the meniscus. Diamond rasp. Open Nova stitch. So I am very happy with the tunnel. You can see it is a very low tunnel, correct?
Absolutely.
And not much of posterior. So that is a tunnel, correct?
Right.
So I think that tunnel is a good tunnel for ACL. You can see large amount of bone in the front of the tunnel. So now we will shift our attention to the meniscus. Give me the torpedo blade, the flyer blade. Give me the. So meniscal repair, Bankart repair, all these are biological surgeries. So preparation is very, very important. In fact, preparation is more important than tying the knots. So my boss used to tell me, it is like marriage. Preparation is more important than tying the knot. So somebody will open this for me. Diamond rasp, probe, whichever you get first.
Just a quick question. Do you think of doing multiple trephinations in the femoral side for meniscus as an augment for meniscus healing?
Sir, come again. The MCL pie crusting is what you are
Not
saying,
not exactly pie crusting on the
trephinations.
Yeah.
Yeah.
Bony
I've
trephinations.
still not started the biological work. I'm going to start all that now. Okay. Now I want you to nicely open it out for me. Yeah. Okay. Can you bring down the table height down? Table height down. So I'm just trying to assess this. As we discussed, this is a double bucket. Another flimsy one. So I will first go preparing. There are few signs if the meniscal repair will survive. One of the sign is trying to do a mild shaving. This is not explained, this is what I do, without much of suction. If this is really flimsy, the shaver will remove all this. If it survives that, then it is a meniscus that needs to be saved. But I will be a little aggressive in saving this meniscus because he is a 23-year-old. So can you see the amount of dust I am creating by doing the diamond rasp? It is very important. Do you have suture fix? Keep it ready. Shaver. Keep it ready. When I say yes, we'll plan to open. Just keep it ready. I think this we'll leave it a little loose because this is pulling on the portal here. Yeah. Thank you, Arnab. Yeah. So can you see this flap here? This is bad. This will not allow the meniscus to survive. Can you see this flap?
Yes,
Sir?
Yeah.
So I think that needs to go. If at all we want to try to save anything, I don't think this flap should be there. So I'll try to punch. Wide. This is a pretty bad one, but we'll see how best we can manage and save whatever is there. But it is all about proper balance between trying to save and trying not to be stupid. Thank you, Arun. Okay. Shaver next. Thank you, Arnab. So you can prepare the meniscus with this shaver. Can you see? It will not go and hurt other things. It will do what your diamond rasp is doing for you with the motor. Can you see there is a lot of uncovering of the tibial plateau here? You can see the rim.
Yeah.
And these are all conditions where it is okay to put in an anchor to save the tibial plateau. So
Y'all.
Saline, please. Thank you very much. So I think this posterior area I will use a Nova stitch. This looks good. I can compress these two well. Then I will try to get some reduction like this. I have to know where these things will go. So because I don't want it to become, this kind of, because there is meniscal loss here, there is some
buckling,
dog ear kind of an effect. So I will have to understand where this will have to fall for me to properly save it. So maybe probe, regular probe for me. Rajiv, make sure that I don't get simple cases where my boss says. Okay, so I think something like this will help. I will want this to stay there, correct?
Yes.
Mhm.
Correct? If we can achieve this, I think I'll be happy. So what I'll first do is I'll try to tag something with this into that. Can we do that? Needle again. I'll open up a little more. No, I'll do pie crusting little more.
Okay.
Okay. Yeah. Yeah. I think this is fine. Okay, can you show me like that? Okay, now I'm going to bring in meniscal stitcher here, single cannula. Pulse. I'll first put a central stitch for reduction with an inside out, and then we will plan the other thing. Give me the needle.
That sounds very fair.
Camera, can you show me here? This is the meniscal stitcher set, which is the inside out way of correcting this. This is the single cannula, my favorite. I'm going to bend this. Yeah, ultrabeats. Hey, faster. Push பண்ணிக்கலாமா வருது take a needle holder, take a big needle holder and push it. Okay, pull it out from this end. Use the thimble to push it. Okay, இதுக்குள்ள போட்டுக்கொண்டு. Okay, so what I'm going to do now quickly is I'm going to switch the portal. Okay, and so you will have to take a big needle holder. The needle will exit here, you have to pull it out. Take a big needle holder. So I'm bringing this one here. The plan will be to reduce this with the reduction suture, and then we can go ahead and try and repair everything else. Okay, this will not be anatomical. Yeah, go on. But given his age, we have to try and give some kind of support. Go. Keep pushing. Yes, good. Pull it out. Same direction, pull it out. Just pull it out, all the way out. Keep, yeah. Give it back to him. Okay, pull this. Keep a mosquito on that, sir. Keep it short. Yeah. No, first push this in, then you can load. Otherwise, the height will not be there to do. Okay? Yes, that is the trick. Okay, so now what I'm going to do is I'm going to try to, yeah, go. Push. Thimble, use the thimble. Yeah. Okay, pull this. Now, yeah, give the needle back to them. Take a mosquito. One second, keep it equal. And yeah, looks decent. Okay,
Not bad.
be careful with that. This is my first stitch. Now we'll take the Nova stitch. Diamond rasp meanwhile for me. Open the Nova stitch, I will assemble it. Meanwhile, diamond rasp for me, please. Now I'll quickly go back to the original portal, okay, of seeing from here. I have fantastic assistants today to make my work look simple and easy, but it is them that, okay. Okay, roughening. Give me the needle again. We'll do some trephinations. Needle. No, long needle. Yeah. Okay, puncture. puncture, 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 yes. So, Harnam, can you hold this? I'll show them the Nova stitch and I'll come back. So this is a Nova stitch again. Yeah, put it here. This is loaded, huh? Okay. So this is the Nova Stitch Pro. So how I use it is, which one? Sorry, can you see this?
Requesting the cameraman to show the Nova Stitch Pro. Yes.
Yeah. So I will, this has got a flexible upper jaw which will take the shape of the condyle. Okay, and that will move with the orange. And once I go in, I will deploy the lower jaw with this gray. It will come in, and there is a cartridge which is loaded. You can reuse this. The next bite I will show you how to load this cartridge, and then I will squeeze all three together to fire. If you see a mark here, black mark, where S and N is written, that is where your needle will pierce out. So with this understanding, we'll go in. I don't use cannulas, but you can use cannulas. Nothing wrong in using cannulas here. Okay, I'm gently going in, and now I will deploy the lower jaw. Can you see that? Hold. Turn the light source like that. Okay. Now show me like this. Now I'm going to take my first bite. Okay. The needle exited here. Okay. Can you see that? And then I will make my second bite. Open a little more, open a little more. I'm not happy, don't be in a hurry, yeah. I'm going to make my second bite there. Okay, that is the exit of the needle. Okay, now if you see what happens, I've taken a mattress like this, hold this. If it is root, I can just pull these two into that and that will make a lasso, but this is not a root. So I'm just opening this, taking out all these. Okay, needles, and I will pull both the free ends. Sorry, mosquitoes for me to pull that. Suture retriever, there is a lasso loop there which was unintentionally formed. I'm just going to remove that lasso loop, not pusher. So one there and one here, correct? Actually, for this meniscus, even if the loop is formed, nothing wrong because the meniscal quality is not great. Grasper, grasper. Suture retriever again. Cannot push her. Yeah, no stitch. So I'm just going to open her now. Open. Understand where I have to put this knot. Okay. The loop doesn't matter. I'm happy, in fact, with the loop. Okay, not. So, as you see, the morphology of the meniscus has changed. So, I'm now going to try and understand if I should place the meniscus there. So, which means I will be using this one as the loop. Can you see that? Yeah. Mosquito. Get one more Nova stitch and yeah. Okay, stay there. I think that is fine, okay? Now this is not very anatomical because the morphology is changed, but as we decided, we have to try and save this for whatever.
We all can see that you're trying to do a very good job, Dr. Bhupesh.
Yeah, the meniscus is unique, the way it is torn.
Yeah. So I will cut that. Give me one fast fix now. Yeah, 360. I am going to go and do one more knot here, but before that I will try to maybe put a needle for me, quickly, that grey needle, fast. Hey. In the needle. Akupass ka? Akupass right. Give me Akupass right. Okay, now quickly what we'll do, give me the needle. I'm going to put an anchor here to kind of push all this inside. 1.7 suture fix, anchor. 1.7 suture fix, anchor. So this is called a mid-medial portal. I usually use this for root tears, but this is also like a root. Because there is so much of uncovering of the tibial plateau. We can leave it down. Thank you. Yeah, okay, maybe this is perfect. So if you can see, there is so much uncovering of the tibial plateau here. So, and that will also help us kind of stabilize this. 11 blade. Single up, put single. 11 blade. No, 11. Do you have 11? Suture fix. You come and deploy it, huh? Okay, give me 15. It's okay. Give me 15. Give me whatever is there. Give me some kind of blade. Quickly. Yes. So I'm just making a portal from here. Ideally 11 blade. Searching for it. Guys, can you help me with the 11 blade?
11 blade, sir.
You got it? Give me. Get the 1.7 drill ready, Arun. Arun, don't look at the blade. You get the 1.7 drill ready. Okay, see the 11 blade is so easy. Okay. Give me the sleeve, 1.7 sleeve. Yeah, thank you. Yes, anchor. Come, drill.
Anchor.
Bone field.
Yes, sir.
Go. Wait. Come out. Yeah, go. Slowly. What happened? Yeah, he's got fantastic bone. Yeah, go. Yeah, out. Slowly, don't be in a hurry. Yeah. Pallet gently, same angle. Don't turn, don't twist. Double load it up.
Single load.
Go.
For 5 minutes, we'll pause it, we'll record it,
Yes.
we'll run it later on. We'll start the again.
Can you hold it? Yeah, do it.
I'm holding it.
Yeah, deploy.
Dr. Bhupesh,
Yeah.
sorry to interrupt, but we are little running short on our academic meeting.
So
is
what
also-
we'll do is, I will quickly finish this repair and then I'll show you the final, this one.
Yes.
So what I've done is essentially put an anchor here and these will repair this bite. Like this.
Quickly, let's see this step. And you continue with the
Yeah.
surgery.
And then you can go on with the lectures. I'll
lecture
come
and then
back
yes.
and show the final
The final
product.
result.
Okay. So that's how I'm going to take one bite over, one bite under, and then tie that down. No, blue. So this is like doing a Bankart repair. Just that, and this, and out. I'm going to make a loop in this. Put this into that. Hold. And yeah. Pull that. Yeah. Gently. Don't be in a hurry. Yeah. Remove that now. Yeah. Okay, so one done. Mosquito for this. Again, knife. Yeah. Relax. In fact, I will just leave it there. Blue.
Dr. Bhupesh, you have done a fantastic job. It was a very difficult meniscal surgery.
Yeah.
So,
So what I'm going to do this is just tie this down into this. Can you see this, sir?
yeah. Any question from the audience to Dr. Bhupesh till now? Because we are going to end it now.
Yeah. So I'm going to tie this down, and that will kind of control this end of the meniscus. Can you see that? How this is reducing as I tie it down? Hold this one.
We require the intra-articular.
Hold this. Hold this one. Hold this one. Hold, gently, don't pull. So I have stabilized with this tie. I will be stabilizing this. The center one is stabilized, and the posterior one is kind of pushed back together to prevent a dog ear. Now some more bites into this, some more fast fix into this, some more fast fix into this, and I think this bucket will kind of save the meniscus. And we will show you the final repair after this is done. So one here, two here, three here. These three things will be my cornerstone knots, and then we will fill the centers with inside outs or all insides. And then I will complete my ACL with a tibial
That
channel.
looks like an amazing plan.
Okay.
Good luck with the
I'll
rest
come
of the
back in
surgery, Dr. Bhupesh.
half an hour's time.
We will join in soon. Yes.
Thank you, thank you. Cut. Sound off.
Hello. Thank you to Dr. Bhupesh Karthik and both the moderators. So we are done with the live session. So we'll be starting our next session on meniscus. To chair this session, I would like to invite Dr. Subarna Misra and Dr. Shanendu Samanta sir to chair this session. Thank you.
The breakfast is served outside, so kindly, if anyone wants to have their breakfast, they can have their breakfast outside.
So good morning everybody. We had excellent live demonstration of a repair of a very, very complex tear. Probably I won't be able to do this sort of repairs, a dream of repair. So now we are going to the next session where we'll be discussing about something about the meniscus. So first I will call my dear friend Amit for his talk. ACL primary repair.
My talk is not on meniscus, but if you have your ACL correct, your probably meniscus will remain untorn. So what I'm going to talk today is about a concept which is nowadays very much popular, is the remnant preservation and the repair. So I have nothing to disclose. We all know that to replace a tissue, the same type of tissues are the best. So skin is replaced by skin, muscle by muscle, and the nerve is replaced by nerve. We all know as an orthopedic surgeon, a bone is perfectly replaced by a bone. But when it comes to the ligament, anterior cruciate ligament, it is replaced by tendon. Say it is BPTB, hamstring, or quadriceps. Why this disparity to the ACL is because ligament as a donor is not available. That is probably the reason why ligaments are replaced by the tendon. So the concept is, if we cannot replace, why not to preserve? This was the whole philosophy behind the remnant preservation. And the extreme of remnant preservation is probably ACL repair, in which you preserve whole of the ACL. There are several advantages. I'll not go into all this detail, but vascularity, if you see, this is one case in which we have preserved the remnant. Look at the vascularity. And the vascularity is most important because if you put your tendon inside the knee, it has to undergo a ligamentization process. And for that ligamentization process, the vascularity is very, very important. There are other several advantages, like it preserves the bundle anatomy and so many others. I'll not go into detail of that. So this is a paper which was published in 2016 in AP Smart, and they have seen about 2,000 cases, and they say that remnant is present in all the cases. The degree of remnant present into the torn ACL vary. And that is how all these classification systems have come up. There are several classifications of remnant has been described in literature. Probably Sherman is the one which we use, but this is just an anatomical classification. It doesn't give us an idea what to deal or how to deal with all these remnants. Probably Grigory Defelis is the one who came up with this extensive classification in which he has taken into consideration the location of the tear, where it is in the ACL, and tissue quality, which is basically an arthroscopic guidance. And based upon these location of the tear and the tissue quality, he has given some recommendation for the treatment, either to do a repair or to reconstruction or whatever. But it has lots of limitation in our context. Basically, diagnosing ACL tear is very difficult in our context, and diagnosing where exactly 75% remnant preserved, 90% preserved in MRI, it's very, very difficult to diagnose. So this is not exactly, for my piece of cake. We all know that the final decision is based upon the arthroscopic decision or looking at the quality of the tissue. So we did a retrospective study of about 462 cases. All the cases which underwent ACL within 4 weeks of injury were enrolled in this study. And what we found probably a simpler classification of ACL remnant, which is divided into 3 types. Type 1 is a tear from the femoral attachment. Type 2 is the mid-substance tear, and type 3 is the tibial attachment tear. To further divide into this, the type 1 is further divided into 1A, 1B, and B stands for soft tissue. So if it is a bony avulsion, that is B. If it is a soft tissue avulsion, probably this is a type 1A, and only this group of patients are better for repair or repair and augmentation. Type 2 is a mid-substance tear, and the type 3 is the distal tear, and then one of the very rare case is type 3A, when you have a soft tissue avulsion from the tibial attachment. But we know that tibial tuberosity avulsion is very common, which comes in the group of type 3B. So this is the treatment algorithm that has been recommended. Is if it is type 1A, the repair alone will not suffice. Probably you have to do an augmentation. So that is what Defelis also recommended, that in type 1A, when there is a soft tissue avulsion only, repair with augmentation recommended. It is the type Bs in which there is a bone piece at the end, probably are a good candidate for repair alone without any augmentation. So either it is 2A or it is 3B, they are recommended for repair alone. But again, to emphasize that this classification is under review for a journal for publication, and this is important to understand. The final decision probably lies in the arthroscopic understanding of the tissue quality or the ACL quality, how much you are going to preserve or when you are going to repair. So we have published our technique of remnant tensioning. This is basically a ACL repair with augmentation of the autograft in arthroscopy. I'll not go into this one because my talk will cover only the repair part. So I'll talk about a 40-year-old gentleman. He is not that much active, an office worker. His demand was low. And then when he came to us with the MRI, you could see that most of the remnant was preserved in this patient. He has anterior drawer test positive. And this is what is important to see, look at the vascularity of the ACL that is preserved. It was avulsed right from its attachment, and it has some bony spicules. So the first part is to prepare the bed where your ACL is going to sit. Second step is to put some suture. There are luggage tag suture, whatever suture you can apply, it has to hold your remnant very strongly. Then preparation of the condylar wall is very important. Multiple microfracture definitely enhances. And there are various ways by which you can fix. I use a push lock in this particular case. So pass the sutures through the push lock and fix it into the femoral condyle, and you'll see that the ACL whole ACL remnant has been preserved. It is tight enough. Although literature say that when you repair your ACL, the rehabilitation should be slow, but what we have seen is these people, they recover very fast. They tend to regain their range of motion, they have less pain, and they tend to go very fast in their rehab. We have to be very careful to pull them back so that the rehab is right on track. So to conclude my presentation, repair should be taken as extreme of remnant preservation. So repair will have all the quality of remnant preservation, plus there is not much harm you are going to do into the bony side. You're just putting an anchor. So there will be a lot of possibility. Even if it fails, there is easy to revise this rather than a failed ACL reconstruction. Remnant put biology to your construct, and when you repair, it's all biological. There are mixed results coming out of both the repair and preservation. Probably we have to be more cautious in identifying and selecting your case, which will go for a repair, which will go for remnant preservation. And probably I presume that improvement in arthroscopy technique and instrument. Thank you. So improvement in arthroscopy technique and instrumentation that we are seeing day by day, every week new thing is coming up. Probably it will further enhance the technique of repair and further enhance the outcome. Thank you very much.
Thank you, Dr. Joshi, for your excellent presentation. Now I will request Dr. Amrish Jha, a friend, to speak on primary repair of PCL.
Good morning, chairpersons. Good morning, friends. So, my talk is a little offbeat. It's primary repair of PCL. So it's an old concept. So it's old wine in the new bottle. The concept was conceived in the 80s and 90s, but later on it had to be aborted because of poor results. So again, we have conceived, and we are trying to establish this. Let's hope for a future of this repair. Isolated PCL tears are rare. In almost all cases, they are associated with PLC injury or meniscus injury or chondral injury or mixed injuries. So without any controversies, grade 1 and grade 2 tears must be treated conservatively. However, we are going towards grade 2 to be for operative. But mind it, grade 2 should be treated conservatively. And definitely grade 3 should be taken for surgery. Why there is resurgence in PCL repair nowadays? Because we have better operative techniques, we have better augmentation scope nowadays, and because of modern braces, PCL braces, which prevent sagging in the post-operative period. So the primary repair concept is not new, it's old one. And historically, in 80s and 90s, the repair was done by open means. At that time, there was no scope of arthroscopic repair. Some studies have shown excellent result in up to 70 to 80% of cases, but again it was limited by grade 1 to grade 2 posterior rod. So there are lot many papers, but the problem is these papers are in the 80s or 90s. After 95, no paper has come up with the repair, and recently again we are working on it. So coming to the role of biologics in PCL management, as discussed yesterday, there is some role of PRP in conservatively treated grade 2 tear of PCL, and where it should be infiltrated in intrasubstance through USG guidance. So remnant preserving PCLR like ACL, as nicely described by Dr. Joshi, there is a scope. In fact, the PCL remnant preservation is more important than ACL because it's a high vascularity and it's a robust ligament. So whenever possible, it should be preserved. And there are papers who supports the proprioceptive mechanism better when the remnants are preserved. So coming to the planning, as already discussed, MRI just helps us to know the location of the tear, but the final decision should be taken intraoperatively. Ligament remnants of sufficient tissue quality should be there to go for the repair. If the ligament tissue quality is not good, we should not attempt for repair, like in meniscus cases. Otherwise, it may fail, it will fail, and better to go to reconstruction directly. No age is a bar for repair, so we can attempt it in any case. And it has been shown that in up to 45 to 50% of cases, the PCL is tear from the proximal end, or it is a peel-off lesion. So we should be vigilant about that, and we should try to repair whenever possible. So currently the proposals are femoral peel-off lesions should be repaired primarily. Tibial bony avulsion, as usual, we all know, bony fixation. Mid-substantia should be reconstructed. And the debatable issue is, in PCL tear in children with open physis, what should we do? Should we repair it or should we reconstruct it? It's still in the process of debate because of availability of this extraphyseal techniques. Some few prefer it to reconstruct primarily. So coming to the case, it's a young adult. X-ray looks pretty okay, but there is tibial plateau fracture, and the MRI shows peel-off lesion, femoral peel-off of PCL. Otherwise, it's unremarkable. There is tear of posterior horn of medial meniscus as well. So what are the options? We can go with repair or reconstruction. If repair, we can do it open or arthroscopic because this was associated with tibial plateau fracture. So we could have done it by open means repair as well as fracture fixation. And regarding techniques, we have implantless fixation over the bony cortex, suture shuttle or endo button or disc, whatever, and knotless anchor, which are the latest ones. So intraoperative. So first you have to release the adhesions between the ACL and PCL. You have to delineate the footprint of PCL because it's a large footprint. Initially, a traction suture must be applied to know the release and know how it can be taken to the femoral footprint, and then the suture through the robust suture through the good quality tissue. It depends, you can take 2, 3 or even 4 sutures. But before proceeding for any tunnel preparation or any preparation to the femoral side, you must release it beforehand, and you must assess whether this is repairable or not without much traction. Sorry for interruption. So in this case, it was done by outside in technique. 4 tunnels were taken. It was drilled by with 4.5 cc drill bit, and then through suture settling technique, this was tied over the bony cortex. The second case is a 36 years male who sustained RTA with tibial avulsion এটা আসছে না, পিকচার আসছে না। এই পিকচারগুলো আসছে না কেন? মাউসটা আটকে গেছে। So, sorry, there is some technical problem. So this was high velocity injury having ACL tibial avulsion fracture, PCL femoral tear, and there was undisplaced avulsion of the lateral collateral ligament along with cartilage injury. So there are literatures which support that if the patient is having multi-ligament injury and if we are planning not to go for cruciate reconstruction in stage 1 surgery, then you can just repair the ligament and hope for the union or healing of the ligament, and if it heals then okay, otherwise we can go for definitive reconstruction later on. So this was the intra picture. So this is the paper supporting this. In stage 2, if it's not, it's remain unhealed, then we can go for reconstruction. So same was done with this case, and it's still in follow-up. So probably I will be able to present in the next meeting. So the summary is, it's a new concept. Basically, it's a renewal of the old concept. Proper case selection is important. And more work and literatures are needed to prove it anymore. Surgical techniques to be learned properly, and rehab plays a vital role, as most of these cases are associated with other injuries, and there are high chances of stiffness and other functional disability. Thank you.
Thank you, Dr. Amrish. This is a difficult talk as such, so you presented it well. So I think Bhupesh is still in OT. So, hello. Are you going to show the live for some time?
Yeah, live. Can you see here? Sir, hello.
Yes.
So we have finished the repair. We have put one more fast fix here, Nova stitch here, and then outside in, 2 more stitches here, 2 more stitches here, 1 anchor, and then I'm doing an outside in here. I've put in 2 needles, 1 needle with a thread, the other with a snare. Now I'm removing the one with the needle. It is already caught in the snare. And now I'm removing the snare. This is an outside in technique, mosquito for this. And that will kind of take care of the anterior-most part of the tear. Hold gently tight. So this is our repair finally. What looked like we cannot save, we have saved with outside in. We have done 4 techniques, 5 techniques here. This is outside in. This is the suture anchor technique. This is all inside fast fix. This is inside out meniscus, fast fix flex, 1 more fast fix flex, and a Nova stitch here. So I know this sounds a lot, but for a 23-year-old, I think it is important that we do this and give him a stable rim so that he will not go into OA. Any doubts, sir?
No, excellent. I think it was more or less irreparable, but still it was managed so nicely by...
With some biology also, not that we didn't prepare it.
Okay.
Samantha sir, right? Samantha,
Yes. Already the biology is there because you are drilling the tunnels.
Samantha sir, how are you?
Yeah, doing fine. This is an excellent job. From the morning itself, I am seeing there.
Thank you, sir.
Thank you. Excellent job. I think you need
excellent job it has been done. Yeah.
Applaud from the whole auditorium. Thank you.
It was really a difficult meniscal situation.
Sound off.
Okay, Bhupesh, we are signing off. Hello, Bhupesh. So now I will request.
Thank you, sir. Thank you.
Okay, thank you.
Thank you, sir.
Thank you, Bhupesh. So we will be waiting for you for your talk here in this session once you come here. So now I will request my dear friend Dr. Gaurav Gupta for his talk on anterior root repair. Are they relevant?
Good morning, respected chairpersons and dignitaries of the dais, as well as my friends, seniors, colleagues. It's a great pleasure to be back here. So we'll be talking about anterior meniscal root repairs, whether they are relevant, and as luck would have it, this is not a very common sort of pathology. So we'll go through what we know already about anterior root tears. We'll go through what we don't know, and then some of my personal experience with anterior root tear. So root tears would be an avulsion of the attachment or a radial tear within 1 centimeter. So what we are looking at here is the lateral side, the lara, and the medial side, the mara. Those are the 2 points where the 2 menisci attach onto the tibia. Now, interesting was I found this paper about research on root tears. Apparently, Rob Laprade has published the most, and then there are some Japanese groups right behind. But still, we don't know a lot about these tears. So what we know, on the medial side, the footprint is 110 mm square. It's weakened or disrupted during nailing, leading to residual pain in some patients. This was published by Rob Laprade's group in our own journal, the IS journal, earlier this year. And the mara, the median footprint is 140, so it's slightly bigger than the medial side. And the fibers really burrow beneath the ACL. And what they've said is that injury during tunnel making in an ACLR would be pretty much unavoidable, injury to some fibers, but its significance is not clear. That's all that they've said. Now we also know, as a general thing, that root tears cause the meniscus to extrude, they increase joint contact pressure, and eventually lead to joint space narrowing and progressive arthritic changes. Treatment recommendations. So I found this good paper. It's really nice. 2019 KASSCON consensus group published in 2020 in their journal, KASSCON. The question asked was, should posterolateral root tears be repaired? The answer is they should be repaired because repair decreases meniscus extrusion and the risk of OA. Should posteromedial root tears be repaired? Recommended because it results in better clinical outcome than conservative treatment and partial meniscectomy, and may also reduce risk of progression of OA. Now this entire paper is in the form of question answers, the consensus statement, but there is no word about optimal treatment for anterior root tears. And this is as late as 2020. Okay. I found this paper from Nicola Mafulli's group. They've spoken about 12 patients, but look at what they've written, repair of anterior horn. So we don't really know how much of this was pure root and how much was root plus anterior horn, or was it that they were looking at radial tears within 1 centimeter of the root attachment, and that is why they called them. That's not very clear from this paper. But anyways, they've got a follow-up of a year, and 8 of the 9 patients returned to sport at the same level, and 1 patient returned at a lower level. That's all that we found in terms of published data. So what we don't know with certainty today is what should be the current treatment recommendation for anterior root tears, because there's hardly any literature out there. Now a bit of personal experience. So this young 19-year-old professional marathon runner came to me with the medial side looking like this, and there's a body tear up there. The body tear is shown in the next picture. So I looked at it, I thought, well, this should be repaired. And then I went in, shuttle sutures, tied knots, and then used my ACL jig to get a tunnel up there. And then for the body repair, I rasped it a bit and, put in some all suture devices. It looked nice on the final picture. And then as we followed up this patient, at 1 year, he had very good function. Absolutely brilliant, and he was back to his marathon running as well. He was 20 by that time. I was curious, so I got, the MR scans at 1 year, and all looked good. So this is where my tunnel must have been. This is my, the post with which I fixed, and you can see some of probably the threads or the tunnel, whatever coming down, and it all looked very nicely healed. So to summarize, root tears disrupt meniscal functioning, and that's why they are dangerous. And when meniscus function is disrupted, then we know that contact pressures shift to lesser areas. We know that the knee degrades, the joint space narrows, and that is the beginning of the end of the knee. We need to look up MRI scans very carefully to pick these root tears, be it the anterior ones or the posterior ones. There's plenty of literature on posterior root tears. We always repair them. That's the recommendation. All of us, I'm sure, are doing those regularly. But there's very scanty literature, anterior root tears. Still, it makes sense to repair them. Thank you very much.
Thank you, Gautam, for your excellent talk on this anterior root tears. Is it open for discussion? Or? Okay. So we will request Dr. Sandeep Bilaris for his speech on biologics on meniscus repair.
Yes, I think Dr. Sandeep will be coming on Zoom. Yeah, Sandeep, good morning.
So, shall I start?
Yeah, start.
Good morning, respected chairperson, my dear friends and colleagues. I would like to apologize for not attending this meeting in person, and I'm thankful to Dr. Biplab and Dr. Rajiv and Team KASSCON for inviting me. So, I am asked to speak on biologics in meniscus repair. I have nothing to disclose.
Sandeep, your voice is cracking. Somehow you just check how the voice can be bit better, but it is more or less very difficult to understand.
Yes, sir, now?
Yeah, now it's okay. Yeah.
Okay. Regarding meniscus, biologics with meniscus repair. So first and foremost is to know the blood supply of the meniscus. We all are aware that meniscus is very much vascular in peripherent, and it is almost avascular as we move towards the central part. So all these biologic thing works when something is done in this vascular or in this gray zone, red white zone, so that it can help in healing of the meniscus, and meniscus can be saved. In earlier era, a lot of the patients were treated with partial meniscectomy, but now as we are moving towards saving the meniscus, as we saw very well case done by Dr. Bhupesh, so biologics has been playing a very crucial role for saving this meniscus. So there are various methods mentioned in the literature. The first principle is based on creating a vascular channel. That means with the help of either meniscus needling or trepanation, or even with the core, removal of the core of the meniscus. Studies have shown that it helps in healing of the meniscus. It increases the blood supply. So this needling can be done either antegrade way or by the retrograde way. So this way it can help in bringing the good blood supply, and literature have shown that it increases the healing. Then next to this is the rasping. So whenever we are planning to repair any meniscus, there is a good chance when you do the rasping, it increases the blood supply, and then it helps in the healing of the meniscus. And it has shown that the rasping is done under surface or even on the superior surface of the meniscus with the help of this diamond-shaped rasp. Sometimes, if there is only one surface here, it is like a grade 2 reaching up to the articular surface. So, and tear is stable, it can be very well rasped and left as it is. And rasping is a low-cost method. There are no negative side effects of this method, and it has shown that it elevates the lots of growth factors. Another thing mentioned in the literature, there is no literature available on this. That's the synovial flap. So a pre-regulated or vascularized synovial flap is applied over the meniscal tear and then it is sutured. It is generally an open surgery. But there is no literature or patient data available about this particular technique. Then another very good thing is opening of the medullary cavity in the notch. So during either ACL reconstruction or any of the procedures in the knee, if you make a multiple microfractures with microfracture all, studies have shown that it releases the healing potential, releases the growth factor progenitor cells, and that helps in the healing of the meniscus tissue. So it has shown that this hastens the meniscus healing, just microfracture, usually during the ACL or PCL surgery. So this opening leads to influx of progenitor cells into the knee, but it does need longer rehabilitation time, and patients, they may develop prolonged hemarthrosis. But it is shown that it is a safe, quick, and cheap technique. Then there are various blood products. We all use it very routinely. So this application of blood products like either fibrin clots or platelet-rich plasma has changed the game of these biologics in meniscal healing. So this helps to improve the proliferation, and these blood products stimulate the fibrochondrocytes. And these fibrochondrocytes migrate from the wound edges to the meniscus and to the clot lichen. And it has shown that because of this chemotactic and metagenic activity, it helps in scaffolding like a scaffold and helps in allowing to ingrow the cells. So this fibrin clot, usually it is prepared outside, then it is delivered into the meniscus defect and it is sutured back. So this is biological and blood-derived product, either of platelet or fibrin. It has got a high amount of growth factor, cytokines, and chemotactic factors. It has potential to stimulate the cell proliferation and it increases the local cell activity. And it also helps in supporting a reparative response of the meniscus in the avascular portion of the meniscus. But fibrin clot also has some limitations, like it's a time-consuming technique. You need to handle the tissue very carefully. There is a lack of standardized procedures developed, and there is also a risk of infection if you are using exogenous fibrin clot, because you need to draw the blood from the patient and the fibrin clot needs to be prepared on table. Another good thing is platelet-rich plasma. So they both PRP and fibrin clot work on the same principle. So this PRP is a sticky gel which is delivered at the meniscal repair site. It is safe, low cost, and very simple preparation, and it helps in obtaining good growth factors. So after these blood products, the next thing is various growth factors. Literature has shown some studies about these growth factors. It is still evolving and needs further studies. It has shown that they play an important role in tissue healing, and most common being the EGF beta 1, which is the most potent anabolic growth factor. It has shown that it helps in the meniscus healing. So whenever meniscus healing is in progress, studies have shown that there is a lot of formation of these growth factors. Now there is certain application of certain cells like mesenchymal stem cells have been used in saving the meniscus. So these cells, they act like a meniscus-like tissue, but they have abundant extracellular matrix. And these cells can differentiate into different, these mesenchymal stem cells can differentiate into various cells like osteoblasts, chondrocytes, etc. And they can be harvested from bone marrow, synovium, muscle, or adipose tissue of the patient. After this stem cells, next one is biologic modality. Studies have shown there is still, it is evolving, that these are the scaffolds which are implanted with various cell lines like the chondrocytes. It can be giving mechanical strength, stiffness, using its design. there are certain resorbable collagen meniscus implants also being marketed, so it is not much available here in India. So this particular, like from that analysis of joint, very recent, but they have clearly mentioned various techniques like mechanical stimulation, synovial flaps, fibrin clot augmentation, PRP augmentation, and mesenteric hemorrhage. So these are the only ones which are available recently. So when you think about the biologics, there are certain few pitfalls, like various techniques of augmentation available. There is a literature of different techniques, like it is very patchy literature, but not enough comparison between different techniques. These biological methods, they have not demonstrated any clear efficacy or superiority over the meniscus repair alone. It needs further more clinical trials, and then there is a chance that people may do unnecessary surgeries, and it may incur excessive cost to the patient. And sometimes these various national governing bodies, they interfere with the licensing of such methods. But future is also bright because many clinical studies are developing various superior methods. Clinical trials will be needed to find out safety and surgical feasibility of these methods. Then randomized control trial to evaluate the efficacy of these biologicals as compared to meniscus repair alone. Thank you very much for your attention.
Thank you, dear Sandeep, for an excellent talk on a difficult subject. You be there if there is some questions. If there is any question from the hall, so Sandeep, one question from my side. Are you using the fibrin clot in your clinical practice for your meniscal repairs?
Sir, I have done only 2 cases so far with the fibrin clot only. I do not have any experience with all other methods.
Okay, because I think there is a lot of literature now that fibrin clot is easily available. It is a good product for your meniscal to heal. It is not very difficult to prepare it. Okay, thank you, Sandeep, for joining for this meeting. Thank you again.
Thank you.
Okay. So now I will request another one dear friend, Ayappan, for his talk on ramp lesion.
Good morning, sir. Respected teachers, senior colleagues and friends. I'll be speaking on the ramp lesion. Before I start off, I'd like to really thank Rajiv Raman sir, Swarnendra sir, and all the senior faculty and members of Kolkata Arthroscopic Club. So I'll be speaking on the ramp. So the beauty of the ramp is that it's like the first line I put up. It saw you, but you didn't see it. So, it's always like there are a high chance of you missing it out. So meniscal ramp lesions are hidden lesions in the posteromedial blind spot area. When you look at the incidence of, along with the ACL, what are the incidence of meniscal tears? Like up to 61%. And if you look at ramp lesions, the incidence could be from 9 to 17%, which is actually a pretty big number. And coming to the definition of the ramp lesions, is there any consensus in the definition? No, because there are varied definitions in literature. When you look at Strobel, he described in 1988, he described this posterior horn medial meniscus tears, and it looked like a ramp when he visualized from that area. That's why he called it as a ramp lesion. Then, is there a particular definition on the base of the length? So this particular paper, AJSM paper, showed that a tear of up to 2.5 centimeters in the posterior horn area could be a ramp lesion. Then again it was modified because all the other papers started talking about synovial and capsular separation, but nobody talked about the meniscotibial separation. So here Peltier said that meniscotibial attachment can also be separated, and you can also have vertical tears. So that also is included in the purview of ramp lesion. So coming to biomechanics, we know that the meniscus is very important for the contact stresses. The meniscus not there means the contact stress increases. And the most important takeaway from biomechanics would be that, so when the ACL is gone, then the meniscus, especially the posterior horn, the middle meniscus, acts like a check ring and a doorstopper. So if the ACL is gone, then there is more play, anterior translation, and this should be prevented by a intact meniscus. If the meniscus is not intact, you have more of translation, and then you can have tears. So integrity of the posterior horn meniscus or the meniscus is very much critical even when you do an ACL reconstruction. Otherwise, you can have an ACL graft failure. So this video is pretty interesting. This actually tells us in an intact case ACL as well as the RAM. Next ACL is cut and then the ACL plus RAM cut. You can see the amount of translation. So if only the ACL is cut, the anterior translation we see is around 3 millimeter. But let us look at this literature, which shows us that when there is a ramp lesion or a meniscus tear, there is a significant more translation. So repairing the meniscus is the key. If you don't repair the meniscus or if you miss a ramp lesion, there are high chances of a ACL graft failure. So coming to the classification, so it is divided into 5 categories. The type 1 is a meniscocapsular. That is type 1 is this particular picture here, and that is meniscocapsular. Next is, it's a superior. It is a partial tear, but superior. Next is type 3 is a inferior, and type 4 would be a complete, and type 5 would be a double. Why is it important? It's because it is also it is important in the management and also in the visualization process. In a type 1, so the mobility on probing is very less. So even if you visualize through a modified Gilchrist port, and if you probe it and see, even with probing you might not get it. So you have to debride the synovium slightly to visualize it. In type 2, so again the mobility is low because it's a superior tear. The type 3 would be more mobile because it is an inferior tear, and type 4 and type 5 would have more mobility. Coming to the etiology, we have 2 types of ramp, that is an acute ramp and a chronic ramp lesion. In an acute ramp, it happens because of a valgus strain and in an internally rotated axial loaded knee. So what about a chronic? It is very, very interesting to look at literature about this chronic ramp lesions. So it is found that the highest incidence of this ramp starts off around 3 months from the date of an ACL injury. So if you have an ACL injury and if the meniscus is intact, so around 3 months you have higher incidence, and the incidence keep on going up to 2 years till you have ramp lesions. So then coming to risk factors, the most important risk factor would be ACL deficient knee, and along with others like a younger age and the time. The most important is an ACL injury. If you have an ACL injury, eventually you can have a ramp lesion. So why is the ramp important? Because it can fail, then ACL graft can fail. Number 2, it can lead to a second surgery for the meniscus and eventually OA changes. Coming to the diagnosis, the history, we should always a chronic ACL case, we should always look out, be on the watch for a ramp lesion. The clinical test, there's no specific provocative test, but there is a posteromedial, if there is posteromedial pain, which increases on flexion of the knee, then you could be having a ramp lesion. So what are the clinical tests you can do? Seaman one sign, that is tenderness shifting from anterior to posterior with increasing flexion. So when you flex from anterior to posterior, the pain increases, then it could be a ramp lesion. Then again a Faucher's sign, and your drawer and the pivot shift could be more. Coming to imaging, imaging is very deceptive. Why? Because the image is normally taken with the knee extended. In that particular position, the gap in the ramp reduces, and that is why we don't pick it up. The sensitivity is from 54 to 84%. So then, what are the signs you see? The only sign you can actually see is a small tear, that is a fluid line can be seen between in the meniscocapsular junction. Then a posteromedial bone bruise can be seen in 70%. So these are the indirect and the direct signs. And then coming to the arthroscopy is the gold standard. So if we can't visualize it properly, the chance of missing out a ramp is high because 40% go unnoticed only with an anterior port. So we need to visualize from the posterior ports as well. So how to see it? There are 2 ways. Okay, one is through the intercondylar approach, that is you go between the PCL and the condyle and then visualize it. The other is directly through the posteromedial port. So this is a video of the Gilchrist. So you basically make a space between the PCL and the meniscus, then you go in, you debride it, go in and pass the scope inside. just skip that. Can I go to the next slide? Sorry about that. I think the video as well as the PPT stuck. Sonnery and Cotet have described the same. What they have done is, okay, we visualize, go from the anterior through the modified Gilchrist port, then visualize, make a posterior medial port, visualize it, probe it, and so during this step, you pick up 40% of the lesion. That is when you are probing from the posterior medial port. The treatment options, one is conservative, next is meniscal repair, meniscectomy, trephination, or freshening. These are different options in front of us. So what is the best? There are different controversies or schools of thought. Number one is, like, when you have a ramp lesion, the question is, like, we should go in, when you have ramp lesion along with an ACL reconstruction, we should always do a ramp repair. So that is one school of thought. Next is, you need not do it, just do an ACL, but you don't have to do a ramp. So there is no clear consensus, but let's look at the papers. So now, points in favor of a repair are, number one, when compared to the lateral meniscus, the medial meniscus, kindly give me a moment more. So compared to the lateral meniscus, the medial meniscus, the healing rates are much lesser. So definitely that is one thing in favor of your repair. Then longer the tear, if it's a smaller tear, for example, if you look at literature, less than 1 centimeter ramp can be treated conservatively. But longer the tear, you should operate. These are the takeaways favoring a repair. There's a longer tear has to be repaired, and a medial meniscus, definitely a ramp should be repaired. Coming to conservative management, there is this particular paper talking about the conservative management. It's very interesting. Non-weight bearing mobilization for 8 weeks, followed by partial and then full weight bearing. These tears which are less than 1 centimeter responded very well to conservative management. Then, this is a systematic review which shows about, it talks about the repair. So this says that most of the surgeons do repair. They do definitely want repair, and the repair rates are pretty good. Then in repair itself, you either freshen it, that is debride it. So what is the rates of success, okay, when you actually repair it? So I mean freshen it. So if you just freshen it compared to an all inside repair, there is similar outcomes. So that means to say that if you debride it also, you can, especially in a type 1 and type 2, that is a smaller tear, simpler tear patterns, just debridement might be enough. You need not do an all inside. That's a takeaway. Then another technique was trephination. You make multiple needle punctures, and here it was done for less than 1.5 centimeter tear. So the outcomes are good. That means similar outcomes to an all inside. So it is. So the takeaway is smaller tear, simpler tear patterns. You need not do a suturing. We can do debridement or we can do trephination. The options we have are all inside repair, where we have all inside devices which will be discussed on later. And we also have lasso loops or the suture shuttling techniques of all inside repair. When you look at the success of all inside repair in ramp lesions, the failure rate is 11%. Compared to inside out is supposed to be better. So this is the all inside. This is also the all inside technique. But this is when you look at the inside out, it is much better compared to the all insides. Why? Because more numbers of sutures are passed. The only difficulty is that we have to protect the structures when we do it. So the inside out repair. So I'll not be going to the video. So this is my take on the ramp lesion. Thank you so much.
Thank you, Dr. Appan Nair, for your excellent presentation on ramp lesion and very good demonstration. Now, at last, we will call together. Now, we will request Swarnendu Samantu sir for his presentation on meniscal transplants.
Good morning, my dear friends, Dr. Subarno, and my senior colleagues, and my regards to Jiten sir for coming to Kolkata again. So I'll be talking on a subject which is very new in the fraternity of the arthroscopy people, and probably we are at the kindergarten state in meniscal transplant. I have been given the responsibility of covering many things of the meniscal transplantation. I will try my best for doing it. So I think the meniscal transplant, if you search the literature, probably it started in the one German paper came in 1988. They studied the meniscal transplant in the horses. So this was the animal study, and actually human transplantation was first reported in 1989. So it is not a very long back phenomena in the scopy people. And how the mat looks in the scopy eyes. Probably from 1990 onwards, there was promising findings in the that there is some peripheral healings. If you can fix the horns, no necrosis, no synovitis, and less immune response. So Orisom's thing is still there, is the meniscal extrusion. Even it is still there. It can degenerate, it can detach, it can shrink, or it can fragment. So basically it is a gray zone still in our mind. So I think if you want to read something, you have to read these two beautiful things. What it is a consensus thing with the International Meniscal Reconstruction Expert Forum, which is headed by none other than the Alan Gategood and the Lob Raprat, Tim Spranding. I think we have all met in different meetings in our country. So what are the recommendations of critical issues of the mat? We have to understand the classic indications and the contraindications, how we can harvest the allograft, then how to size it, because the sizing is a very critical issue in meniscal transplant. How to fix it, because the lateral meniscus and the medial meniscus transplantation is completely different, because in the medial side you use the bone plugs, on the lateral side you do the bridge technique, it is a bone block technique. So I think if you want to understand about some of the indications of the meniscal transplant, there are three, not more than that. One is it has to be the unicompartmental one. When we try to do the revision ACLs, because you know that if you don't do something on the medial side or the lateral side, the pivoting effect will be still there. The tibia and the femur will slide. And in the cartilage descent. So the indication list is not very long. One is the unicompartmental, second is the revision ACLR scenario, and second is the cartilage lesions. So primary indication, probably we have understood that these are the three, and if you can follow this, then you can succeed in doing your meniscal transplant. ACL deficiency, we all agree, and it is more true on the lateral side. Why? Because on the medial side, you have the concave tibia and convex femur, so it is stable. But on the lateral side, it is convex on convex, so it is very difficult to stabilize if the lateral meniscus is gone. So the lateral meniscus for revision ACLR, you can go for the transplant. So knee instability is probably one indication for doing your mat. Then the articular cartilage defect. If the meniscus is gone, if whatever you do for the cartilage, probably you do for the warts, mosaic plasty, your ACI and all this, if the meniscus is gone, it is not going to fit, it is going to fail. So ACR and the mat, probably they will go hand in hand, and that is the recommendation from the IMREF, that is the study group. So mat, you cannot do mat for your more than KL3. If it is more than KL3 or 4, you should not do the mat. Then you have to do something which is different, because this is not going to succeed. So meniscus deficiency is the classic indication for mat in this scenario. The case scenario, whether to do it prophylactically, I will tell you no. Young patient, post-traumatic meniscal loss, specifically on the lateral side, will benefit from the mat. Aim to prevent, what is the aim? Aim to prevent the future, or you can slow the process of your going for the cartilage degeneration. So high success rates and low complication rates making the MAT a suitable option in symptomatic knee. I will stress upon that the guy has to be symptomatic. Don't go for just a prophylactic technique. You don't go for the MAT for some who is not symptomatic. Is young, asymptomatic patient is a big no for going for the MAT. So if you see if you go with the study that what is the consensus group, 42% surgeons in this group, they generally don't perform MAT if the guy is symptomatic, if you see the chart. And also what are the prerequisites, as I told you, the allograft and the alignment, they are fresh frozen graft is the best one. Then how to preserve and procure the graft. I told you that there is certain technique. People started with the lyophilized graft, then the fresh frozen, the gamma irradiation. This is the technique, because you have to have the proper matching of your graft size. This is difficult. There are many techniques how you can measure the graft, whether you can do the X-ray, you can do the CT scan, you can do the MRI, you can go for the scaffold, you can go for the 3D printings, but still the polar technique of measuring with the X-ray stands good. Why? Because you can do the MRI for the patient, but you cannot do for the where you are procuring the graft. So in the lab, probably you are not having the MRI in the facility. So you have to match with the X-ray with the X-ray. So still the Pollard's technique holds good. They have to check. From the last 2 days we are talking about the alignments. You have to check the alignment. If the alignment is wrong, then your MAT is not going to succeed. So your alignment has to be 100% correct. So primarily, even if you do the HTOs, if you correct the axis, probably even if you don't need the meniscus transplant in our scenario. So 93% surgeon in this group would elect the realignment osteotomy if the meniscus axis is, if your mechanical axis is wrong. I think the Peter Vardong and the Rene Vardong, the best people throughout the world, they have the maximum study in the Belgium group. So if you want to read something, you have to read, there is a small group written by this Peter and Rene Vardong on the meniscal allograft technique. I will request you can go and have that book. Contraindications, I told you that if it is KL3, femoral tibial osteophyte, you should not go with the MAT. So other contraindications include the obesity, skeletal immaturity, instability, and the synovial disease and the PVL joint infection. So it is an evolving process. You have to understand the classic 3 indications of doing it, how to measure the allograft. It is still the X-ray is the best technique, not the CT and the MRI. And you have to match the graft. You have to basically do at least 100 of meniscal repairs, then only you go ahead, because the suturing the bone plugs, creating the tunnels, the bridge technique on the lateral side is not difficult, because putting the graft inside through the ports is a bit difficult, because sometimes it can twist. So you have to understand, still it is an evolving process. So I will request that if you read the book from the Rene and the Peter, probably you will be understanding many things about the nursery sort of thing in our country, because the one company is procuring the graft. I think in November we had a big meeting only on meniscal transplant by what my dear friend Raghubi is organized. That is an excellent meeting. I think Amit was there, live surgery was there, and the cost is, you will be astonished to know that for one meniscus in our country it is like 11 lakhs. So I think the money is also the factor for this thing, because we can do 11 TKRs with that. So thank you very much for your kind and patient hearing.
Thank you, Samantha sir. So we will take questions at the end of lectures.
I think Dr. Rahul is ready. Dr. Rahul is ready now? So he will be coming. Yeah. Welcome, Rahul.
Thank you. I'm just going to try and share screen. Can you see that?
Yeah. Make it full screen, yeah.
Can you see that now?
Yeah.
Great. Okay, so thank you for the invitation to speak at this meeting. My name is Rahul Bhattacharya. I'm a consultant knee and trauma surgeon in Glasgow, as well as honorary clinical senior lecturer at Imperial College London. So I'm going to talk about the technique today of meniscal allograft transplant, following on from that nice talk going through the indications. I've got no relevant financial disclosures to this talk. A little bit of acknowledgement, all my knowledge and skills in meniscal transplant comes from working with Mr. Tim Spaulding. I did a sports knee fellowship with him last year, and a lot of the talk that I'm going to describe here comes from working with him and his techniques. I'm not going to go over the indications. These were well described in the previous talk. There is exactly what was described, so I'm going to skip over this. And this is again the same paper that was mentioned by Al Getgood and Tim Spaulding, consensus meeting, talking about the indications of meniscal transplant. I'm going to predominantly focus today on the surgical technique. The graft sizing is important for us. Mostly the grafts come from companies, so we use Ortho Solutions, and these are usually sourced from the US, and they size it, and it's an MRI-based size. You can cross-check it with the Yoon modification of the Pollard technique that was again described in the previous talk. Sources for us in the UK here, multiple sources, again companies or the NHS allograft sources are used to get the graft. Now, focusing on the technique today, there's three real main techniques. One is the soft tissue, one is the bone plug modification of the soft tissue, and then the bone bridge. And the one I'm going to describe today is the soft tissue, because you can actually use that for any, either medial or lateral. I'm going to also talk to you about some evidence and some of my own research experience comparing the bone bridge and the soft tissue technique for lateral meniscal transplants later in the talk. So for the lateral side, you can do soft tissue or the bone bridge technique. The medial side is predominantly soft tissue or the bone plug modification of the soft tissue technique. I'm going into the soft tissue now. This is divided into 7 key phases or stages. First is graft preparation, then the arthroscopy phase, then preparing the meniscal bed, then drilling the root tunnels, then how do you pass the graft, how do you fix the graft, and how do you rehab the patient. So the first thing is the preparation of the graft. You can see here, this is an allograft, and now this is detached off the bone. And you see the word top written on the top surface. I always do that before I detach it off the bone, because if you detach it, sometimes you find it difficult to orientate yourself afterwards. So it's important to put the word before you detach it. And then the letter P here, this usually is at the level of the popliteal hiatus. And you can then use these different dots, and that guides your orientation of the graft once you've inserted it into the knee in case it's twisted or you can't see it properly. These are all different markers and checks that you can use once the graft is inside the knee. Once you've done that, then you have the main thing in the preparation is preparing the posterior and the anterior roots. Various ways of doing this. You can either whip stitch it with a suture tape like it's done here, and then you tie it over a button at the end, or some more modifications, things that we're doing now is to load the adjustable buttons or reducible loop buttons on both the anterior and the posterior root. Once you've done that, you can keep that graft in a vancomycin wrapped swab. Then you go on to your standard arthroscopy. Is your diagnostic arthroscopy with a standard anterolateral anteromedial portal. The key thing is to make the anteromedial portal in your working position. So for example, if you're doing a lateral meniscal transplant, you make it in the working position, because that's really key to have the ease of operation throughout the case. Otherwise, you'll be struggling through it. And it's important also to put something like a passport cannula through the anteromedial portal. This helps both in suture management and also preventing any soft tissue bridges. And that's, again, these are all tips and tricks to ensure the procedure goes smoothly. Next phase is to prepare the meniscal bed. Now, most of the cases that we do, it is deficient in the posterior root, in the posterior horn and the body of the meniscus. So the anterior horn often is still there. One efficient way of taking the anterior horn is just to take an 11 blade. You can see here, that's the 11 blade there, and it just takes out the anterior horn of the meniscus. And then you can just use a standard arthroscopic shaver, leave a 2mm peripheral rim, and you can use other things such as an awl or a needle to just stimulate bleeding from the rim that allows healing of the allograft onto the peripheral vascular capsule. Once you've done that, the next stage is drilling the root tunnels. The key thing here is to identify anatomically where the tunnels are, or where the roots are, both for the anterior and the posterior root. You can then use any jig, a standard ACL jig like we were seeing there before, or you can use specifically designed meniscal root jigs that help you take you to the correct location. First thing is to drill the wire and then take the jig off and check the position of the wire to ensure you're happy. And then you can over drill it with like a 4mm endo button reamer. If you're using retro cutters, flip cutters, you can use that and create a 6mm socket up to a 10mm depth for the graft for the root to go into it. And then you can pass your passing sutures, and this is key. So you pass your posterior passing suture first, bring it out through the anteromedial portal, and then you pass your anterior passing suture after you drilled, like you've shown here, the anterior root, and you pass the anterior passing sutures. After you've passed your posterior and anterior passing sutures, you locate where your middle passing suture would be with a white needle. This is usually just anterior to the level of the popliteus. So now you will have 3 passing sutures through the medial working portal. That is your posterior, middle, and anterior. Following this, you have to pass the graft. Now this is where the problems occur. You have to ensure that you can pass this smoothly without twisting it and losing orientation. The way I've been trained to do this is essentially take the posterior sutures first, so posterior root sutures from the graft, and pass it through the posterior passing suture. Then the middle traction suture from the graft through the middle passing suture, and then the anterior sutures pass through the anterior passing suture. Once the sutures are passed, your graft is still outside the knee because you can still control it. Then you gently orientate the graft and pass it through and use a probe to guide it into the knee by sequentially pulling the posterior first, then the middle, and then the anterior until the graft's inside the knee. Once it is inside the knee, you just snug the roots down. So don't fully tension it at this stage, just snug the anterior and the posterior roots down. Once you've done that and the graft is now nicely inside the knee, you can proceed to fixation. You mark the level of the popliteus and usually use 4 all inside type suture devices, whatever you're comfortable using, 2 up and 2 down, well spaced out sutures. And then anterior to the popliteus, you put inside out sutures, usually about 8 to 9 sutures, and mostly on the top surface, but about 2 or 3 at the bottom surface as well, just to balance the forces. And again, equidistant sutures so that it's nicely spaced out. And finally, once your graft is inside and you've fixed it inside, you tension the roots with either the adjustable buttons or tying over a button, whatever is your preferred technique. I find using the adjustable reducible buttons controls the tension better and probably gives a better fixation of the roots. And then you can finally tie over your inside out sutures over the capsule through a separate incision. This is how it looks at the end. So you can see this is a right knee lateral meniscus, and that's your transplanted graft at the end. So it's well positioned, well fixed, and looks good there. Okay, and here you can just see the inside out suture configuration a little bit better in terms of the spacing and how they've been placed. The bone bridge technique, I'm not going to go into detail today because of time constraints, but you can use this for the lateral side, particularly where you can see here that the graft comes attached to a bit of bone and you keep that bit of bone between the anterior and the posterior root. The importance here is that you're essentially depending on bone healing to reduce the rate of root failure and therefore meniscal extrusion. That's the theory. As I'll show you a couple of slides later from my own research, that doesn't always hold true. At least we haven't found any convincing evidence that it's any better than the soft tissue technique, particularly with the modern modifications of the soft tissue technique. So rehab, you go through 3 phases. First one is recovery from surgery. It lasts up to 6 weeks, and then strength and neuromuscular control from 6 weeks onwards. And then the last phase, which starts about 6 months, where it's the end stage rehab and return to appropriate activity. In phase 1, you can use a range of motion brace for 4 weeks, 0 to 90 degrees non-weight bearing, then convert to a functional offloaded brace at 4 weeks, begin partial weight bearing, and then progress to full weight bearing at approximately the 6-week stage. I'm going to go into my own research experience now. I reviewed Tim Spaulding's data looking at his bone bridge versus soft tissue technique for lateral meniscal transplant. And actually, we found no difference in either the failure rate, in any complication rates, or particularly the root failure. So there's no difference in root failure rates at all using the 2 techniques. And the patient-reported outcome measures were excellent for both techniques at 2 years post-surgery. And this is just under review now, soon to be published in the Kester Journal. I'm also involved in various other research within meniscal transplants, and now also looking at the 1-year comparison with the MRI scan, comparing the bone bridge and the soft tissue technique to see whether there is any radiological extrusion, and then over a longer period of time to see whether that makes a difference in the clinical outcomes. And now the Meteor trial is ongoing. This is a multi-center international trial where we are heavily involved in the UK in this. And this is going to provide us level 1 evidence comparing meniscal transplant to a standardized or a particular physiotherapy program. Our site is going to be one of the recruiting sites, and this will be very exciting to see the data that we get from this, and also to see whether in future you can predict chondroprotection. So, we were talking about only offering this to symptomatic patients, but maybe there may be a role for meniscal transplants for example, in a young 15, 16-year-old completely deficient meniscus cases, or even asymptomatic, to see whether that actually prevents the progression of arthritis. And that's an interesting area to look out for in the future. That's all I had to say. Thank you for your attention. I'll take any questions.
Thank you, Dr. Rahul, for an excellent talk. Any question from the hall? In the meantime, Rahul, one question that it is very nice to hear from you, that the bone bridge or the soft tissue both are giving excellent, probably the similar result. I think that will solve lot many doubts about how to pull the bridge tunnel and how to put the graft inside. So the question is that if we read from the textbook, like from the Bardong, Peter and Rene, there even whatever you do, there is some sort of meniscal extrusion at 1 or 2 year time. Like they say, it is like 70 years, though it has got no significance. What's your experience about the meniscal extrusion?
Yeah, so that's a very interesting point. Meniscal extrusion, the worry always was that meniscal extrusion happens in the soft tissue technique. The reason being that the roots don't heal. So roots don't heal properly, or they fail, and as a result, the meniscus extrudes. Now, in reality, it does happen, but it hasn't shown to affect any of the clinical outcomes. So if it doesn't affect clinical outcomes, it doesn't bother us, and that was the reason why we brought in the bone bridge technique. But in the paper that I just mentioned, that I've just written now, when our meniscal extrusion rates are no different between the two techniques. It's there, but it's no different. The MRI scans that we are now reviewing, we want to see at 1 year whether there's a difference between bone bridge and soft tissue. And then in the longer term, does it cause any difference in the clinical outcomes? Now, if it does happen, I believe that, with the modern soft tissue techniques where you're putting adjustable buttons through the roots, you can tension the roots a lot better. And if the roots heal and tension properly, then meniscal extrusion rates are lower. Now, there's another school of thought which comes from some groups, and I think Pablo Galvar from Barcelona published on this, where they use the capsulodesis technique. So they still put some middle sutures where they take the graft down and stick it to the capsule to again prevent extrusion. And we don't do that because I don't know whether that actually makes any difference. So, you can see the extrusion on the scan, but if it causes no problems for the patients and the clinical scores are the same, then probably don't need to do anything. But it is something that we're still reviewing. So that's the next project that we're doing. And also the Meteor study will probably give us some answers on that.
Yeah, thanks Rahul for making it extremely clear, because they say that it's like 70% meniscal extrusion, but clinically it doesn't make any sense. Most of the time, even if you see in the MRI that extrusion is there, it doesn't make any difference for the patient. Thank you, Rahul, for an excellent talk, and thanks for joining. Thank you again. Yes.
Thank you.
Just Rahul, wait for some time. There is a question from the podium. Yeah.
Good morning. This is Rajiv Kulkarni. I want to ask whether the alignment issues have been also addressed in meniscal transplant cases. What is your experience on that?
Yes, so very good question again. So you have to always, with every patient where you're going to do a meniscal transplant, check the alignment. So we do routine long leg alignment views for these patients. And if you've got any doubt that the alignment's off, you have to do an osteotomy first, because if the transplant fails if you don't do an osteotomy and correct the alignment first. You can do it staged or in the same procedure. No, we often do it in the same procedure. If you have the availability of the team, etc., doing it in the same procedure obviously helps the rehab for the patient. But you always have to correct alignment. You can't do it without doing that.
I think I stressed twice on my lecture that if your alignment is wrong, you should not do the meniscal transplant. The primary thing is the alignment. If your alignment is wrong, 100% your meniscal transplant will fail. Rahul, the last question, what's the cost for your meniscal transplant there, over here?
So the graft itself is £5,000, up to about £7,000, depends on from where you get it. So that's really the graft cost. Everything else, if we do it in the National Health Service, everything else is...
No, I'm just asking about only the graft cost, okay.
£5,000 to £7,000.
Okay. So you still follow the Pollard technique or any other method for CT or MRI?
It's a Yoon modification of the Pollard, but actually, to be honest, the grafts now are very well sized by particularly Ortho Solutions. When they provide us the graft, we see size mismatch is incredibly rare now. So we very rarely have to do anything else. They deal with that, the companies deal with that. And again, with the soft tissue, if you've got, in the rare occasion you've got size mismatch, you can deal with it with various modifications of your technique. In the bone bridge, if you've got a size mismatch, you're in real trouble. because you can't adjust it, because your bone slot guides where the remaining part of your bone bridge goes into, so you can't change the position, whereas a soft tissue, you can alter the position to deal with size mismatch, but it's very rare.
Thank you again. If there is any question left for any of the speakers in this session, or else we will close. Okay, thank you.
Thank you.
Thank you again.
Moving forward to our next session, Meniscus Repairs Armamentarium. I would like to call the chairperson, Dr. Shakti Prasad Das, to kindly join us on the stage. And Dr. Ananda Mandal as well to chair the session.
Good morning, everybody. Our next session is on meniscus repair armamentarium. May I call upon Dr. Naresh Gaud for his lecture, My Armamentarium from Arthrex.
Good morning all, respected chairperson, dear colleagues, myself Dr. G. Krishna Naresh Gaud from Manipal Hospital, Bangalore. Today I will be talking about all-inside meniscal device in my armamentarium. I will be taking you through the fiber stitch implant, which is a newer all-inside repair device. Quickly brushing through the anatomy, as everyone knows, meniscus is a crescent-shaped structure which is wedge-shaped, adds to the stability. It also acts as a shock absorber, has 3 parts. Main thing is it acts as a distribution for the load, and it helps for shock absorption. Second, it also acts as a secondary knee stabilizer. Main thing is it helps in stopping the knee or the extrusion, translation of the tibia, sorry. So if you are doing a meniscectomy, the stability of the meniscus will decrease, which will cause increased wear and increasing the joint stress, which will lead to arthritis. The meniscal blood supply, there is 3 zones, red, white and white zones. And the main motto is to save the meniscus. If the tear is in the red zone, you have to repair it. You can go for a partial meniscectomy if it is in the white zone as well. Different techniques are there. I will be talking about only on the all-inside repair. You will be doing on the posterior horn or the junction between the posterior horn and the bit body. Meniscal tears, mostly medial meniscal tear are more common than the lateral meniscal tear. It is in the older age populations, whereas lateral meniscal tear are also in common with the acute ACL tears and trauma tears. I want to stress here about the ramp lesions. It is often associated with the ACL tears. It is also called a hidden lesion, as my senior was talking before. Everyone has to make it a habit to put a posteromedial portal and to see the ramp lesions whenever you are doing a repair or meniscal repair in the posterior body. Different classifications are there, like apparatbic, vertical, horizontal tears. I will be talking now about the Arthrex device. This is a revolutionary all-inside suture device. The main advantage of this is it will replace all the plastic material and the PICC material. It is a all suture anchor. So the irritation which is causing because of the PICC or the plastic on the outer surface of the synovium will be decreased because of this implant. The fiber wire is a very thin, and the one more advantage is it will have 2 suture bridges which is forming a sliding knot which causes a robust fixation. On the outer surface, there will be a no knot which will decrease the joint cartilage damage and the stress frictions between the cartilage. So one single line ergonomic deployment is there, only one wheel. If you have to push it forward to deploy the first implant, pull it back, completely take it back and again push it into the second. You can use in different scenarios with different times. It will come in different adjustments as well. It will start from 10 mm to 18 mm with 2 mm increments. That, as I was telling earlier, double mattress fixation is the highest load to failure, which is a very good, and a fixation will be beautiful. Different ranges are there. There are different types of needles we can use. There is a 12-degree up curved needle, 12-degree reverse curved. There is a 24-degree up curved and a straight fiber stitch. Different scenarios, like I was telling, if it is a 12-degree up curved needle, you can use in a posterior horn or the body junction between the posterior horn and the body. The special thing in the reverse curved needle, you can use in a bucket handle tear, where you have to take the suture in the under surface of the tear. The fixation or the deployment will be really good. I will quickly pass through a animation. As I was telling earlier, different types of availability is there. You can use in different scenarios. One-handed deployment, you can use either it is an upside, or if it is you can turn it down, and using in an under surface, you can use it in a down side. The suture here now you can see the once two are there, you can see two suture bridges. First you hold that the first suture bridge is tied, and the second it will fix a very good implant, and it will fix very nicely, and you will not be able to see the thread as well. And the surgical demonstration, this is a surgical demonstration. We did it in a horizontal tear. First you will see we are going through the upper surface of the meniscus, go through the capsular junction, fire it, take it back, and we used it in a horizontal tear. So now you can see going through the under surface of the tear, two suture bridges are there. You can, once you tie with a knot pusher, it will go tight and sit, close the book, and finally you cannot even see the knot. Thank you very much. I thank all my seniors for giving me this opportunity. I thank Dr. Ayappan sir for giving me the slide as well for the video presentation. Thank you.
Thank you, Naresh, for your excellent delivery. And
thank you, sir.
Now, if there is any question. Okay. Then our next speaker is Dr. Vivek Vaskula.
Good morning all. I'm Dr. Vivek Basukala. I'm from Nepal. So today I'm going to talk about meniscus repair, my armamentarium. So we have come a long way in meniscus surgery. Previously we used to talk even in meetings like this, how to do perfect meniscectomy, but times have changed. Now we talk about meniscus repair. We see 5 and 6 anchors being used to prepare that sort of meniscus, as Dr. Bhupesh has shown. Even we are now starting to talk about the meniscal transplant. Wherever there are meniscus, we try to repair it. Wherever there are no meniscus, we try to transplant it with some allograft or with some scaffolds. So definitely trend today is to save meniscus. That is all because of many biomechanical studies which showed that meniscus is the most important structure within the knee. So there are many techniques by which we can repair meniscus, inside out, all inside, outside in. And as we have shown in Dr. Bukesh's live surgery, all techniques has to be used. We have to master all technique. But what technique to use depends upon many factors. And from the country where I come, I think the cost is the main issue, and various types of tears are also important. So outside in is our main technique, main go-to technique to almost any type of meniscus surgery in medial side, maybe the posterior side of the medial meniscus tear, and tear which are posterior to the popliteus in lateral meniscus, we deal it with the all inside repair. So whenever we try to do all inside meniscus repair in our cases, we do mostly with the FastFix 360, the meniscus repair system from Smith & Nephew. This is the animation from the company. Firstly, we have to see the depth, because posteriorly there is the demon, that is popliteal vessel. We don't want to injure it. And with the help of the slotted cannula, we insert the FastFix. This is the needle. We pierce right from the top of the meniscus like this, and the implant is the peak anchor is deployed, first anchor, then second anchor is deployed, and there is pre-made loop, and we just have to pull this suture, and these are the knot pusher and knot cutter, 2-in-1 system. So this is how we finally repair it. So this is the this is the same thing in live setting. The bucket handle tear is there, we reduce it. It's just like non-union surgery. We have to have good exposure, that is with pie crusting. We have to freshen the edges, that is with the rasp and low suction saver. And after good preparation of the edges, what we do is we now go for good opposition and good fixation, like in non-union surgery. So this is where it comes the use of this all inside sutures. That is, first bite is taken from the superior part. We always prefer the vertical mattress because it has been shown vertical mattress is way stronger than the horizontal mattress. First bite is being taken, and after removing this part, we will get this pre-made loop. We just have to pull it and pass the knot pusher and knot cutter combo from that suture, and we just will push this thing so that there will be good tightness, and from there we will just cut it. This is the first suture being tied. So second suture, so we should not hesitate to change our portals for good bite, good attack of that meniscus. So we have already changed our portal for our work. This is second anchor being passed. First bite, first deployment through the capsule, second deployment through the meniscal substance, that is the medial side. So just give a tug, compress it with, tighten it with the meniscus, knot pusher and knot cutter combo. Then, as we always see while keeping this vertical mattress, the meniscus tends to roll up. So to prevent this, we are taking one more bite, one more anchor, that is through inferior surface, and this will. So anterior part we always do with the all inside outside in technique of ours. This is how we are doing it, and at the final how it looks like. This is how it looks. So take home message is very simple. Meniscus repair should be the motto of present day. I think meniscus is just like this shirt being torn. If you repair it or if you sew it in time, everything will be okay. But if you leave it, it will tear from multiple sides and this whole thing will be gone. So just like Dr. Bhugesh's case, first case, that meniscus could have been saved if that patient presented very early. So I think the stitch in time saves 9. So there are many techniques. We have to master all, and that's it. Thank you so much.
Thank you, Dr. Vivek, and excellent video presentation. Now our next speaker is Dr. Tirth Vyas. Is he there? Dr. Tirth Vyas.
Good morning, everyone. Thank you, KASS, Dr. Rajiv sir, Samantha sir, for inviting me over here. So I am going to talk about all inside repair device in my armamentarium. I am supposed to talk about Air Plus, which is a versatile device from Stryker company. Before I take you through the key features of that device, let me just brush you through the meniscal tears and repair. Meniscal tears, mostly they are traumatic or degenerative. Acute tears, they are usually traumatic and seen in younger patients. And chronic tears, they are degenerative tears seen in 40+ age group. Now, what are the indication of all inside repair? First is the tear location. Usually it is posterior horn of medial and the lateral meniscus. Usually the tear pattern is longitudinal, vertical, and sometimes radial tears are also being repaired. Now, the design of this Air Plus is very versatile. You can see the transparent body, which will help us to know whether the implant has been fired or not. Now let me take you through the salient features. Inline trigger mechanism. That is, before the previous generation was having gear shift cycle and the track shift cycle, but now it is in an inline deployment. So just you have to do it back and forth movement. Once you do it, the back movement, it will load the implant, and then forward movement for the deployment. Plunger option and thumb trigger option allows you to fire the fast twix in multiple position in different degree of flexion and in different position of the limb. It is actually ergonomic handle. We can use it with one hand, and there is no gear shift as I told you before. Onboard depth setter, that is in 2 mm of increment, and that helps you to adjust and avoid the over penetration within the at the back side of the knee. It has got rigid removable sheath. Rigid sheath because that helps you to over penetrate at the back side of the knee and avoid neurovascular injury. Improved suture configuration. In previous generation, it was a whitish thread that was not giving good contrast. So now it is a co-braided with the blue suture, 20 ultra high molecular weight polyethylene suture. It has got a reduced loop length, then better performance under cyclic and ultimate strength test. That helps even if your meniscus doesn't heal up, that the failure would be little bit delayed. Now this is the best thing that has with the Air Plus. See, feel, hear, active deployment. That means it has got a deployment window. Once the implant is fired, you will be able to see that the first window will turn black. And also it has got a tactile feedback and it has got audible click sound. That helps you to know, and which is a very good confirmatory test for during the intraoperative time. It has got a flexible needle, 45° up and 45° down, and anywhere in between we can use. For example, if you are not able to negotiate through the condyle, then you can just bend the needle intraoperatively and use it. As I told you before, multiple deployment methods that helps you to use it in different degree of flexion and in different position and through different portals. These are the changes from previous generation that Stryker has come up with. Flexible needles, that means from above and curved up and curved down, there are 2 types of variants. Anywhere between 45° up and 45° down, we can use it. Deployment mechanism, that is, there is no track shift cycle or gear shift mechanism. Suture composition, it is co-braided, depth setter, active deployment, depth limiter, and needle options. Now, this is the animation video from the Stryker.
Insert the 17-gauge needle through the meniscus and capsule before deploying the first peak implant.
Okay, so once you have insinuated into the pierce to the meniscus, reach the capsule, just back with the thumb trigger, that will load the implant, and then push it. That will fire the implant. Once that has happened, you will be able to see the audible click, tactile feedback, as well as your first deployment window and will be turning black. Now, coming on to the surgical demonstration. This is the medial meniscus longitudinal tear. Once I have pierced through the meniscus, just pull back the trigger and then push it. You will be able to see hear the audible click. Now repeat the process. Now coming on to, this is the only company which gives you that if it is misfired, you can just contact your local representative and that will, give the another device. Thank you.
Thank you, Dr. Tirtha Bash.
Thank you.
And now our next speaker is Dr. Ritik Ganguly.
Repair, should be, you should know all the tips, all the techniques of repair. Suppose if you encounter this type of large bucket handle tear of the medial meniscus in the peripheral red zone, So you should repair it. So all the techniques you should know. The outside-in repair technique is cost effective though, but there are certain disadvantages of repair, like the position and placement of these knots and the accurate piercing of the soft tissue, accurate piercing of this meniscus tissue is important. And sometimes these knots produce irritation at the capsular region. So it can be repaired by multiple techniques. In the posterior part, you can use the all inside. In the body part, you can use the outside in or inside out technique. Or sometimes, if it is a peripheral rim, you can also use the all suture anchor, like Dr. Bhupesh case. So you should know all the armamentarium should be in your hand. But what are the indications? This is very clear. The age of the patient is important. The age of the tear is also very important. You should not repair a tear which is more than of 3 months old with a degenerative tear. The location of the tear, the length, and whether the knee is stable or not. If the knee is not stable, then the repair is going to fail. The Warren has stated that 90% of the successful repair is with when it is concomitant with the ACL reconstruction, both because the knee is stable and due to the drilling, the fibrin clots on the hematoma will increase the healing of the repaired tissue. And there is increased chance in case of the unstable knees. So these are all the techniques, all the things you should, these things are kept in your operation theater table. These cannulas is basically the 6 in numbers, 3 for the right side and 3 for the left side. The 3 right side are basically for the posterior zone, the posterior horn cannula. This is the most right part. Whenever you will going to repair the posterior horn by outside in, inside out technique, the left side is for repairing the anterior part, the anterior horn, and these are the 2 needles which comes with the suture. This has to pass through the tear side. Now these zone specific cannulas has 2 curvature. One is superior inferior curvature to manipulate the femoral condyle to entering the small space, and the second curvature, the lateral curvature, to manipulate the tibial anatomy. The advantages are, as the stainless steel exits the pre-bent cannula, it typically retains the curve of the cannula and can be directed away from the neurovascular bundles. And placement of the retractor is very essential during this inside out technique. These are the few steps. If you want to repair the medial meniscus tear, the posterior horn tear, then both the horizontal and vertical sutures can be given, and before that you have to make a safety incision and you have to retract the soft tissues. The placement of the horizontal mattress is easy, but whenever you want to place a vertical mattress suture, then this cannula should first bite should be through the capsule, from through the peripheral part of the meniscus to the capsule, and the second bite is through the meniscus and the capsule. So whenever you are tighten over the capsule, this tear, the peripheral tear, reduces and it sits well. And these are the threads which comes to the safety incision, and after knot tying this, this is a final reduction whenever you are using this horizontal and vertical mattress. Now the all inside meniscus repair system, it is basically, it is called the all inside and stay inside. So it has different parts like handle, thumb wheel, the switch trigger, depth stop sheath is there, and needle. So first of all, you should know about your armamentarium. This ratchet is wheel is for tightening and loosening and slacking of your wire, and there are switch, the two position of the switch is there. When the red dot is exposed and when the red dot is not exposed, there is a forward position, free wheel position, and it is used for most of the cases, most of the duration of the surgery, during the penetration, during the rotation, and during the tightness of the suture. This ratchet position is used. So this is the technique, the PRDT technique. First is pierce the needle to the peripheral part, then rotate the two wheels rotate 360-degree rotation, and after that you should deploy the part, the anchor. Then after that you have to give the tension and ratchet is exposed. So this is a video for repairing of the lateral meniscus. There is a bucket handle tear, and first implant is deployed at the posterior part. Then you should target for the next site of the piercing meniscus. Then that some amount of this suture is slacked into the joint. Then you should penetrate, and during penetration one thing is important, your curvature of the needle should be downward, otherwise it may injure the femoral condyle, and piercing and triggering should be done whenever the cannula, the outer part of the cannula touching the meniscus. Before firing, first the forward excursion of the switch is done, then backward, so that this anchor is deployed at the back of the capsule. Then after confirm that you have deployed it, then withdraw and aim for a second bite. First tighten this. In this position you have to make it in a ratchet position for tightening. Yes, it is and the wheel, you have to move the wheel so that the suture is tightened over the tear and tear is reduced. Then you have to take another bite. And the configuration should be a continuous. You don't need to come out of the joint for these sutures. So it is continuous. You can suture whenever you are in the joint. So you can see is a V configuration. Again you can take the bite, and finally you can repair a large bucket handle tear with this type of repair system. So it is easy. So take home, it is the one single device is loaded with the 7 implants. You can give the 6 continuous stitches. The technique is simple technique, and it gives the knotless repair. All the implants are outside the capsule. There is no worry of the friction of the knots into the joint, and it is a cost effective. Thank you.
Thank you, Ritik, for your excellent deliberation. Now, may I call upon Dr. Ravi Kumar. Dr. Ravi Kumar for his lecture. Now, may I call the next speaker, Dr. Gautam Tawari.
Good morning to everybody. thank you to the KASSCON team to have me here. So we've been listening all day yesterday about all inside ACL reconstructions. Obviously, when we see benefits, it's not only benefits. Every coin has two sides. I'm here to talk of the dark side. Let's see what we can do. So all inside is not a new technique. There has been evolution. It was first described in 1993 where Rosenberg talked about half tunnels. That is when ACL moved the next step, which means moved from full tunnels going across the femoral condyle and getting tied on the tibia onto just lying in the femur for the femur side. And then Morgan in 1995 talked about sockets. So that is when sockets came into process. And since then, we've been evolving into how to make these sockets better and better. So what were the proposed benefits of an all-inside technique? So the proposed benefits were that we should get a more anatomical placement of the tunnels as we had more vision. And we didn't have to exit at all from the bone that we were entering. We would be able to use any graft that we liked. So we could use a soft tissue graft, we could use a bone plug, patella tendon graft. We could get an improved bone graft integration because that is the key for ACL to survive and function. We could get improved cosmesis because we didn't want our patients to have huge scars. We should have bone preservation. That is why we started doing half tunnels, so that we could consider revisions should the first one fail. And we could get an improved long-term function. As the techniques were changing, as the outcomes were looked into, we wanted more for what we were doing. So what were the current trends in the literature right now for an ACL reconstruction? So we have a mean age in the literature for an ACL reconstruction of 31 years. We have a mean follow-up of 18 months. And the current trends I'm talking about is for all inside. We have graft choices. So most of us for all inside are using autografts, 73%, but we are still using allografts, which is in about 27% people. What are the graft types we are using for autografts? So we use semi-T in most of our cases, but we're using BTBs. And then we're using unspecified grafts, which are peroneus longus. In allografts, tip post is the most favored allograft used for the ACL reconstruction. Drilling techniques. So for all inside, most of us are using outside in technique. However, free AM portal is the next best technique. And then the standard socket length is about between 20 and 37. A few of us are still using transtibial. Graft fixation, we still use suspensory fixation in maximum number of our cases, and interference screws in the rest. So we'll go through pitfalls of both and see where we stand. So all inside technique, what do we think could be the pitfalls? So we'll try and take a stepwise consideration. We'll look at the anatomy. We'll look at biomechanics. We'll look at clinical outcomes. We'll look at fixations. We'll look at expansion of the tunnels. We'll look at our learning curve. And we'll look at tensioning. So these are the most common, and then we'll look at some complications that we have seen from the literature. So anatomy. Single bundle, double bundle, we can do both through all inside technique. But tunnel placement is crucial. That is the key. We've been listening all day yesterday about this. Tunnel placement is the most crucial thing. Restrictions in drilling. So AM portal allows you a free drilling into a femur without having to worry about the bony contour. Whereas retrograde drilling, you are restricted how you go inside the femur based on the condyle, where you are, outside fat. So there is restriction from the bone. Transtibial drilling obviously has the restriction from the transtibial tunnel. We have flip cutters or retrograde cutters to help us with all inside, and we have the standard way of doing the all inside through a simple antegrade drilling to the femur. Biomechanics. Joint line fixation. This is talked about in biomechanics. What I mean by joint line fixation is that it is an aperture fixation. Why do we prefer this? It decreases the graft length, it decreases the graft strain, and it decreases the graft wear in the joint. The next, socket fixation. Socket fixation causes two principal irritation factors or wear patterns, which is bungee cord phenomena, which is a linear torque that happens into the tibia, and a windshield wiper effect, which happens to the graft at the femur when you flex and extend. This is because the fixation point of the graft is further away. Clinical outcomes. So obviously before we do anything, we need to know what we are doing and why we are doing it. So we only have short-term studies right now for all inside. The current clinical outcomes are between 18 and 24 months, and I'll come across to their complications in a bit at the end of the slide. But this is what we have to think about. And we have to keep our outcomes guarded because we probably might be facing this. It might just be a Scott's parabola, who knows? So we don't know until we have outcomes. Let's go on to fixation. So we have suspensory fixation and aperture fixation. Suspensory fixation, we've talked about a little bit. Aperture fixation has a biomechanical advantage, but it has its own set of issues. That is a retrograde tibial screw that is used for a suspensory fixation at the tibia. Now, the problem with, aperture fixation. The problem with aperture fixation is we cannot have divergence of the screw to the graft. If we have divergence of the screw to the graft more than 15 degrees, we risk our graft. Retrograde tibial screw has its own problem of causing tibial blowouts. So one has to be mindful of aperture fixations when you're doing the all inside. Tibial expansion. Now, it is said that aperture fixation has a more advantage because it reduces the synovial fluid ingress, whereas socket fixation has a higher risk of synovial fluid ingress, as a result of which you can get dilatation of your sockets. So in revision surgeries, you might have to face a little more trouble. Learning curve. The learning curve is definitely demanding for all inside. It is a technically more robust procedure in terms of surgical skill. So you have to follow a stepwise way of doing the procedure, and the learning curve is steep. It is not for a newcomer. You have to try and learn and then progress. The stepwise learning is the key. In the developed countries, the stepwise process goes through drilling the AM portal, then drilling the tibial portal, and then going all inside. Tunnel accuracy, again, is the key, and that is where we want our tunnels to be. Tensioning. So, suspensory fixation, tensioning is easier. However, it has its own loopholes. With aperture fixation, one has to be mindful which way the screw is going. So the reason for using a retrograde screw is because the tension of the graft in the tibia is in line with the screw that you're putting. So it's likely that you're not going to get graft loosening whilst the screw's been put in. So complications. So what do we get? So we get bottoming out if we do all inside. Bottoming out essentially means that we have miscalculated the graft and the socket length. So what should be the length? The total graft length should definitely be less than the total socket length and the intra-articular portion. Should you mismatch this, you will have a loose graft and you will not have a chance to salvage it.
Dr. Gautam,
yes.
please summarize.
Yes. So the graft is 70 to 75 millimeter, and this is what happens. We see all inside complications in about 10% people. And this is the paper from Adrian Wilson's group. And you can see the cause is ACL failure. However, infection and hematoma are small causes. What they don't talk is loss of extension, which is the most commonest thing in the literature for all inside. So in summary, pitfalls for all inside for ACLR is placement of the femoral and the tibial tunnel. Either you put tunnels or sockets. Tensioning issues, steep learning curve. Functionally, it's loss of extension. So if you tighten your graft too much, then that is the cause. Comparable results to the transportal ACLR, better outcomes in the first 3 and 6 months, but these are short-term results, and definitely bone preserving. So that is the literature that goes on about everything that I've just spoken.
Thank you, Gautam. May I call upon our dear friends, Dr. Bhupesh, to delivering his lecture on root repair technique. It was in the previous session.
Okay.
I
have been given 8 minutes. I will take only 7 minutes. Okay. At the outset, I would like to thank Team Kolkata for calling me here. Thank you very much. This will be a technique-based video for medial and lateral meniscal root repair. In conclusion, to start with, I would say you have to do root repairs, because if you don't do root repairs, the patient will go in for OA. The OOP stresses of the meniscus is gone. It is equivalent to a complete meniscectomy. You have to cover the tibial plateau and give some kind of a shock absorber in between. How do we do it? So that is your medial compartment. You do the pike resting as we showed in the morning. I use Bancha's magic point technique, which is around 1.2 centimeters from the joint line along the TU line. Now your medial space is wide, and that is where I usually do the pike resting. Once I do that, I will take away little bit of synovium from the notch which is in front of the PCL. This step is very, very important. By doing so, I am creating 2 points of attack. These 2 routes of attack is one for visualization and one for instrumentation. So you can see the tibial spine at the 7 o'clock, 8 o'clock position now. Once I clear the synovium there, now I can bring my scope from above the tibial spine, that area. So I will bring my scope through that part. Like that, and have an end-on view of the meniscus, and the instrumentation will come through the black arrow. So follow all principles of any repair, freshen the edges, nibble off little bit so that new vascular channels are going to be there, ready to heal, and then release the meniscus along with the capsule. You should not make a rent between the meniscus and the capsule. Release the meniscus along the capsule, like that. You can use your Bankart elevator to do the same, and gently mobilize the meniscus so that the meniscus can be pulled in. I either use a curved curette or a rounded burr to debride the cartilage on the root attachment area so that you have a healing bed for your meniscus to sit. You have side-specific meniscal root repair jigs. So for the medial meniscus, like your ACL jig, you will bring in this jig and then drill your bead pin to the root entry point. Then you will hold it with your scoop and do a 4.5 or a 5 mm tunnel over it. The transtibial technique is my preferred technique because it brings in good marrow cells and healing is better. I use the antegrade passing device like this one. This is the Smith & Nephew's First Pass Mini. When you use a mini tape with it, you don't have to shuttle sutures. This will take the mini tape and you can save a lot of time. I usually take the most medial stitch first and pull it through your anteromedial portal, lateral portal, and then take the more medial stitch. I take the lateral stitch first and then the medial stitch next. Now you bring in proline through the tunnel and then send all these one by one without tangling it, and that's how your repair is. Now, in acute cases, if you are happy with this, I have switched to tapes from sutures and luggage tags because tapes have better cut-through strength. If you are happy, you can leave it, but as in this case, if you see there is tibial plateau rim that is still uncovered and you are not happy about it, then you can do a centralizing stitch. So, again, make sure you don't make a rent between the meniscus and the capsule. You just elevate little bit of capsule that is attached to the tibial plateau. We are not trying to do a ramp lesion here, minimal elevation so that the tight structures are loosened and then the meniscus will fall back into the tibial rim. You put in your 1.7 suture anchor from the mid-medial portal as we saw today in the live surgery. And I usually use, for this condition, I use the mini lasso. The mini lasso will take the threads outside the capsule and I take the bite just in front of the anchor because this is essentially like a double row rotator cuff repair. It will kind of reduce this and push the meniscus towards the posterior en route, so the tension on the transtibial sutures will be less and this will kind of translate the meniscus into the tibial plateau. So, we do a mattress here. Unlike for repair where we did a simple, this is a mattress stitch and the knots are tied behind the capsule. So now when you pull the sutures into the transtibial, you can see good dunking of the posterior en route into the transtibial tunnel, which is very important for healing. A bump is created there and then you can see a lot of meniscus is now inside the tibial plateau and there is covering of the tibial plateau and meniscal extrusion is corrected. Now for lateral meniscal root, you follow the same principles, you mobilize and then you debride off the cartilage from there. They are usually seen in conjunction with ACL tears. This is one of the bad cases like today's case, long-standing ACL, your lateral meniscal root is out. So here you can put the opposite side jig. For the right knee you have to use the left side jig because all the jigs are made for the medial meniscus. And then bring in your transtibial tunnel and then your suture tapes along with your first pass mini. I usually prefer at least 2. In some instances I use 3 sutures. Bring in your proline. I usually have the all suture anchors which have a hook in front. I ETO them or plasma sterilize them and keep it ready for suture passage. So that is my second one coming in and then they are shuttled inside. Of course, there is no centralizing stitch in lateral meniscus because it's a very mobile structure, but there was a tear which was extending here, so an all inside stitch was made there. And you can see how a lateral meniscal root repair usually brings back the condyle into place. Thank you. I take this opportunity to invite you all for the LSD course in Chennai next week. Please come. You can register at www.ieaaf.com. Thank you so much.
Thank you, Bhupesh, for your excellent video on the root repair technique. And thank you. Then our next session is the patellofemoral instability. And our chairpersons are Dr. Amrish Kumar Jha and Dr. Sabyasachi Satra.
So our next session is on patellofemoral instability. So we would like to invite Dr. Kanchan Bhattacharya sir to deliver his lecture on evaluation and management algorithm of patellofemoral instability. Sir.
Good morning, everybody. Respected chairpersons and the delegates. So talking about patellofemoral instability is something that has been bothering the orthopedic community for as long as we can remember. It's a conundrum both for the treating surgeon as well as the unfortunate people who've been suffering from it. It's a lateral subluxation usually of the patella from the groove during flexion and extension. It has forever it has been realized that it's a multifactorial of origin. The patellar groove, the bony structures as well as the restraining soft tissue structures play an important role in providing a good extensor mechanism. And when they are not up to the mark, we have an issue. The incidence is not as small as we think. It's suggested that 7 out of every 100,000 people are likely to suffer from this condition. It presents more often than not in the second decade, and at that point, about 31 out of 100,000 can have this disease. It's usually seen amongst adolescent females with hypermobile joints. The recurrence rate is about half of them have a recurrence. And once you have a recurrence, the incidence gets more and more often, more and more regular. More often than not, it's first presented during a playing activity, sometimes in activities of daily living, and very rarely traumatic. The treatment has seen a lot of changes, but the basics have remained the same. Even from the early 19th century, surgeons have been trying to treat it, and usually they were concerned with people who have a habitual or a recurrent dislocation, where there's usually a lateral structure which is tight. And in our younger days, we saw a lot of them with injection fibrosis, but this could have happened even from birth. So the early literature by Rue Goldwaite in about 1903 talked about lateral release. The first bony operation that was recorded was Hauser, and that was before the Second World War, 1930s. So people have been thinking about it, and we have not changed a lot over the years. But what has made a marked change is de Jure's study, first published in 1987 and then again in 1994, which has kind of cornered the fact that there are major factors which are important in deciding why it's going to dislocate. And the major factors are trochlear dysplasia, patella alta, a TTTG distance, which means an increased lateral vector. And they initially thought that patellar tilt would also be important, but subsequently they realized patellar tilt is more of an effect than a cause. The diagnosis in de Jure study were made mostly from X-rays and CTs, and of which a very important finding has been a good lateral view X-ray. And its cornerstone has been 3 signs, we call them 3 pillars: the double contour sign, the crossing sign, the supratrochlear spur. And then when you put this X-ray into perspective with either a CT or an MRI, you have 4 grades, A, B, C, and D of de Jure's classification of trochlear dysplasia. The first is a shallowing of the sulcus. The second is a flat sulcus. The third is a kind of a convex. And the fourth is a box-like structure with a large supratrochlear spur. Over the years, some important findings have been the patella alta, of which insult salvati has been there for a long, long time, which is calculated in an X-ray in 30 degrees of flexion. And anything more than 1.54, we would say, is patella alta. The more recent one is Keita Deschamps, which is done either in CT and X-ray. It's easier nowadays because the radiologist gives you the figures, and anything beyond 1.20 is an increased CD value. And here, the radiologist gives you an exact figure, and you don't have to use pencil and ruler to find out where you're going of. In the TTTG, there are a little bit of variations here and there. Either you go by CT or MRI, but each have a figure. If it's CT, it's more than 20. If it's MRI, it's more than 13. And you would like to keep them at the end of the day, you would want it either between 10 and 15 if it's CT guided, or between 2 and 13 is MRI guided. It's more often than not, it's 10 to 15 is CT guided. And these are the backgrounds that we have nowadays when we think about treating them. Now, when the patient comes to you and you have to evaluate as to what needs to be done, if at all anything needs to be done. History is very important. Find out when it has started, is it one side or both sides, how many dislocations, and have the dislocations caused a lot of swelling. We also have to find out if there's any coronal or sagittal plane deformities which can be easily evaluated clinically and radiologically. If it's instability of flexion, if you find that the patella is slipping out during flexion, it's usually because of the quadriceps tendon length or the extensor mechanism tendon length. But if you find that the patella is popping out during extension, it's usually because of trochlear dysplasia. And this gives you a very important, very firm ground on which to stand when you decide how you want to do. An important test is apprehension test, which is very important when it's done a few days after injury, but not so much if the injury has happened a long time back. Hyperlaxity of different joints is quite often present and is again something that you have to take into account when you decide upon your surgery. Patellar tilt or maltracking. Patellar tilt is usually present when there is lateral band tightening, and this again is important for your evaluation. And a prominent J sign is something, you can have a dramatic, the video will it run? Let me see. So this is a dramatic J sign. You find it's, as you extend, the patella moves out. And this is again important for you to define how you're going to go about it. Once the clinics are over, you go through an X-ray, an AP, a lateral. Du jour suggests a lateral in 20 degrees, standing X-ray, making sure that the posterior condylar borders overlap so that if there is a double contour, which means one condyle is smaller than the other, then you can see it very nicely. You can also do the trochlear spur and the crossing sign. And you need a Marchand's view in about 30 or 20 degrees to find out where the patella is lying. A CT and MRI gives you a global view of the knee, especially the relation of the patella to the groove. What are the treatment options? Conservative does not mean doing nothing. Conservative perhaps is the mainstay and should be done very assiduously. The strength of quadriceps, primarily the VMO, the gait, if there is other associated weaknesses, those should be addressed. The soft tissue surgery, the current flavor for the last about 2 decades is MPFL, using one graft or the other. Tibial tubercle transfer again has been there for a long time, either distalize or enteromedialize, trochleoplasty and lateral disease. So these are the surgeries that we have. And in terms of algorithms, if it's the first time dislocation, more often than not, the literature says that look for a bony injury. If it's adolescent, apart from X-ray, you might need an MRI, because if there's a bony flake of bone coming out, you would need surgery. Otherwise, you would either conserve or operate. The pendulum still goes in favor of conserve first, surgery only later. In the adolescent, the epiphyses are still open. Again, conservative first, surgery if there's an acute injury and if there's a bony piece of, or if there's a loose piece of bone moving around. In case where you must do a surgery, soft tissue surgery, MPFL reconstruction with soft tissue harness in the tibia, in the femur, attached with the adductor magnus, or some variation of Roux Goldwaite procedure where the patellar tendon, the lateral side of the patellar tendon is overlapped onto the medial side. And when you come to the adult, there's a plethora of algorithms. I think there are as many algorithms as there are orthopedic surgeons. So looked around and found out something that is going to meet my requirements and my practice. So you find that if you have patellar pain or potential patellar subluxation, you conserve, and you still fail, then you think of surgery. In objective patellar dislocations, means those who are really dislocating, if it's less than 3, you conserve. If it's less than 4, you think of surgery. And when you think of surgery, MPFL is one constant. Either you do it together with others, or you do not do it together, or we do it by itself, but it is not a panacea. Now, If you have trochlear dysplasia according to de jure, A, you do nothing. B and D, you do a deepening trochleoplasty. C, we are not quite sure what needs to be done, but probably some kind of tibial tubercle transfer. When you have the, in addition to all those, if you find that there is significant patella aorta, you can distalize it. If there's, and if there is significantly increased TTDG ratio, then we enteromedialize. If there is patellar tilt or different lateral tightness, then you certainly do a lateral release. Now, talking of trochleoplasty, and this is the one that is bugbear in today's context, and several studies have shown that it's not easy for average surgeons to figure out which is A, B, C, and D of de jure. And Ferguson, who's a big man in patellar instability, in 2019 published that everything else seems to be exactly like the Lyon school. The only difference is in presence of trochlear dysplasia. He feels that if there's significant patella aorta, if there's hyperlaxity, and if there is a significant spur, supratrochlear spur of more than 5 millimeter, more than 5 millimeter, and a convex or a box-like trochlea, that's the only situation you need trochleoplasty, and you very rarely need them. So the take-home message from me would be very focused conservative management. That is really the mainstay. Surgery, you think only after at least 3 dislocations. Every case is going to be different, so it's going to be a la carte, a case-based evolution. MPFL reconstruction is the most common surgery, but it is not the panacea. It will not take care of all your problems. TTO in selected cases and lateral releases were indicated, and deepening trochleoplasty in only a few cases. Each one of the surgeons, young surgeons, who are all very talented, should learn how to do trochleoplasty, should learn how to do a tibial tubercle transfer safely and efficiently, because this is going to be part of your treatment armamentarium in the years to come. Thank you very much.
Thank you, sir, for the informative talk. Any question from the floor? No question. Thank you, sir.
Thank you.
So our next talk is on MPFL reconstruction. It's a real life video by Dr. Sarthak Pattanayak from Odisha.
Good morning, everyone. At first, I would like to thank KASS for giving me an opportunity to speak on MPFL reconstruction. As we know, MPFL is one of the most important primary ligament which holds the patella. To start with, we go for the clinical examination of the knee. We always should see the normal knee, try to see the patella and the shift of the patella, and then before doing this examination, always look for the beaten score. It is very much essential in a patient with patellar instability. I go with the graft. I generally prefer to take a semitendinous graft. Then my friend, the marker pain, which is very much essential. Always to get your patella anatomic structure, like surface anatomy clearly, palpate the inferior pole, palpate the superior pole, the lateral border and the medial border. Don't do much of sketch. It will just dirty this area. Keep it safe and clean. Once you get it, flex the knee, and now for the femur side, try to look for the 3 things. First, look for the joint line. You get the medial joint space, palpate, and mark your medial tibial condyle, which will help you to notate. Then mark for the medial femoral condyle, and once you mark the medial femur condyle, you see you mark it properly, and then you have to look for 2 anatomical prominence. One, you have to feel for the adductor tubercle, and you have the medial epicondyle prominence. So once the adductor tubercle is felt, you mark it, make it felt with an assistant, and here you can see the adductor tubercle is well marked and along the epicondyle. So this is where your space where I am going to get my incision for the fixation of the graft at the femur side.
The incision is given, we go deep, we try to, I'm sorry for the video because it was taken by my assistant and she has done a very bad job, so you might, there's some steps has been missed, I completely, please pardon me for that. So once you feel the anatomical landmark, confirm it with the C-arm, I miss the C-arm image here, and then flex your knee, and after putting the drill pin, drill the femur tunnel and go slightly anteriorly. This is how you have to do it, and recheck it with the C-arm. I do the femur tunnel first because that gives me, it saves my time, and then you pass the suture once you get it and leave the suture there with the tunnel. This gives me a lot of confidence and also saves my time because I know the major part is done, determining the scale and everything. Then I go back to patella. This is how I do my patella marking. I mark it completely. I take the scale. I mark the superior most point, the superior patella. My first mark, which goes around 10 millimeter, and the second point goes around 10 to 14 millimeter. So that it is on the patella. I mark it, and I'm happy with this. As you can see, I try to see it is going parallel to this. Then I take my parapatellar incision, medial parapatellar incision, try to feel the medial border of the patella, and go and feel it till I feel the medial margin. I try to hit the capsule and examine. Then I put my wires on the markers where I have done it, and then I see it in the C-arm, I check it up. You can see the video qualities, I'm sorry for that. And then once it is done, I fix those wires. I take out my wires and then place my anchors. So depending upon your patient's affordability, there are various anchors. We have swivel locks, we have this metal anchors, we have bio anchors. Some people do the and this is what I would like to show you today. This is one of my invention. This is known as PAT rig. This is a jig which I have made for the patella MPFL, which you can see. This is a 3D print image jig, and there's got 3 sockets over here on the superior side. So if a patient's patella, it differs in the sides. So in the medial to lateral side, you can have 3 slots, and from superior to inferior pole, we have got again 3 slots. So you can keep it, and then once the slot is fixed in the patella, these are the space where you can put the belt, and these are 2 slots where you can put your drill pins. This is how it is placed inside on your patella. We have the belt, and this is, it can be sterilized and can be kept, or it is just you can throw it. It costs you only $1, and is already been US patent has been approved for this. And this is a bar gram, which is radio opaque, which will help you determine exactly the position of the your placement of your neck. I have modified it with the femur side recently. That has also gone for its approval. So we won't need that scale which has been supplied by Arthrex. This is maybe in the next time I get an opportunity of showing you the device. So it is a very novel device, and it can incorporate it inside the X-ray device to take the real-time measurements. It can be used intra-op very easily. It costs just less than $1. So this is what which is known as PAT rig, and this is how the image bars it is. So once you do this, the graft, the semitic graft we try to under observation, we try to bring it, mark those 2 points which I can show you, 1 and 2 points where your 2 tunnels you have made or the 2 anchors you have drilled. We try it properly. You can take 6 stitches, you can take 9 stitches, which is up to you and your fixation. So minimal what we fix stitches I take is around 6. So once I do my proximal stitch, I try my second stitch also, and once it is done, just slide it. I fix it tightly so that we get a good thing, and then it is well stuck. So once I do this, then we go for the femur side. We try to go the extra synovial. We put our artery forceps, try to get it from the patella side towards the femur side tunnel, and we do the suture pass has been done, and I think everybody knows it, and this is how we do that. And sometimes your loop remains down thanks to your assistant, but then you can mark it, you can tie those things and pull it down. Once you do it, your patella is now in place. This is how you get it. We know various technique. We have to push it back So the pin will be there, the bead pin, those thread is there, and then with the help of your drill bit, you have to push it, all those threads. So once you do it, hold it, you give a lateral push, let the graft go slowly, all those threads come in slowly towards your head. At that point, you don't need to maintain anything, but yes, once you are going to fix it, hold it, you can either put your drill bit and tie the loop around the tendon and look for your patellar tracking. What I feel, I push it and then I keep my artery forceps and then look for the patellar tracking, how rigid it is, and then later on the final pull is given so that I get a good thing. So once I get this, I'm quite happy with the fixation, and then I pass my Nightingale wire followed by the bio screws, determined in basically 6 to 7 diameter, and so once it is well tied, I get that click noise. I'm happy. I maintain around 45 to 60 degree of knee flexion, and once it is done, I'm fine. We remove the screw. Thank you. So I would like to take your time. This MPFL rig which I have done, it is very user friendly. I would request if some of the seniors would love to try it, I will be very happy to share it, because it has been designed by me and the University of Cape Town, and we have successfully done the trial basis has been done, and we are looking for a good company, and I am looking for it to. But if somebody wants it for any cadaveric study, I can get it available, sir. Thank you very much.
Thank you. Thank you, Sarthak, for excellent video demonstration. Our next speaker, Dr. Abhijit Sen, he will speak on tibial tuberosities transfer.
Good morning, everyone. My topic is tibial tubercle transfer. So, tibial tubercle transfer is a well-established procedure in the treatment of patellar instability and in selected cases of anterior knee pain. So, what are the indications for this procedure? Number one is patella alta. So, how do we define patella alta? It's defined with the help of Caton distance index, the normal value of which is 0.6 to 1.3. The Caton distance index is calculated with the help of a lateral view of knee at 30 degree of flexion. We draw two parameters. One is A from the lower border of the articular surface of the patella to the anterior angle of the articular surface of the tibia, and B, which is the length of the articular surface of the patella. So we take the ratio of A and B, and we get this Caton distance index. Next parameter for seeing the patellar instability is insult solvability ratio, which we all know, the normal value of which is 0.8 to 0.2. So it's calculated with the help of taking the ratio of length of the patellar tendon and length of the patella. So anything above 1.2 is patella alta, and if it is less than 0.8, it's patella baja. The second indication for this tibial tubercle transfer is TTTG distance. So to get this value, we need to ask a radiologist to superimpose two axial views. One is of femur and one is of tibia. So the femur axial view will be at the deepest point of the trochlear notch, at the level of the deepest level of trochlear notch, and the tibial axial view will be at the highest point of tibial tuberosity. So if we superimpose two views, then we get the distance between these two lines, and this is called TTTG ratio. So the normal value is less than 15. If it is between 15 to 20, it's borderline. If it is more than 20, then it's considered as abnormal. So there is a abnormal lateral pull of patella outward. So what are the techniques of this tibial tubercle transfer? So there are many techniques, and these techniques are performed depending upon what abnormality we have actually. Like this, the first one is medializing osteotomy, and this is called Emsley-Trillant technique, and this technique is basically isolated medialization of the tibial tubercle. So it's done in case of patellar instability or lateral maltracking of the patella. So how do we do this? We give a parapatellar incision, either medial or lateral, depending upon whether we perform MPFL reconstruction or not. Generally, we combine this procedure with MPFL reconstruction, so we prefer to give a medial parapatellar incision. Then we expose the patellar synovium and the bursa, and we dissect on both the sides so that the patellar tendon can be visible clearly. Then we start our osteotomy from the proximal part of the tibial tuberosity and extend distally, and we do a segment of osteotomy of a length of 5 to 6 centimeter, and we keep this osteotomy level 5 mm posterior to the anterior surface of the tibial tubercle. Then we medialize this osteotomy and fix it with the cortical screw. So how much medialization is to be done will depend upon intraoperative tracking of the patella. We need to make the patella sit centrally. So if there is problem in TTTG ratio, then we go for this type of osteotomy, Emsley-Trillant procedure. The next procedure is anteromedializing osteotomy or the Fulkerson technique. So in this technique, we transfer the tibial tubercle anteromedially. We perform a oblique osteotomy like this, which runs from this anteromedial to posterior lateral surface. We start from the insertion of the patellar tendon and we go distally up to 5 to 6 centimeter, and we translate this segment anteriorly and medially, so that both we can cover the TTTG ratio and we can anteriorly place the tibial tuberosity. So this can help in normalizing the anterior knee pain also. The third osteotomy is distalization osteotomy, where we perform osteotomy of the tibial tuberosity and fix it distally. So by this osteotomy, we can address the patella alta component of the issue. And the fourth osteotomy is MAC technique, which is anteriorizing technique. This is not basically for recurrent patellar instability. This is basically for anterior knee pain, where the osteotomy is done and the tibial tuberosity is anteriorized and the gap is filled with bone graft. So basically these techniques all have complications. So the most common complication is skin necrosis, and other complications are non-union and implant prominence. So this MAC technique, the last anteriorizing osteotomy, has been already banned due to the major complication of skin necrosis. Now we have one case which I must thank Dr. Sunit Hajja sir for providing me with this case and sharing the pictures. So this is a 20 years old female. She has presented to us with recurrent patellar dislocation. The apprehension test was positive. the X-ray, we can clearly see that the Caton Distance Index was 1.3 and insult solidity ratio was 1.5. The TT-TG ratio was measured to be 13 mm, so which comes to be normal range. In MRI, we can see the patella is laterally subluxated, the MPFL is attenuated and laxed. So we have decided to go for a distalization osteotomy, as she has problem of patella alta, along with that MPFL reconstruction. So we have chosen medial parapatellar approach, and we have exposed the tibial tubercle, and we have performed the osteotomy from the attachment of the tibial, from the attachment of the ligamentum patelli, and we did this osteotomy 8 mm posterior to the anterior surface of the tibial tubercle. So this is a 6 mm long, 6 centimeter long segment we have osteotomized, and then we removed a 1 centimeter block from the distal part of this osteotomized segment, so that we can make it fix it distally. So how much segment is to be removed can be decided with the help of a intraoperative calculation of Caton distance ratio, which should be in the range of 1 to 1.2. Then we fix this osteotomized segment with the 4.5 mm cortical screw, either 2 or 3. Then we perform routine MPFL reconstruction with the help of Gracilis graft. So this is the post-op X-ray, 6-month follow-up X-ray. So we can clearly see that the insult solidity ratio and the Caton distance index has been reduced, and the osteotomy is already united. And this is the final clinical picture of the patient at 1 year follow-up. Thank you.
Thank you, Abhijit, for explaining the details of different methods and to finish your talk on time. So our next speaker is Dr. Sachin Tapaswi, who will talk on trochleoplasty. It's a virtual talk, I think, isn't it?
With you virtually today and present on trochleoplasty. There are no disclosures relevant to this talk. At the outset, I'd like to invite all of you to come and join us from the 27th to the 30th of April of this year in probably the biggest knee surgery event involving our subcontinent as well as the Asia Pacific region, none other than your favorite Pune knee course. So I hope to see all of you there. This time it's a 4-day gathering, and we promise to give you everything which is to do with knee reconstruction and ligament and knee preservation. So essentially, what is the patellofemoral articulation?
So it's a recorded video.
So if you look at the patella gliding, in the first 20 degrees of flexion, the MPFL is important. Beyond 20 degrees of flexion, the trochlea and the MPFL take over, and this is a static type of a restraint in which the bony contour of the trochlea will glide the patella in the groove. As you move from proximal to distal, you will understand and appreciate that the trochlea deepens as you go further distally. This is an arthroscopic view of normal patellofemoral tracking when the scope is placed in the superior portal, and you can see a very nice smooth gliding of the patella within the trochlear groove. There have been various studies to look at the various anatomic factors which are associated with the primary patellar dislocation. One of them is that younger the age, higher is the incidence of patients having a primary patellar dislocation. And when you analyze them into the various risk factors, you would find that trochlear dysplasia is probably one of the more common risk factors that is primarily associated with a lateral patellar dislocation. So almost about 84% of all lateral patellar dislocations will have some form of trochlear dysplasia. Trochlear dysplasia implies a hypoplastic medial side with a hyperplastic lateral side. And essentially what happens is that when we have an abnormality like this, the MPFL starts getting stretched and becomes relatively non-functional. So to give you an analogy, you go into a bowling room and you're trying to roll the ball in the bowling alley to try and knock off the skittles. When you find that the groove is nice and well prepared, of course the patella is going to glide straight in the center. And this is what happens normally when we look at a patella that moves. When you have a flat trochlea, this can go waywardly, and when you have exactly the opposite, the patella, which is the ball, is always going to glide off. And this is exactly what happens. You can see that there is a large bump on the lateral side. The hypoplastic medial side is seen across, and the patella, as it starts flexing, will hit this bump and then glide off laterally. And that's essentially the essence of trochlear dysplasia. When you try and diagnose them on imaging, you'd probably look at a few x-rays, and you'll definitely look at a lot of slice imaging on your MR scans. On the x-rays, you want to look for the trochlear bump, you want to look for the crossing sign as well as a supratrochlear spur, whereas on the slice imaging on the MR scan, you want to look at various aspects of the trochlear and the patellar shape. You want to look and ascertain the facet asymmetry. You take a ratio of the medial to the lateral facet. 40% is the threshold, and this becomes a very sensitive and specific way of measuring trochlear dysplasia. The other aspect is to look at trochlear depth, and what we essentially do is to drop a perpendicular to the trochlear floor, and this again is very important. A trochlear inclination angle will detect a dysplastic lateral facet, and anything which is less than 11 degrees is definitely significant, as what can be seen in this particular example here. So based on these radiographic anomalies, they can be classified as per the de Jour classification into a de Jour type A, which is a shallow but not a flat trochlea with the presence of a crossing sign. You have a de Jour type B, in which there is an additional trochlear spur, and the CT or the MR will show a flat trochlea like in this example. You have a de Jour type C, where there is no spur, but you have a convex trochlea with a hypoplastic medial femoral condyle, and you see the so-called double contour sign because of the two condyles or the two trochlea that overlap each other in this particular fashion. When you have an additional supratrochlear spur, then you have the cliff formation, which is the de Jour type D, which is by far the most severe type of trochlear dysplasia. So clinically, what we diagnose them is that we see that these patients have a very high grade J sign, like what you see in this young boy here, and these will have apprehension not only at full extension but even 30 and 60 degrees of knee flexion. So the indication to perform a trochleoplasty is when you have apprehension of the patella in deeper degrees of knee flexion, almost to around 50 degrees, when you have a grade 3 plus J sign, when you have lateral trochlear inclination which is less than 11 degrees on your slice imaging, your radiology as well as your MR scans demonstrate either a de Jour type C or type D, the pattern of the dysplastic trochlea, and there should not be significant chondral changes on the undersurface of the patella or the trochlea. There are various ways you can perform a trochleoplasty. You can do what is called as the opening trochleoplasty, which was probably one of the older methods, wherein you created an opening and you coronally oriented the LFC to open more, but these actually are in contrary to the original pathology and have a higher risk of osteoarthritis. Later on, the wedge resection trochleoplasty was popularized, wherein the sagittal wedge was removed from the anterior femur to make it flush with the anterior cortex, but this only caused tilting of the articular surface without recreation of the groove, and this was not a very popular procedure. Later on, we had the procedure of deepening trochleoplasty, which was popularized by Massey and Henri de Jure, and this by far has shown to be the most sort of commonly done trochleoplasty procedure which has stood the test of time. So how do we look at it? This is one such example. You can see a grossly abnormal trochlea, and next what we need to understand is that we need to plot where the current trochlear groove is. You want to plot where the proposed trochlear groove is, and then we want to mark out the center of the trochlea and both the trochlear facets, and this is the area that we need to tackle by doing a trochleoplasty. One must also understand that when we do a trochleoplasty, we affect the TG part of the TTTG, and effectively we decrease the distance of the TTTG once we perform a trochleoplasty is something that you need to remember. So how do we start off by performing it? Well, this is done predominantly as an open procedure. You plot out the proposed groove, you mark out the current groove, you then want to go ahead and remove the large bump, which is a supratrochlear bump, and then with the help of chisels, a burr and very sharp and smart instruments, you want to start removing bone from the subchondral area. The use of specialized tools will make your life a lot more simpler, and these specialty burrs which will allow you to remove 3 or 5 millimeters of subchondral bone are effective methods to do the same. So a combination of freehand technique, the use of a burr and the use of chisels is carried out to create a smooth flap, and once this flap has been created, which is usually then rendered to be quite mobile, one goes ahead and proceeds with the definitive cuts in the articular cartilage and goes ahead with the fixation. The fixation is pretty simple. We take a 3.5 millimeter knotless anchor loaded with 3 strands of number 2 vicryl. This is inserted at the center of the trochlea, and then these 3 limbs are then shifted proximally, and then the whole trochlea is depressed down and fixation is done proximally with the help of knotless anchors again. This is probably what you would get to see at the end of the procedure. Probably the most important aspect of performing any form of trochleoplasty, as it should effectively decrease the supratrochlear bump and allow the patella to track smoothly within the groove, as is demonstrated in these pre and post-op pictures, where the supratrochlear bump has been decreased from a height of almost 11 millimeters to that of 4 millimeters. In lower degrees of trochlear dysplasia, a grooveplasty can be performed, wherein the supratrochlear bump is removed and not much work is done on the trochlear flaps and the subchondral bone per se. So to conclude, trochleoplasty has got promising clinical and radiological results. Cartilage viability is very well preserved, contrary to what you may feel when you first perform your first trochleoplasty, and trochleoplasty should be considered as a definitive procedure and not a salvage procedure. So thank you friends for your attention, and I hope to meet you in person very soon within the next 3 months. Thank you. Greeting friends, my name is Dr. Sachin Tapas, and I'm very happy to be with you virtually.
That was an excellent talk by Dr. Tapaswi on tracheoplasty. So this ends the current session on patellofemoral instability. Now we would like to invite Dr. Amit Joshi and Dr. Mukesh Ladda to start their next session on patellofemoral instability. It's a panel discussion. Dr. Joshi. So the next panelists are Dr. Vikas Kapoor sir, Dr. Puran Chandra Tejaswi, Dr. Kanchan Bhattacharya sir, and Dr. Bhupesh Karthik. To Dr. Joshi.
Thank you. Please, you can sit there, no problem. They will turn that side. Please turn this on that side, yes. Sir ke paas. So, we saw a very nice session of patellofemoral instability. All the talks, you know, my job makes very easy, but you see, talking about all these patellofemoral instability in very 20 minutes time is a really difficult challenge. So we all know that patellofemoral instability is a challenging condition, and then understanding of pathology is changing every day, you know. Few years back, nobody used to do a trochleoplasty. Now everywhere we are talking about trochleoplasty. This is relatively rare condition as well. That's why probably that is the reason why it's not coming. Okay, that is the reason why, you know, not much of publication coming in, and then treatment is still confusing. So my job is basically to come in to discuss about this a la carte menu, which means that ordering dishes from a menu. So you go to the restaurant, you see the menu and order that. And unfortunately, to order from this menu, you have lots of surgeries. There are soft tissue surgeries, more than 75 described, and there are more than 100 surgeries described for this patellar instability. So to identify what is the menu and to create a menu, probably I'll say that we have to do certain investigation, as all Kanchanda also said. So Bhupesh, what is your go-to investigations for a patient with patellar dislocation?
Of course, to start with, I will want a plain X-ray and the Lawrence view and the Hutchison's view, where you can see whether the patella is centered. And the true lateral view will be my first line of investigation for any patient.
Absolutely, true lateral view is the most important. But what we have experienced, that if you ask even for true lateral view, most of the time you get this kind of oblique view. So how frequent is this common, Vikas sir, in your practice? You send
Always.
for two?
Always.
So what you do then?
We have to send somebody to get a proper view done.
Okay, so you'll send the patient again and again?
Not the patient. Either you go yourself, if you have the privilege of a department, you send somebody who can.
Perfectly. So I'm sure that this problem is everywhere, and then I have talked to some of my colleagues elsewhere also. They say that this oblique view is a problem. So what we personally do is we take the patient to operation theatre and use a C-arm to identify exactly what are the views in which degree of flexion, you know. You can do a static picture of the same patient, and then the dynamic picture you can also take. So probably this is one thing we have been practicing for quite a few times, getting all these proper X-rays, both AP as well as the lateral view and the other views in the C-arm. We call them in operation theatre, and everything is in our control. So skyline view, you will do a skyline view because I was going through the prescription, and most of the, if patella problem, then we always order AP, lateral and skyline. Bhupesh, I can't ask question to Kanchanda because I'm afraid, sir. So you write skyline view?
Before the skyline view, I'll go back to your question about lateral views. I find all those lateral views are very good. I honestly do not have the time to go through all the lateral views in my clinic. For me, history, clinical examination, a lateral view, and a CT or an MRI, and they all come with them, that takes care of it. Question of skyline view, I think it has no value. Because in 90 degrees of flexion, if it's a permanent dislocation or a habitual dislocation, otherwise everything is happening in the first 20, 30 degrees. So it's a merchant's view or any of those views in about 20, 30 degrees, that is of more importance to me.
Yeah, and everybody doesn't have the privilege of going to operating room with a C-arm and getting all those views, and it's like one whole day doing one imaging. Besides that, these skyline views in 30, 60, 90 degrees, 120 degrees flexion will give you a reasonably good amount of idea about the tracking of patella at various angles, and I think that is very easily doable in a routine technician's hands in X-rays.
If your radiological technician gives you a perfect view, there is no debate about that. But when you don't get this, routinely get the correct view, probably that is the place where this has options. Okay. So what I mean to say that current literature says that probably other views except the true lateral views are of lesser importance, because you can measure all those angles. What you are trying to measure in the skyline view in different angles can be measured in CT scan or MRI, that which is you are going to do definitely. What about scanogram? Do you do scanogram to all of your patients who come with patellar dislocation, Kanjanda?
No.
No. Vikas sir? Yes. You do?
Yes, it's a routine for all knee patients.
Okay, for all knee patients.
I don't, but clinically I will definitely measure the Q angle, because here I am not looking at varus, thrust gate and other things, because these are usually 15 years to 25-year-old kids. So I look at the Q angle, and of course my decision making is based on TTTG and the Q angle, so I don't do this scanogram. Having said that, there is no harm in doing it.
But there is no advantage in your opinion of doing a scanogram? No advantage. Okay. Because sir, why you do scanogram for this patient?
Yeah, the valgus and varus angulation of the knee gives you a fair mental picture of what you might expect in patellar tracking also. At the same time, it's a good practice to have when you are routinely dealing with a lot of knee cases, to have a routine procedure, a routine list of investigations which makes you attuned to how you approach a knee. So scanogram is a must for all knee patients.
Okay, what about CT scan? Bhupesh, from you. You do
CT scan, yes, definitely yes.
For all the patients?
CT scan, definitely yes.
Kanjanda, you also do CT scan for all the cases of patellar dislocation. We are talking about recurrent patellar dislocation.
Patellar, it's either a CT or an MRI, and I don't see a big difference.
Not both? Because sir, you do both CT and?
Both. CT is more important when I am planning surgery for the bony reasons, but MRI is a must when we are looking at, it's basically a second investigation after an X-ray rather than a CT scan.
Bhupesh, what is the advantage?
So both is very important, because in today's, our part of the world, we are privileged that patients can just walk out and get their own CTs and MRIs and come. There is no waiting time. And most of the time when you ask for an MRI, you can ask for a screening CT, which will give you this. So it is definitely not a problem at all in our part of the world. And the advantage of MRI is you see other hidden problems, you see the MPFL ligament, you see chondral fragments which are inside the joint, which are all very important decision makers in the surgery. The TTTG distance and the morphology of distal femur and patella is better described in the CT scan. So both are equally important for me.
Yeah, absolutely. If you go to literature, they say that the measurement differs between CT scan and MRI. So probably MRI is little over-exaggerated measurement, so you have to reduce by 6 to 10% the measurement so that you come to the normal this thing. But I absolutely, with the panelists that probably this is one condition, patellar dislocation is one condition in which investigation has to be exhausted before planning a correct treatment plan for this patient. If I say this, do all the panelists agree? Vikas sir, you agree?
Do all the?
Everything,
Yeah,
yes. All the investigation has to be done before planning. Absolutely. So, CT scan is very, very important, because all the measurements, if you go to literature, they are done under the CT scan, especially TTTG. And most of the time we do TTTG for the patients, But what about femoral version? Do you measure this femoral version? Do you ask your radiologist, Bhupesh?
No.
So, if you were not here when Adrian and Clay was talking about that, very good number of the adolescent, they have a abnormality of the femoral version. So probably that is why it is important to identify what is the femoral version, and then this is what current literature has to say, that it's not only the TTTZ which is important, but also the femoral version is important, which can very easily be measured. The same technique of measurement of the TTTZ distance. So MRI, one additional advantage of MRI probably is we can look into this cartilage status, so that you decide in recurrent patella, you identify what are the things you are going to. So I'll quickly go into cases. This was a 26-year-old gentleman, no history of trauma, pain right knee, difficulty in running, but he used to say that the patella moves, his patella movement was little abnormal. Bhupesh, this is his clinical picture. What you see here and what you are thinking in line.
He's got a positive J sign.
Perfect.
And as he is flexing, you can see the patella relocates into the groove with a clunk.
And this is bilateral.
Yeah.
In the bilateral. So
both
what are
things.
the things, we'll not go into clinics because this is probably will elongate the clinical examination is absolutely very, very important. But in terms of investigation, what are the investigations you are looking for? Because sir, in this particular case.
Yeah, so the investigation already we have a routine set in the previous discussion which we have done. So we'll do all the three investigations one by one.
Okay.
And starting with the X-ray, of course, and now the MRI and CTs.
So I'll just show you his data, CD ratio 1.5. This was his CT scan. His scanogram was perfectly normal. There was a little bit of trochlear dysplasia, but grade B, maybe TTTZ distance was 24. So I always ask my residents to plot this profile, the instability profile, so that all the information that you want is in one table, so that you can decide what treatment this patient required. So this patient was skeletally mature. The TTTZ distance was 24 and the CD ratio was 1.5. So what will be your treatment option for this patient? Bhupesh?
Can I quickly ask, the history-wise it is post-traumatic?
Not exactly. He was not having that good history of trauma was not there. He just noticed after running, he noticed that his patella was not gliding normally.
I will first try a good rehab for him, because there is no trauma and no frank dislocations for him. First I would try a good rehab, condition his quadriceps, VMO strengthening, and then reassess him after 6 weeks to take a call.
Absolutely. The Bhupesh wanted to say that those people who are non-traumatic, and Kanchanda also mentioned that non-traumatic patellar dislocation, probably your rehabilitation protocol has to be exhausted before. Yes, sir.
They do respond sometimes to a good ITB stretch and also to patellar taping maneuvers in certain cases. So those are important addendums to your conservative management.
Perfect. But this patient again comes to you after 6 months of good rehabilitation. He was saying that my pain has increased. I'm not improving. So what will be your next step, Bhupesh?
I don't surgically operate patients who don't have frank dislocations. So if rehab is failed, then we have to very clearly try and look at what is going wrong. It could be multifactorial, like Vikas sir said, it could sometimes be, apart from this, clinically it can sometimes be because patient has got a very tight IT band and he is bilateral. It can also be because of poor quadriceps conditioning over a period of time. He's been doing excessive workout, running a lot, but he's not conditioned his quadriceps well. If pain is his problem, then I will look at ways to improve his, maybe viscosupplementation or PRP or something like that. But with good rehab, definitely a non-traumatic bilateral type A trochlear dysplasia should improve. Otherwise, we are going somewhere wrong. We have to revisit.
Because, sir, 6 months, no improvement. Patient is begging, do something for me.
Have we done the skyline, seen the tilt and everything? Have we done all those things in this patient? Okay, and if we find, are we finding that at various angles the patella is not tilting?
There was not much of patellar tilt in skyline view because he was dislocating right at the full end of extension. And
so I think the CD ratio needs to be addressed at some point of time surgically if he doesn't respond.
Kanchan sir, what will be your suggestion to this patient?
I'd be very hesitant to operate on a subject like this because his complaint is only pain.
Yes, sir.
And I'd be very, very hesitant to operate on it.
Maheshwari sir, yes.
Well, I'm a little bit surprised that with that kind of a definite bony abnormality, and it is bilateral, it has to be bony abnormality.
Perfect.
And young guy and the petalized J sign there, why you guys are hesitant about surgery? This is one surgery which to my mind is predictable. And what is physiotherapy going to do? When there is a bony abnormality, what will they do? What stretches will they do after it has happened? Because there is a bony abnormality. And if you don't correct the bony abnormalities, what can muscles do? What can stretches of ITB band do? I can understand if there is no bony abnormality. So every patient of mine goes to rehab for 6 months, but if there is no clear-cut bony abnormality, even those with bony abnormality do go for rehab just for my satisfaction. But I know after 2-3 months they come back to me and I have a low threshold for operating, because this is a juicy case where you can correct the bony abnormality and things will be all right. So I am quite surprised that all the three don't want to operate.
So no, Maheshwari sir, you will address the CD ratio, isn't it? That's what you said.
Both. So TTTG as well as CD ratio.
That gets corrected by itself.
Yeah.
The tibial tuberosity.
Okay, I have four interesting cases. We can just rush through because I decided what Maheshwari said. I did a medialization of the tibial tuberosity as well as distalization, and I also did a MPFL since it was in extension. I supplemented with MPFL, and then this is what immediate post-op. This healed in 6 month time, and this is what the patient came to us after 1 year, and then we did same procedure on the other side as well. If you compare both the knees, the gliding is perfect on the right side, but the left side still remains. This was before the second surgery that patient remained. So as Maheshwari sir was saying that in literature also say that if there is a bony or organic anomaly, probably your rehab has to be to preparation for the surgery rather than just a rehab is a definitive treatment for that particular patient. This is another case, a 15-year-old boy, first time patellar dislocation 3 months ago. Because sir, this question is to you. 3 months ago, had a first time patellar dislocation. He was having on and off pain. It was not that much bothering. When he came to us, he had, after 3 months, he had a little bit of apprehension. You could see that there is a bony avulsion of the MPFL, which has been already rounded off. So first time 15-year-old dislocation coming to you after 3 months with this picture. Sir.
Yeah, so I would actually scope him once, I'll scope him and I would have a very low threshold to just go and fix the fracture fragment. Rather than trying to go for a MPFL reconstruction, I would like to reinforce this MPFL back to its original place, and that would be probably the end of surgery. Yeah.
Kanchan sir, how will do this? Is first time dislocation, 15-year-old boy.
Yeah. So if there is a bony piece, I would go and operate. I'll take
Rupesh?
the bony.
MRI?
Yes. MRI?
Do you have an MRI for this?
This was a avulsion. I think, yes, MRI is there, but you can see, I have not taken probably the correct cut, but you can see that there is a small...
My reason for asking for the MRI is simple, sir, because if it is a fresh injury and I see him on day 1, day 2, day 3 within first week, I will go in and fix it. This is 3 months old.
3 months, perfect.
So stretched elongated MPFL is a problem that we see. So if it is a stretched elongated MPFL in the MRI and I'm not happy with the quality, I would do a straightforward MPFL reconstruction and remove that bony piece. But if the MPFL appears to be good in the MRI, then after an arthroscopic evaluation, I might plan to fix the fragment back into
Because sir, you want to say something?
Because see, in my experience, we have done a couple of these late also. So the MPFL, in my opinion, will not get stretched if you have a bony avulsion. It will not really get that badly stretched. So it does retain a lot of its length. So, and if you are fixing, when you are fixing, you do a bit of reefing also. You don't end up just putting the screw there, and it does get tightened up. So I think, again, the procedure for me would be just fix it, freshen up the edges and fix it back.
Even if the patient presented to you after 3 months?
That's what I'm saying, yes.
Okay.
Yes.
Okay, but this was his profile, all the things were normal, within normal everything, except that bony fragment which was seen, and probably We did a conservative treatment for this patient, and then patient improved in 6 months' time, and this underwent a non-operative treatment in our hand. But instead, this is another case, same age, first time dislocation of the patella, presented with this X-ray. I'll not go quiz all of you. There is a small bony fragment which is seen in this one. We did all the investigations. I'll not go into detail. I'll just show you that this was the bony fragment that we are talking about. This is the fragment you are talking about. Patient presents to you on the 3rd day of injury. Kanchanda, what will be your advice for this patient?
Tell the patient, first, surgery, I'll try and fix the fragment if I can fix it, or let it go if I cannot. What was the age again?
15 years,
15 years old, and the epiphysis is open, so this is the kind of fragment we're going to fix it?
Yeah, that is the kind of fragment we got.
We're going to fix it. That's all I'm going to do.
Okay, so probably even there are indication for, going into the surgery even after first dislocation, and probably this is the osteochondral fracture is the most prominent, investigation. This was our older technique of fixation. We used to use a Herbert screw. This is 4th case, 26-year-old lady. Look at the scar. She has undergone 4 surgeries, 2 on the medial side, 2 on the lateral. Okay, give me just 2 minutes, I'll finish. On the lateral side, all 4 failed. When she came to us, this is what she was having, and she was not able to extend actively her left knee, if you see, and she supports her other knee, other leg to extend the knee. And I'll not go into detail of this because this was all discussed. This is what she was having, trochlear dysplasia type C. 26-year-old lady, trochlear dysplasia type C, TTTG marginal, or except trochlear dysplasia, there was nothing. Kanchanda, what you will suggest to this patient?
See, according to Dujour's classification, type C is the difficult one. They feel for type C, deepening trochleoplasty is not what needs to be done. According to them, they still think you deal with the TTTG there, which is not so bad. So I think because you're going to do something, we'll have to do a deepening trochleoplasty here also.
Sorry, sir, what you?
Then we'll have to do a deepening trochleoplasty because all other figures are normal.
Because, sir, you agree, Bhupesh, you will also agree that. So I'll not go into detail. We did a trochleoplasty, very conventional technique. We don't have that burr of arthrex. We do all with this thing, and this is what it looks like after the trochleoplasty and the MPFL reconstruction of this patient. We did a lateral lengthening also, and this is 8 months follow-up, following which we did on another side of the patient also. You can see that she is able to extend, and the tracking was perfectly all right. Final case, quickly, 12-year-old girl, patellar dislocation since childhood, because this is one common group where you will get this patellar dislocation very often, and this is what, the skyline view shows. Or other things were normal. This is intraoperative picture actually. You see that it remains dislocated in flexion, and it's very difficult to reduce as well. So what will be, this is his profile. Type C, trochlear dysplasia in this case, and then TTTG 21. So what will be your, treatment option, Bhupesh? 12-year.
12 years, so this is difficult. So whatever I do, this is one case where I'll be doing a lateral release also, because it's been a very tight lateral band, and so TTTG is 21. I'm sure the X-ray has got a lot of growth in it. So I will try to center the patella and do an MPFL for now, and maybe watch out for the requirement of a definitive bony procedure later.
Absolutely. So I'll just like to introduce a surgical technique which is described by Dr. Seetal Parikh, 4-in-1. That is what we did. Number 1 is lateral lengthening. He said that release is not good, probably lengthening what you have to do. Then tubeplasty. Once you release the lateral side, lengthen the lateral side, the medial side becomes rudimentary. So you cut it out from there and fix into the lateral patella. And then third one is Roux Goldwith, which is equivalent to the tibial tuberosity, to correct the TTTZ, Roux Goldwith, and finally we did the MPFL reconstruction for this patient, and that is why it is called 4-in-1 procedure. And then this is the patient after 1 year follow-up. You can see that we operated on the other side also. This patient, same procedure was done, and she was quite happy with that one. She was having difficulty. So few slides on, concluding slide. Menu a la carte is the important understanding, but what we have to understand that soft tissue correction cannot be compensated cannot compensate the bony anomaly. So if you identify there is a bony anomaly and try to compensate that with just a soft tissue procedure, it is not going to help. And what this a la carte say that if there is a bony problem, do bony correction. If there is a soft tissue problem, do soft tissue correction. And if there are both, probably you have to address the both. That is why this is the menu that I have prepared for you. If there is a patella alta and patella baja, distalization or proximalization, which is very, very important. If there is a trochlear dysplasia, especially type B, C and D, these will require a trochleoplasty. TTTZ distance more than 18, you have to either medialize the tubercle. If there is a femoral rotation, which should not be forgotten, that if there is a rotational anomaly, probably you have to do a derotation. Do not forget to examine for valgus and varus. Corrective osteotomy may be required for that. And pediatric patellofemoral instability is completely different because you cannot do a bony procedure. Thank you very much. I took a little more time, but I think it was helpful. Thank you.
So we will be starting our arthroplasty session. The next session is difficult primary total knee replacement. So I would like to invite Dr. Sudipta Bandyopadhyay sir to chair this session.
So we are from Scopy in the morning, now we are shifting to Plasty. We are already running late. So may I please call upon to speak on complication of UKR, Dr. Debashish Misra. He's not here. So the next speaker should be Dr. Jitendra Maheshwari. He'll be talking about TKR after UKR, when and why, a video presentation.
Well, when and why cannot be a video presentation. So this is just a usual lecture. And I noticed recently the UKR is becoming more acceptable. So I've been doing for 15 years, but lately I find the set is not available in Delhi because it's being done in another hospital. So it has become a popular operation now, and obviously a revision will come as soon as a procedure becomes more popular. As far as the registry data, UKR is revised 3 times more often than TKR. This is something established. That doesn't mean it is a bad operation. Reason is selection and execution of UKR is tricky. When you're doing partial, you have to use your head, whether it is suitable for partial, how to do it, technically demanding. As against TKR, straight away. Do TKR one operation every time the same way. Revision of UKR to TKR is an easy decision because patient is not happy, you don't care too much and then say, okay, I will fix it. And do a TKR, which is a relatively easy undertaking with your experience of TKR of all kinds. Now revision to UKR to TKR, on the femur it is mostly primary. You can put a primary femur there, no problem. On the tibia, usually augment is required. It can be a stem only or it can be sleeve occasionally, but usually stem. Constraints are rarely required, but sometimes yes, if it is an old case or infected case. In 30% of revisions from UKR to TKR, you can actually get away with just primary components. But I have a low threshold of using augments because revision is a revision. I don't want another operation after that. So this is one study where they said compared to UKR to TKR and versus primary, you use more augments in this, of course, because this is a revision surgery compared to primarily. So it's not as good as primary, but quite close. And some of us who work in this part of the world, we know our primaries are not like that. Our primaries are all something in between. So we deal complex primary, which are more like UKR to TKR. So it's not a bad revision, I would say. So this is my collection. I did this in October. Till that time, out of 317 UKRs I had done in 15 years, obviously it was growing slowly. I revised myself 8, and some of them may have been revised by somebody else, I don't know. And I reoperated in some cases. So about 5% of my patients were unhappy, reoperated or revised. 20% were not satisfied, but they were quite okay. And definitely 80% were very happy. And this very happy word makes me do UKR more and more. So it's a wonderful operation. When it works, it's like no operation. Patients are very happy. So those who are happy are very, very happy. Those who are not happy or converted to TKR, it's not a bad operation. It's one of our routine complex primary TKR. So I'm not much worried in case I have to tell them, okay, I'll fix it and I'll do a TKR. So that is my current understanding. Now revisions for UKR to TKR are simple. I think this is what book says also. Progress to another compartment, dislocation of the plastic because they do mobile bearing, loosening of the implant, infection again continues to be a major reason in our practice. So this is usual anywhere in the world, those are revision. Now what are the issues when you do revision from UKR to TKR? Loss of bone stock because you have to remove the implants and uncertain soft tissues. You have to balance. That's the basic principle of knee replacement. And I'll go through some of the tips how if you have to do a revision from UKR to TKR, you have to take care of these things. Remove implants carefully because you want to use minimum augments. And if you do implant removal carefully, you may end up doing a primary TKR and not need augments. So this can be possibility. It can be a contained defect because take out the tibia and no problem because you can just fill up with bone graft. It can be slightly more and you can use a smaller augment and it can be more depending on what kind of the reason is. On the femur side, usually the defect is not much and you can do away, take all this in your cuts. So how to build up tibial defects? Depends. If it is a contained defect, which very often it is, you can just do a bone graft and use a primary tibia. I of course have a low threshold. I sometimes use stem even then. And usual scenario is this, when you have a step cut more or less, you can use this and leave it without a stem, but I do use a stem even there. And very often when it is infected or bad or old case loosening, a lot of things have gone, I have a low threshold again for using augment like sleeve. I don't want a failure after a UKR has been revised. So one of my own cases, arthritis progress to lateral side, so you don't diagnose these. Keep coming with pain because I have the advantage of doing scopes. I scope the patient and realize that he has developed lateral compartment osteoarthritis and then we had to convert it. It was more or less a normal TKR with maybe a stem because there was a bone defect there. Another case study, this lady, I did a bilateral TKR and she was doing quite well. This was the immediate post-op picture. She was doing quite well for 10 years and then she started complaining of pain on the right side and I could see right tibia it getting loosened. So I had to advise revision and this is what we did. We used a bone graft. I added a tibial stump. So basically quite a standard TKR we are all used to. Our TKRs are not Western TKRs, they're like this. Use augments more often than they use. On the femur side, not a problem. Usually all these defects come in the cuts, but you can use the augment posterior or distal depending on if you have to do it. So you have to take care of femoral alignment. Like anywhere where femur is damaged, you have to take care of this. If it's a valgus knee or a varus knee, rotation issue comes in, where do you cut? So you keep the implant there, put intermediate rod and cut it. And then something is left here. If it is included in the cut, no problem. If not, you can sometimes have to use a distal bone graft or distal augment. Similarly, sizing. You have to use your jig properly so that you don't undersize because posteromedial condyle is defective. That part of the jig will not sit properly, so you have to be careful about sizing. And same about rotation, we all know it. When one of the condyle is damaged, you can put the implant in malrotation, whereas medial rotation or outer rotation that we understand from our valgus knee issues. Now constraints are sometimes required and this all depends on what you have done. This is a patient where I did a uni compartment and the plastic decided to move out and this was the biggest plastic I had put at that time And it moved out. I didn't have the bigger plastic, so I told them, get me another one. They took 1 month to get it from UK, and by that time it was bone on bone, and I did change, and I took the patient in, and I found there was so much metallosis because of this in the waiting period, so I had to go in and revise it with a total knee, and I reconstruct because the MCL wasn't look good, so I actually reconstructed the MCL as well. Again, use of constraint, another one, bilateral uni done in a 55-year-old. This time, unfortunately, got infected, and we had to do a 2-stage revision. I had to put a hinge because when you do a 2-stage revision in infection, you are very merciless in your first operation of debridement, and you take away everything. And I am very, very aggressive about removing collateral or whatever. I don't care, but my infection should go, and I don't mind using a hinge or any serious constraint in that process. My enemy is infection, nothing else. So to summarize, revise UKR to TKR early. I hate to revise my UKRs, but if I have to, I rather do it early. It's an easy revision. You don't need too many things. Use appropriate augments. I have a low threshold for using augment because I don't want another revision. Be careful about malrotation because of the damage already. We all understand that. Use appropriate constraint. Again, low threshold for using constraint in case. Despite higher revision rate, uni remains my favorite operation. The reason is those who do well, they do very, very well. Those who don't do well, it's a easy TKR. Only problem is to convince the patient for another surgery, but I know this patient is not going to be disabled for the rest of his life. Even if I have to revise to a TKR, it's not a big deal. Thank you very much for your attention.
We are running short of time, so we'll be taking the questions in the end of the session. So now, may I call upon Dr. Swarnendu Samanto and Dr. Maheshwari again for the debate. He'll be debating with him, sir. He'll be on the stage and he'll be...
No, I think his presentation will be coming there.
So the debate is between the high tibial osteotomy versus unilateral knee, unicompartmental knee.
Good afternoon, friends. So I think the debate is whether you go with the HTO or the UKRs. I think Maheshwari sir quite senior, so I cannot attack him full blown, okay? Because in his lecture he already told that in 317 UKRs he has revised some of his own, and probably if you revise some of your UKRs within 10 years of time, I think you have to revisit it. So basically, whenever there is unicompartmental disease or there is some sort of malalignment, probably you have two options. One is you can do with the HTO, or else you can do with the UKRs. From last 2 days, probably we are talking about what is the mechanical axis deviation, how to calculate and all this, the LDFA or the MPTA. And before choosing your HTO or the UKRs, you have to check all these, your long films, the standing CT scanograms, and you calculate all these because it's hardly 87, 88, 89, and 90. It's not a very complex mathematics. So even in HTO, probably if it is unicompartmental, you realign your axis. In UKR, you resurface it. And UKRs, Maheshwari sir will all agree that when he does his UKR, probably he leaves these knees in 2 to 3 degrees of errors. Agreed, I think. So I think me and Maheshwari sir will agree in one point that both goals are the same. You have to reduce the pain, restore the function, and improve the quality of life. So ideal indications of doing your HTOs or the UKRs are more or less same, but if you read the first indications of the HTO, the thing is that you have to select the patient who are quite young and active patients. But I think when Maheshwari sir will be talking about the UKRs, the indication of, if you remember, you have to be very cautious when he will be presenting his age group. Probably he will agree that it has to be more than 65. So I think in Indian scenario, if you are seeing a patient of 65 plus, probably in our part of the country, we deal with mostly the tri-compartmental disease not suitable for UKRs. That's why probably my UKR numbers are very less, probably very, very less. So you have to have the normal range of motion, you have to have the body mass index very low, less than 30, and no patellofemoral arthritis. I think in this podium, in this hall, they have to think that how many of the guys, those who are opting for any operation like HTO, UKRs or the TKRs, they don't have any disease on the lateral compartment or something, not anything under the patella. Good range of motion, stable joint, expanded indications like if you have gone through the first days of the London osteotomy course, that even you can do the HTOs for your many ligament problems, your ACLs, PCLs, the triple varus deformity and everything. The HTO is really a good operation for the young people. And unicompartmental knee arthroplasty is superior to high tibial osteotomy treating unicompartmental arthritis. A meta-analysis was there. But I have highlighted that part. Valgus HTO provides better physical activity for younger patients. So if it is less than 60, probably HTO is still holds good rather than having the UKR. I think it is quite industry driven. High tibial osteotomy versus unicompartment knee arthroplasty for medial compartment arthrosis with kissing lesions in relatively young patients. If you go with the different studies, HTO might be good alternative for UKR. I think I think he has to really defend himself how he does his UKRs. And open wedge high tibial osteotomy shows an improved indication for active patients. So when we are doing the HTOs or the UKRs, we don't talk of the tricompartmental disease. We don't talk of how the patient is going to go ahead with the walking on the floor. Rather, we'll be talking about how the guy is going to do something like cycling, marathon, or some sort of sports when you talk of the UKRs or the HTOs. So there is a long, if the HTO, if you go, this is the classic landmark study by Fetcher, that 85%, more than 85% survivors are at the end of 20 years. So probably Biosoris in his talk has told that he has revised the UKRs less than 10 years of time. So I rethink what he is going to defend. So alignment goals are like your adverse age, your over and under correction, instability, severe arthrosis. These are all having the unfavorable results when you do your UKRs. This is a very complex slide, but you don't have to look anything on this. But if you go, this is a very basically this study is because of your UKRs, how you compare the UKRs with the HTO results. But if you read this article, you will see that most of the long-term follow-up, it is more than 10 years, the UKR will supersede the HTO will supersede your UKRs. So the mean functional score of HTO was 71 in HTO group, and it is 59 only for the UK. So our average range of motion for HTO is 117 and 103 for UKR. Probably he will tell the other side of the story that UKRs are having better motion, but this is not true. So another one study with the surgery for this study, younger people HTO seems to be better choice for UKR. So I am not quoting you because this is a point, I am 2 minutes left with this. So many studies, if you even read the articles for the revision of HTO to TKR, primarily when we did this, the Coventry sort of thing, probably people were telling your revision from the Coventry side, your staple and everything, you have to two-stage, then you don't have the offset stem on the tibial side. But nowadays, because your stem is probably going to hit something on the medial side, it's not true now. Because we do have the offset stems now, we can hit the middle of the tibia. So I think this is not going to hold good, that the revision from the HTO to a TKR is a very complex scenario. This is not at all complex. So revision of totally arthroplasty after failed UKR, the longevity of that part also is very, very poor. Because remember that revising a HTO to a TKR is a much simpler operation than revising a UKR, though he told that you can have the cuts and you can fill the voids, your grafts, augments, but this is probably I think you have to rethink. I think it is completely been driven by the industry. So I am not going to perplex you with convince you that he probably will be coming to convince you that UKR is much better, but you have to be rather give your 100% when he presents his talk. So return to sports is much, much better with the HTOs. So to conclude, it should be considered equivalent, it should not be considered like HTO. Correct patient selection, young people less than 60, probably if you sell your UKRs, probably you are not selling the right thing to your right patient. Thank you very much for your kind and patient hearing. And thank you, Jiten sir, for coming and joining for this debate.
And a half day of London osteotomy course, it's all osteotomy here. I'm quite sure I'm on a swimming against the tide, and then with Samantha being such a good speaker, so I picked up a few points right away before I start my talk. The indication of UKR that you mentioned is about 25-year-old. A lot of water has flown under your Havra beach since then. London osteotomy course, of course, is important. Younger patient. Now, what is a younger patient abroad is not a younger patient here. It is all activity. Our patients usually are low active. So let me right in the onset say disclaimer that my practice is based in South Delhi, where most people are low-key patients. Maybe I'm not talking the same about a patient in Bihar or somewhere in the village where, yes, UKR may not be the right operation. So let me have that disclaimer. Then, third is, revision is a, so I think I'll come back to the talk because first is I'm not a joint replacement surgeon. So I'm not fanatic about replacing joints, nor am I fanatic about preserving joints. So today I'm a member of two WhatsApp groups. One is joint preservation, one is joint replacement. And the same case, joint replacement, joint replacement. So I'm none. I'm a knee surgeon. So for me, I do what patient needs. I can do everything. UKR or STO, this is an everyday debate for me, not here. Every patient that I see, I ask myself, should I do this, should I do that? And I have my own algorithm, how I decide, maybe some other day. My spectrum of surgery, January to October last year is this, 144 TKRs and 43 UKRs, and I do 27 STO in a year, more or less. So I'm not against STO, but there's a clear reason where I do STO. My heart goes out for STO actually. So I've given up already this debate because I like STO. I think it is a good operation. It is a very logical operation, but, big but, it is just too complex a procedure for me. I do everything. One operation I'm still dreaded, and there are courses after courses after courses on STO. How many people have started doing STO? I asked Synthesis, sorry sir, number nahi badh raha. Too many techniques, sorry, wrong spelling, too many techniques. Open wedge, close wedge, this plate, that place. Too many fixation devices, tibia alone or both. Now new thing has come up. You know, you should do both. Calculate. Do on tibia femur. TCVO, a new kid on the block. They say don't do STO, just do unicondylar. Amazing. And bilateral. How do I do bilateral? I'll tell my patient one surgery, then after 3 months, then 6 months again come back. Doctor, what is this? Longish rehab. And most importantly, unpredictable results in my hand. I don't know which osteotomy patient will be happy and which will not be happy, which I know about unicompartment. 90% of my patients are very happy. Some of them are unhappy, but they remain like that, and only about 5% need revision. So my average UKR patient incision is this. First day this, second day he's standing and walking. After 2 weeks he's walking without any support, and the full range of movement he gets. That's the kind of patients I see. I'm sorry, I'm again saying this is not representing the whole of the country, but that's the kind of patients they want improvement like that. It's a very logical option for me. If you have a disease localized to one compartment, what is the disease? The cartilage has worn out. Just put the cartilage there. Why do you want to bother about realignment and blah, blah, blah? You are, looking at things from the other angle. Yes, there are downside, and I know that those downside you should not do it. So uni is more or less a forgotten operation. You ask those patients, do you remember you have had an operation? No, you're doing everything. And I can pull out a lot of literature in support of UKR as you have brought in support of STO, and literature really confuses you. So uni is superior, it lasts longer, convergent TKI is simpler. So you can, what literature, you can find out in a debate any literature. Now what is bothering me in my practice most is this. Patients do not like valgus gait after STO. The pain is gone, but they don't like the STO. And we know in the TKR world, we are moving away from mechanical alignment. Perfect. TKR is such a perfect operation, but the patient don't like is after TKR, pain is gone, but their kinematic alignment is not there. They're not happy. So this is one of the reasons for STO why I think those patients are not happy, despite the fact that their pain is gone. We do have an anecdotal example. Every time, oh, there's an orthopedic surgeon in Mumbai, you know, I mean, you all know him. He had an STO and he was playing, you know, tennis after that. 20 years have gone, everything. I have n number of orthopedic surgeons who have opted for uni-compartment replacement because they say, डॉक्टर साहब किसके पास टाइम है इतना 2 महीने 1 महीना क्रच लेके चलेगा फिर दोबारा कराएगा फिर दोबारा कराएगा ऐसा करो फटाफट काम होना चाहिए Is age a criteria in my practice? It is not in criteria. I see if it is only uni-compartment replacement or disease, patient gets a uni-compartment. In my mind, I say, this is a typical patient on the table of uni. Bone against bone, rubbing against rubbing. It's like a ball. It has been rubbing for some times. It is a mechanical problem. Cover it with something and the pain will disappear. Typical mechanical problem. Uni-compartment, confirmed uni-compartment because meniscectomy. 70 years of age, the rest of it is normal because he had a meniscectomy and I know it is only medial compartment osteoarthritis. Did this, lasted very well for 14 years, is still going on. So severity of uni-compartment OA, bone on bone is not now my indication. I do it even without bone on bone because a lot of these bone on bone so-called on the left hand side, even right hand side are bone on bone. You go, you scope them, they are bone on bone. You do this flexion view, they are bone on bone. They may look not bone on bone. So in my practice, if the bone is raw on both sides, femur as well as tibia, uni-compartment becomes the indication. So are there situations where I still prefer STO? I will tell you I like STO because it appears a very logical operation. You know, I mean, patient friendly and what do they call it? It is a natural operation. Don't put any implant. I do it in obese people, in those with severe patellofemoral, not with mild patellofemoral. If ACL is deficient, I still hesitate. Though literature says you can do uni-compartment, but those are the cases where I still am not bold enough. So this is a very important slide. I do STO more often because if I know as the operation will fail, and every operation can fail. For example, in an obese person, I will rather do STO because patient can live with suboptimal results in STO. They cannot live with suboptimal result with uni. So it's a point in favor of STO. You are talking about revision. Revision is not criteria in my mind of success. In my mind, patient's happiness, satisfaction with the operation. Revision from STO and to TKR will never happen. Patient will never go for surgery. But was he happy in the first place? No, he was not happy. He was going on with pain. So this is the only point in favor. If you want one operation for your patient, doesn't want to come back, poor patient, yes, do STO. Even if he is not happy, he will not come back to you. So this is a broad comparison between STO and UKR. Preserves natural knee, sounds very, very good. I'm not bothered about that concept of natural knee or unnatural knee. I want my patients to be happy after surgery. So that's a point. It semantically appears very good. And then a lot of other things are very much faster, everything. Restriction, yes, in UKR, and of course, any younger patient playing sports, you cannot do a UKR. And if it fails, these are the two main negative factors against UKR, I take it. So to conclude, I'm more inclined to do UKR because it is a patient-friendly operation, quicker recovery, bilateral, same sitting, very, very, very important thing. And it is more predictable in my hands. I do prefer STO even today. Active, sporty, young people. In that literature, young people are, they're doing skiing and everything. My patients are not active, sporty, and young. Where in doubt, I do STO. Obese, I do STO. ACL deficient, I still do STO. So I think it's not a question of being fixed to one idea. It's a question of what can give best result to your patient profile. And my patient profile is low-key. They may be young, but they're inactive, and they want a quick result. They want bilateral same sitting. And in my hands, uni works very well. Thank you very much for your attention.
So, thank you. So to conclude, both HTO and uni both are good operations for almost the same group of patients, but
only 10 seconds. 10 seconds for the rebuttal.
Rebuttal.
2 minutes for each. 1 minute.
No, I will take 1 minute. Okay. What 30 seconds? Chulbe eta?
I think what Maheshwari sir was telling that, giving some information that UKR is better than the HTO, but I think still you have to take your right hand on your left side. You should feel your heart, what supports. I think in this hall, who has done more UKRs than HTOs? Rakesh? So still the HTO people, they are doing much more. I think this small video clip, what me and Maheshwari sir was doing, he was trying to impose, because you see with the white shots, he was trying to impose you something with lot many data, lot many things. I was sitting idly here because we doing some exercises, giving some referrals, just need one punch that HTO is much better than the UKR. Thank you.
I don't have a video to compete. I will bring next time. Or maybe who knows which is STO and which is UKR? Who knows? So you're claiming that guy is STO, I'm sorry, that's UKR. But I think the point I want to make is the biggest fallacy of surgery is taking revision as a benchmark. Okay, I did 100 operations, they were not revised. I am asking how many out of 100 were happy. That's my basic criteria. They don't go for revision because they don't want another
For you,
surgery.
it has been run twice.
No, I'm saying the other guy is actually UKR, the fat and big one. Okay, so now revision is a poor measurement. When you put statistics, two things. Younger patients, younger active in the literature in Europe are 70-year-olds, they are doing skiing. My 50-year-old do done nothing. They want 2 surgeries, 2 times. Doctor साहब चला दो बस, हम ध्यान से रखेंगे इसको, कभी भागेंगे भी नहीं. Actually, that's the kind of patients we have. So our clientele is different, they want different results. Number 2, revision is not the criteria of success. If you have not revised your case, doesn't mean 100% of your cases are happy. So I'm looking at happiness, patient-based criteria of success, not surgeon-based, which is revision. I don't agree with the criteria of revision as a measure of success. STO will not get revised because they will keep on going with a painful knee rest of their life. UKR will come back for revision because they want to be all right. Thank you.
Sir.
Thank you.
So there is a little change. There is a little change in the schedule because our patient is ready in the OT for the live surgery. So we are we'll take the questions in the end of the session. The session will be continued after the live surgery. So it's a break for the live surgery. Then we'll continue the session.
So we are continuing with the live surgery. Surgeon being Dr. Karthik Shukla. I would like to call the moderators, Dr. Ovik Roy and Dr. Atul Srivastav, to kindly moderate the session.
Okay.
Yes.
Karthik, can you hear us?
Yes, we can hear very well.
And is Darshan also there?
Yes. So we are audible?
Yeah, you're audible, Karthik.
Okay. So let us start with the X-ray first. This is the X-ray. I would like to have a look at this. 50-year female with medial compartment bone-on-bone arthritis on both the sides. Left is more involved, left is more symptomatic. To add on to this, there is a little bit of tibial translation as well, if we can appreciate on a standing X-ray. Unfortunately, we do not have a valgus stress view to show the correctability. That we'll just demonstrate before we start the surgery. So I think if there's anything we would like to debate on this, like HTO versus uni, we can still do here. But I think we are just going to demonstrate a partial knee, mobile bearing, rather I would say meniscal bearing design, which mimics well function in a history with a long track record as well. So can we start the surgery now?
Yes, Karthik, I think you start.
Okay. So the surgery is always done in a hanging leg position. I always prefer it, which is gravity assisted position. Tourniquet is always on because you cannot see anything when the tourniquet is not on. So there is no debate like TKR whether we can use a tourniquet or not. Always a tourniquet, proper tourniquet, hanging leg position. Make sure you have a free flexion when you have this position. Your popliteal fossa is not having a pressure by the stand. So the stand is in the mid thigh. So we can use a marker if you have.
Karthik, would you do a STO in this patient?
No.
Why not?
I don't know it. I don't know STO very well. But I definitely had a very good satisfactory results with this procedure as well. I think what Dr. Maheshwari said, I personally believe this is most predictable surgery. So with a good result for a long duration. STO, I am not sure about the outcome longevity, like when the question comes how long my STO will survive. And when you do this, you can in future, if at all need, easy to revise this knee with a total knee. So this is just a marking to show the patella. This is the tibial tuberosity. So there are ways you can put either straight incision or a little bit of curved incision. I personally prefer a little bit of curved incision from the midpole of the patella to the tuberosity. So this is the incision you need. You can always extend if you want on a higher side. You can feel the medial border of patella here very well and the tuberosity. So just a retractor, fine. Small arthrotomy you need here. This is the medial patellar tendon. So this is surgery is beautifully done when you understand the mobile window of a soft tissue. So when you extend, you will have a different view, just like in THR. So this is only you need this much patellar movement you need. You don't need to subluxate the patella. You don't need to dislocate. A little bit of fat pad, which just comes in front of a way, needs to be taken. That's it. So you can see the front of a tibia very well, I think. We don't need to release anything. Actually, just we need to put the zig here. That's it. No osteophytes is present medial in this case. Otherwise, you can take this. This is a little bit of fat here that I would definitely like to take because it will affect my gut. So that's it. That's the whole exposure we need.
Dr. Karthik, in the X-ray, it was not bone on bone. Now
I will show you with us. Definitely, this is the biggest problem because this is not a varus stress view. So I'll just apply GLP, and you can see the horrible condyle. So everyone will say, oh, now the question comes to me, what about the STO? Like, would you do STO in this? This is the biggest thing that you can see. See, there is absolute no cartilage, gross loss of cartilage on the femoral side. Why not uni? See, that's why you need proper radiological evaluation and correctable varus.
So, can you
anyone
also show
wants
the
to see the ACL? Beautiful ACL, lateral compartment, beautifully seen, no cartilage loss, and you can see the trochlea. Trochlea is sometimes affected with a little bit of fibrillations, but I had never seen anterior patellofemoral pain in patients of uni. At the end, we will show the patella as well. Let's remove this. So this is the retractor all the time used to protect the MCL. We are here to take only medial meniscus from the knee, nothing else. No soft tissues we are going to touch. Now this is most important instrument, the spoon. So all the time people consider this is for sizing. It's okay, you can use it for size, but that's not the whole idea. The whole idea is to balance the knee as your ligament permits. Obese female patient, you need a thicker spoon. Bone loss, you need a thicker spoon. So that's why it comes in 1, 2 and 3 millimeter. So how to decide which spoon to use? So put a spoon. This is an average female height, So it is always small. So the simplest way to remember, life begins with a color code. So all females, so the girls are pink and boys are blue, easy to remember. So it is always red. Every instrument on the trolley is
He
red.
can't see that, no?
You just, pardon?
No, it's okay, Karthik. We've seen some
Okay.
better X-rays now.
Okay, so just now you can just toggle it. So this is fine with me. I would like to tell you that this is a time of a surgery worth spending. There are 48 ways you can cut the tibia. So you can plan patient's profile, patient's body weight, BMI, bone quality, and you can play with the system. So if suppose I would like to go for 2. So what will happen, it distracts my tibia a little bit more, so I will cut less tibia. The whole idea is I would like to cut less tibia. I think I would definitely go for 2 in this patient. I would like to cut less tibia. Now come the tibial jig. So this is the tibial jig, beautifully designed. So the whole idea of this instrumentation, that surgeon has a freedom only in the coronal plane. The sagittal plane decision is always done by the instruments. Because in TKR we had witnessed, we always talk about the coronal plane because we have only 2 ligaments left. So no one pays attention to the sagittal plane in total knee also. So this is very thoughtful that the sagittal plane is not your cup of tea. So I will just put this clamp. It comes in 2, 3 and 4 depending on the implant you want to put, the bearing you want to put. 3 millimeter is bone preserving, 4 millimeter is good for larger knees. Only 1 pin on the lateral side, far away from the knee, so not to create any stress risers or anything. So on the ankle, we are in the center. Now the question comes, we can be here, we can be here, we can be here. So this is the only area where we can be, hardly within 5 degrees, varus and valgus. So it doesn't make, this is a ball and socket joint. Ultimately, we are producing a dual mobility hip within a knee. So whether it's a 41 degree abduction or 46 degree abduction in total hip doesn't make any sense. And the slope is determined by the instrumentation system, which is always inbuilt 7 degree. So it is not we have to apply our mind in this. So see, the bone which we are going to remove is very less. This is the only cartilage and little bit of bone we are going to take out of this. Now comes the second. This is my ACL, and just medial to my ACL, I would like to cut my tibia. So initially, if you want to be sure, you can use a cautery, mark it very well, because this is a slopey surface. So you put your saw here and you are pretty sure that you are cutting here, it slips here and it cuts here. That's why you will end up in a small tibia, which will be painful, having impingement and everything. So make sure you have a very proper tibial cut. So and second important thing, don't cut it like this. You will cut more posteriorly. Flush with your base plate. Done. So my vertical cut is done. I'll remove this shim. I can use the same shim, but it is non-slotted, so my blade can skive. So I will use the slotted shim without altering anything. Now let me confirm the placement of my curly wurly. This is beautifully hold towards the ground. Nice. Done. The second cut. Done. 2 cuts are done. This is the most crucial part of a uni, because your tibia is terrible, femur is fantastic. So tibia, you have to spend time. So the tibia has come out.
So Karthik, with these jigs, how sure you are that you're aiming for 3 and you get 3 mm out?
Pardon?
How sure are you with these instruments?
100%. 100%. Every single time you can play with the soft tissue. See, that's why we will discuss it. There's a 48 ways. The important thing, you have bisected the tibial eminence, means you are good. Your sagittal slope is good.
Can you show the tibial damage, Karthik?
Pardon?
Just show the tibial damage where it's worn out and
Yes,
where the cartilage is still
exactly. So this is again a full thickness cartilage loss. Anyone can see this?
We can't see, Karthik.
Okay? This is the full thickness cartilage loss.
Right, we can see it now.
So this is the tibia. Yes, I'll just make it little flat, release it, relax, just keep it there, relax. I can use the tibial cut to size my tibia, but believe me, it is so reproducible that in 95% of female, what we had observed, that it's a small femur and B tibia and the 3 bearing. So now this is the most important step. Now you have cut the tibia. Now you want to check whether you are okay or not, because most of the time the people will realize at the end that they are too tight and the poly is not going in. So this is a femoral drill guide, small, red color. So you can use this and put it, slip it. I feel it is little tight. That is meniscus. Just give me the curly wally, please. And you just need to retract it a little. That's it. Just hold it, don't stretch it. I am able to put this in this simple way. It should go like this. If you cheat yourself at this stage, you will suffer at the end. There are 3 ways it will go. We will discuss this in a lecture, but it should just slip in. That's the perfect way, because if you forcefully put it, your bearing will not go at the end. Believe me, it will not go, and it will stretch your MCL. So I am very happy with my flexion gap. So actually the surgery is over. This is the only step we are worried about. Now rest is done by the instrumentation system. This is the notch. This is the lateral border of a femoral condyle. And you can put it anywhere. It is not like absolutely you have to put it here. This is the area. I will just show you. Let me put it and then I will show you. You can widen it and direct it toward the posterior and lateral side. That's it. So let me show you the entry point. So this is the entry point. Lateral border of a medial femoral condyle, 1 centimeter above. Use a rod. Never hammer this. It should slip in with your hand. Otherwise, you will definitely perforate the femoral canal. Now let us mark. The coronal plane, you are given a freedom as an orthopedic surgeon. Sagittal plane, in this system, you do not have any freedom. So rather than putting a line, I will mark the middle 1/3, because that's where exactly I want to be. So medial 1/3, middle 1/3, and lateral 1/3. These are the 3 parts of the condyle. I'll just slip in. You can see this yellow mark, and there is also yellow mark which is not there, but yellow to yellow, you have to match. Flex the knee and it goes in. That's it. Now the freedom of flexion and extension is gone. Varus valgus is gone. It is always 100% time reproducible with 10 degrees of flexion, because it's a high flex knee, and 7 degrees of valgus. That's it. The only freedom you can play is coronal plane translation. So I'll check it. I'm fine. Now this lock is done. Now I cannot do anything. So everything is stable. I'll just confirm. I'm fine. So he has just removed, because go halfway, remove it, because the bone slurries can widen this peg hole. So go halfway, remove the drill bit and go back again. So now I am done with the peg holes. So this system is the only system in the world which starts with a genuine philosophy that anteromedial osteoarthritis is a disease of extension, and my flexion compartment is virgin because it's a flexible varus. Let's cut the flexion compartment first and reproduce it in extension, which is a diseased compartment. So now this is most important. This cut is not given the advantage or the importance of the problem that arises. This is an open box design. So if you cut it like this, your flexion gap will reduce. You had checked everything, and then at the end you realize that now you are too tight. What mistake you would have made? The mistake that you have not done a drop hand technique. You have to drop it and cut. And always the curly wurly is inside. Done? Rocket, please. Again, whenever you take this, this is not a good instrument in a way. You have to lock it and literally use a force, otherwise it will fall on the ground. If you are doing bilateral, you will be in trouble. Remove it like this in a one stroke. If you try to be modest with this, it will fall on ground. So this is the posterior condyle. So this is the posterior condyle. It is having the same thickness as the implant, 3 mm. That again reconfirm that I am fine. Again, still, I will always use a little bit of bone file to make sure. Now imagine if you have not cut this proper, when you put anything, this hole will become oblong because this surface is a steady landmass and everything will reduce your flexion gap. So you are in trouble. So basic cuts are done. I will use the first spigot as a zero spigot. You can use a hammer here. Remove the curly wurly. Now this really is very helpful. You need this instrument all the time. All this. Okay? This is the Miller. So our first attempt is just to make this multi-radius femur into a single radius femur. We are not doing anything else. That's it. Let's remove this. Anyway, we are going to cut the corners only, not the distal femur. So this is done. Okay. Section, please. So now we are going to cut the meniscus, which is already quite degenerated, torn at multiple levels. Fine. Let me reapply this. Now always make it little anterior. So this will help you to start with your anterior portion. Hold this. Do a little position. Fine. So we'll start with the anterior horn and the anterior meniscus. Be very precise, not to go in a soft tissue. Just take the meniscus out, because that is the pathology. The whole idea actually in this surgery is to reproduce the meniscus. Biologically, if we cannot implant it, let it be the best engineering possibility. And the implant, this implant was never designed as a uni. If you see the history, it was designed against the wear. So they put on both the sides initially when they started, and then they move on with the realization that it is used for one side as well. So I will take the meniscus carefully. Okay, action please. Done. Sorry. That's okay. Action. Can I have a little light as well? I want this on this side, little on this side, your side. Yes, perfect. That's okay. We are good. Okay, that's it. That's it. I can curve the cartridge. That's it. Not grabbing. Okay. Fine. Fine. This is fine. 1 minute and we will be done. Okay. Now this is better. Done. Wash, please. So my flexion gap, everything is fine. Yes, now you can take this posteromedial. Okay. So I will just reconfirm with my perception of this. So I'm very happy with the 3 size bearing. I will use little bit of file here to make this little smooth on this side. I am fine. Not much. So this is a B size bearing tibia. Let me hook it at the back. We are always good. Put it. So most of the time 95%, 90% in average female, it is small b and 3. In tall female, you can have small 3 or 4 as you plan. Now we will prepare the keel. Hold this. That's it. Actually, I have done this because I think the tourniquet is applied since this anesthesia is applied long. You can do this at the last also to see your impingement and range of motion. That is your thought process. Because if you are fine, you are good with your keel and everything, you can prepare this at this time, or else you can do later as well. So this is slotted tibia we have used as a trial now. The microscope, if my microscope goes like this, it's a 3 millimeter bearing. All the time you have visuals and tactile feedback in your surgery. So trial femur in, trial tibia in, remove this, no retractors inside the wound. And then we'll check the balancing. So let me start with the 2. Just show you. This is the 2 millimeter. So anyone can make out this is loose. 4 will not go in. So this has to be 3 millimeters. 2 is loose, 4 is tight. So it has to be a 3 millimeter bearing. This 3 will give you a 3 feeling. See, I personally feel I'm still little tight. Still little tight there. Because this is flat. When you put a curved poly, it's more congruent. So I'll just take a bone file, half a millimeter. This is about within a millimeter we are talking. The precision within a millimeter. If I do accept this, it's fine. It's still okay. But still, this is still 1 millimeter will give you a 0.3 millimeter precision on your finger type. That I am little loose, I am good, I am little tight. 4 is not going, 2 is loose. See the precision this system can offer you. And because that's why you can trust, see my 1 is not going. So let us understand, my flexion gap is 3, my extension gap is 0. So I have to go 3 millimeter more proximally to recreate my extension gap. That we will do. Galti. I will definitely strive for little 3 millimeter and in between. So I will definitely use a little bone file. That's it. Nothing more than this you need. That's it. So this is 3. So my whole idea that I will never overcut. So I will do 3. I may be still tight in extension, I don't know. But I will go very carefully with a 3 minus 0, 3 millimeter. If I will be tight, I will do it again. No problem. The whole idea that once you are large in extension, you have a miserable day. So just reproduce your extension gap as per your flexion gap. That's the whole idea. Step by step. Fine. Wash please. Again we will check. This is a meniscal bearing design. So there is nothing except ligaments and soft tissues to hold your bearing. So you have to be very precise. And the precision is in instrumentation. You don't need to bother for that. Only thing you have to use them correctly. Understand? Oh yes. So nothing has changed in flexion. So it's 3 flexion. Let me start with the 1. It was initially 0. Let's start with 1. So 1 is loose, so we are good, okay. 2 I will accept. So 2 may be a little loose, I think. It's little valgus, yeah, nothing. No? So I will accept this. This is a beautiful feeling, and 3 will definitely not go, that I tell you. See, 1 is loose, 3 is not going. So I just need to go for 1 more millimeter. So I will add 1 more millimeter to the last picket. That was I used 3. So now we will do 4.
So Karthik, what's the explanation for this?
Pardon?
So what is the explanation for this? That you had 3, 0 minus 3, 3, you did 3 and still it doesn't go.
Yeah, because this is variable as per the stages of arthritis. If there is a bone loss, I would have just used a 0 spigot and I am done. The whole idea is that you should never do something which increases your extension gap. So my flexion gap was 3. I used 3. At that time I was 0 or less than 0, maybe -1 or -2, I don't know. So I will be very careful. I will use 3. I will check again, and now I will use 4.
So I think this does happen to us from time to time. So it was not 0, it was actually -1.
Yes, yes.
Did you get that? So it was
No,
actually
precisely.
-1.
See, you can see the 1 millimeter collar. So the instrumentation or precision in within 1 millimeter.
You can't measure anything less than 1. No? That's the minimum.
So 1 millimeter we have done.
So
It's done.
basically it
It's all
was
good.
-1.
Jalpi. Will you use anti-impingement? No. So now we are going to produce a complete ball of a femur through wonderful anti-impingement guide. So since this system is flooded with the technology, only thing you have to use it right. You don't have to apply mind. So this is anti-impingement guide. Again, it will do its job automatically. This is posterior impingement. It won't go in. So there is nothing like vessel injury or anything. It's done. Now my femur is complete. We will do the trial and we are ready with the implantation. So there is no posterior osteophyte in this. So let us put a trial tibia, which is a slotted tibia, double pec femur. Remove the retractor. 3 millimeter bearing, please. It has to go with a hand. Most of the time that's a problem. There is an instrument given. It is for the removal of a bearing, not to be used this side up. So this side up. But you are not supposed to use this instrument to put your bearing. That means you are tight. You are painful uni. And then someone is always ready to revise. Waiting outside the hospital that let me revise the uni. So don't use this instrument. Even if you feel little tight, you can use the bone file, put this, and it should slip in. That's it. No one can remove this except this instrument. Tell me, I will just show you that, demonstrate you right now. Cement mixing start, please. JLP. Small B3. So, suction please. That instrument please. So, if I put this instrument and try to pull, see, it's no signal. There is no signal.
We can see
It's
you,
okay?
Karthik. We can see you.
Okay. So even if you try to pull it, it won't come out. The only thing that if you leave it, it gives you a gentle open book feeling. That is what exactly you are looking for. Otherwise it can't come. The only way it will come, you apply the flex, do a flexion, pull it and lift it. See, this much force is needed when you want to dislocate this bearing. So it hardly dislocates. I had never seen bearing dislocation In last 10 years, we have only 5 bearing dislocation in almost around 5,000 Oxford. So, and people are sitting on floor, they are doing everything, involved in sports, trekking, and every household work they are doing just like a natural people. Yes, give me the drill hole, please. Very simple, very reproducible procedure. Again, you don't have to apply your mind. This is done by the system. It will do its own drill holing. So you don't have to bother about the diameter and depth and only thing. A little bit of in tibia, 1 or 2 if you want. That's it. The bone is really good. So most of the time people do in early cases. These are not the good cases. Let bone be prepared for bone on bone arthritis. So if you see the medial half so strong and sclerosed, and lateral half is little always more cancellous. If this bone is not prepared properly, because most of the time surgeons are inclined in very early cases to put uni, they always have a miserable result because they really want a good bone to be at the end. Mop, please. So we have modified a little here in a cementing technique also. So make it dry. We use 1 cement pack. It is fine to use 2 in initially. There is no problem. Over a period of time, there will be apply this. Dry the peg holes with the suction. Fine. Apply a larger one. That's okay. May I have a small artery, please? Okay. So we have prepared our surfaces very dry, neat and clean. This looks like an egg within a nest all the time. So we are good. We use 2 cc syringe to fill the plugs. So just put it like this, pressurize it, and you will have a very consistent cementing all around your peg holes. So it will never loosen. So the most common concern was a loosening of a peg holes or anything. If nothing happens. Second syringe, remaining cement, you have put it on a femur. I would like to add some cement as well on the femur. So 2 advantages. You are stress free. That what will happen if you run out of time? Your femur is already ready. Now you spend again time with the tibia. You have secured the femur. So this is the straight osteotome. Very thin layer of cement you need to apply. It's not like TKR that lot of cement you need. Just a millimeter of or a half a millimeter of cement you need. Very less cement. I am happy with this. I will apply the same amount of cement on the implant. I will make it dry. Very happy with the preparation. I will show you the amount of cement you need. So very less, very less cement you need, because all the cement will come out. Put it from posterior to anterior like this. Press it with a beautifully designed microscope or tibial impactor. Done. See, the cement will come only little bit of anterior. There is no way the cement can go at any place. So even if you check, if you do not check, there won't be any cement. It's only anterior portion. Done. Same way, femur, cementing. Identify your peg holes. Put your femur here, impact it. Remove additional cement. whatever the theory is taught for TKR, the notching and patellar clunk and mid-flexion instability and synovitis, and this and that, nothing happens here. And what kind of physio do you recommend for this patient, honestly? You have not cut anything. Your deep MCL is intact. All your 4 ligaments are intact. Opposite meniscus is intact. Done. And the bearing is in. That's it. Now, only important thing you would like to check is that this bearing is not hitting this anterior, because this is a physiologically hyperextended knee. Very beautiful demonstration we will have. This is a physiological hyperextension. This instrument system is so precise that it removes the bone for neutral femur. So if I check, I may be touching a little much more, that I will remove. The ligaments is determined to remove whatever the cement necessary to be removed. Again, the system does everything. You don't have to bother for anything. So I'll just remove additional cement. And one more thing, the wear rate of this poly is documented worldwide. In a 2012, Dr. Anderson, in a Kendrick study published, the wear rate of this poly, because it's a mobile bearing, 0.02 millimeter per year. So it takes 50 years if it is done well. If it is not done well, it will be out in a year or a 3. No one can stop it. It's only impingement, you have to be careful. External and internal. I will just show you what are these impingement we are talking about. Otherwise, whatever the patient is doing, the knee does not bother whether it is in 0 degree or 90 or 120 or 140, because the surface area is same throughout range of motion. So at the end, what we want to show, now the most important part, this is all good. Why they have given a possibility that you can prepare tibia at the end. Now that's the important part. At the end, if you do not have this space, means you are not in alignment. See, people talk about alignment all the time. The alignment in uni is internal. It's not external we are talking. How you can change any alignment in uni? You have not released deep MCL. It is only intra-articular alignment we are talking about. In same way, so it is the alignment between your femoral component, your polyethylene and the tibia. That is important. Now if you made a mistake that your femur is here, then the poly will follow the femur. It will be a painful uni. If you are here, poly will be here. If you have cut left tibia, that is internal impingement syndrome. That uni has to fail. This is the space you want every single time, and the proper positioning of all 3 components every single time. So coronal plane is your plane, sagittal plane is a system's plane. So fortunately in this there is no notch osteophyte, but we'll still demonstrate a little bit. This you need to take, because in extension this osteophyte can cause damage to your ACL. That is a decapitating effect of this osteophyte on ACL. There is a little bit of small anvil osteophyte that will take, very small actually, not much. So we are done with the surgery. We always put drain, but it is an optional. If you want to put drain, it's okay. Otherwise, it's not mandatory. There is no problem with the patellofemoral tracking or anything. And it's a rock solid, stable, because you can never do under correction. You can never do over correction in this procedure. It's within a 1 millimeter precision all the single time. The sharp edge of a femur you can remove to avoid irritation of synovium. That's it. So we are done. Any questions so far?
I'll just ask the audience, is there any question for Karthik? Yeah, so Karthik, there's one question from that you didn't pressurize and didn't hold it still till the cement was setting.
Yeah, cement is still wet. We will be doing this 45 degrees. We will do that now because it is still wet.
Okay.
You can do a trial poly and do all these things initially. It's fine. Table down, please. Meanwhile, the cement is pressurized and everything is settled in a static position. I do understand you need a static position. You don't want to move the limb when the cement is settling down, but you can always have this possibility to put it in 45 degree and you can finish your closure. So it won't move.
Sir, I wanted to ask if there was a lot of posterior osteophytes, what to take care of?
Osteophytes where?
Posteriorly.
Yes, yes, sir. The system will take care of the posterior osteophyte. You don't have to bother for any osteophyte in the system. Just finish your surgery in the standard tibial cut. Whatever the tibial posterior osteophyte, it will come out. What posterior osteophytes will come out with the chisel. That is the anti-posterior impingement guide given. So this is the instrument designed to remove exactly the needed bone to be removed so that the poly can move without any pressure or any impingement. Any loose bodies will come out when you do the arthrotomy.
Good afternoon, sir. Another question, if there is a gross varus deformity, would you
Yes.
go for uni?
What do you mean by gross varus deformity? That's a question to me. It's a static deformity you are talking about, bony deformity, or intra-articular varus you are talking about?
Sir, even if there is a intra-articular cartilaginous lesion also, and that is simultaneously varus deformity is there, will you go for uni alone or along with?
This has to be understood very well all the time. I'm still surprised why they have published Cosin, Scott criteria and Campbell. The varus is having lot of things. Varus is the static part and the dynamic part. See, our patients do have a constitutional tibia vara. Now we have finally realized in TKR also that it is not a mechanical alignment. See, varus is a sum total of the femoral bowing plus tibial bowing plus obliquity of joint line plus cartilage loss plus lateral laxity. So you understand the varus. So if there is a significant bone loss, significant lateral laxity, your varus may be 17 degree. The whole idea is whether it's a correctable. In a lateral X-ray, the posterior tibial cartilage is intact. I will show you the X-rays, which you seem horrible. Even for TKR, you will keep complex TKR. And we have almost now 9 years, 10 years of results. It is like 15 degree, 20. The whole idea of varus is where the varus is. If I have a stiff knee in a male patient, there is no lateral laxity. I have less varus with even significant bone defect. If the bone defect is 2-3 millimeter here, cartilage loss is here 3 millimeter, and lateral laxity, obese female patient, you will have 12 degrees of varus. Why we need values all the time? I do not understand why always we are talking about degrees. In HTO, every degree matters. It's a planning through degrees only, because exactly your precision is through degrees only. Here you don't need anything. It's a gap balancing technique. It's just to balance the gaps. That's it.
So I'll just make this a bit clear to you. So why are you worried about varus? Because you're worried about wear. That is okay for TKR. For UKR,
Yes,
the wear
yes,
rate
agree.
is 0.03 mm per year. So in 10 years, you have a wear of 0.3 mm in 10 years. In 20 years, 0.6. There's hardly any wear. So wear is not an issue with UKR. So you can leave varus, no problem.
And see the incision, if you see, this is the size of my
You
patella.
only have poly in the medial side. You never want to overload lateral. You want to keep them deliberately in varus. This is the
So in
structure of the
thick
operation.
bearing, they say you can do a deliberate varus, as Dr. Rajput has mentioned, leave it undercorrected. The beauty here,
Yeah.
you
You
can't
should
do
keep them in varus.
anything.
Never
You can't
go in,
undercorrect, you
normal
can't
or
overcorrect.
valgus.
So
You
it
do
is
not
just
want
the
to
way it
overload
has
or
to be.
transfer onto the lateral compartment.
Any more questions?
No, Karthi, I think that was a wonderful operation. I think, any last questions? No, Karthik, I think
Thank you.
you've made the London osteotomy course a failure, I think.
It's a pleasure. I am visiting Kolkata first time, and for an Oxford, it's a pleasure to be in Kolkata.
Right.
Thank you.
Thanks for
Thank you
coming.
for the invitation. Done? Arey, we are still live or we are done?
Okay, now further, I would like to call Dr. Rakesh Rajput.
আমাদেরই লোক হ্যালো
Can we I think we've had a wonderful demo. believe me, it's not that easy as what he's made to look out. He's a guy who does 5-6 Oxfords in a day. So it'll make it look very easy, but there is a learning curve to it. So make sure you train yourself very well if you want to venture into this. Can I have this one? So I think we'll talk about, so a topic which given to me was reason behind resurgence, right patient for long-term success. So I'll actually focus on both these aspects, okay? Nothing different. So if you looked at Oxford in days gone by in 25, 30 years ago, look at what it was: osteoarthritis, medial compartment, and occasionally avascular necrosis. That is why the number of patients you always had was very low. Gradually we realized that what we are trying to answer here is right indication, who is the right patient, and who is the right surgeon for that patient. So that's what we are trying to answer. So indications, time-honored anteromedial osteoarthritis. No doubt, that's how we started the journey. That's how still the number one indication for this is. You open your knee, you have huge defects, doesn't matter. As long as the arthritis is medial, as long as you have a functional ACL, not anatomical, functional ACL. Lateral side more or less pristine, you can have couple of ulcers on the lateral side, doesn't matter, because sometimes the tibial spine, because of subluxation, can indent on the lateral compartment. Doesn't matter, that's all okay. Chondrocalcinosis, injections in the knee previously, all this white matter does not matter. So all these are the thing. So I think we had a question about older population. What happens in very old populations? We have tricompartmental arthritis. I'm giving an example of an 81-year-old person who came, who was still very active, unable to walk, okay, more than 500 meters. So even this guy is demanding to walk more than 500 meters, which is, fair amount for this 81-year-old. So that's his x-rays. Is 81-year-old, does it look bad? On the left side, that's where his symptom is. So you do your x-rays. I think what we are seeing is, if you do unis, you should do valgus and varus stress views. So you stress them out and you see that bone-on-bone contact medially side, it's opening up on stress views and no collapse on the lateral side. There is chondrocalcinosis. So one thing you can clearly see, chondrocalcinosis is not a contraindication. That's all his scar is. Just look at the scar amount. That's all we can do our operations. And he's showing off to you that he can now stand on one leg. So function-wise, he's so happy. He's actually still alive, which is now 6 years down the line and still walking around. He comes to our clinic for back pain now. Give you another example, 70-year-olds. So we heard this talk from Dr. Samanto that after 65, you have tricompartmental. Look at this guy. He's a retired army person. He's wanting to play golf, not wanting to just walk around. He's already walking 1 kilometer. He's wanting to play golf. Can you satisfy with him with a TKR? And the answer is no, because the moment he's asking, demanding questions, can I play golf? The answer is no. Everybody told him that. So that's how he landed with us, because he was still demanding with that. So that's his arthritis. And as Jiten told you very well, that sometimes they don't look bone on bone because we are doing them in extension. Sometimes the arthritis is central. So unless you flex the knee to 30 degrees, you won't see them. So that's his valgus stress views. You can see clearly opening up on the medial side, so not contracted MCL. So you go ahead, do your unicompartmentals, and you can see the amount of activity this person has. This is him after about 4 or 5 months. So you can see the level at which this guy is demanding. You can't give him these sort of things with TKRs. So only a UKR will give you this. So Jiten told you one thing, the happy ones are not happy, they are very happy. And that's what we actually see this in our practice also. So another case study, we were told that only after 55, young patients we do osteotomy. Well, when this guy came to us, I gave him the option. So he was asking me, at that time I didn't have such wonderful osteotomy studies to quote. I could only quote what Coventry was quoting at that time. This is about 10 years ago. So when he heard everything, he said, no, you do me what you were saying. I said, well, this time the operation will probably last only 10 years. He said, well, go ahead. So we went ahead, we still did stress x-rays, and that's what we see. So went ahead with an Oxford. Believe me, this guy came exactly after 10 years, and I said, what's your problem? No, you said after 10 years I need a revision, I'm here. So I said, can you? And I think my fellows are laughing because at that time, this guy actually had arrived. And he was asking for a revision with no symptoms, just because I said, that's the belief he actually had on you because of the amount of energy he had, what you gave it to him. We tell bugger off, so he's now 11 years and he's still going very strong. So how to perform a stress x-ray? So you need the knee flex as 20 degrees, the angle needs to be about 10 degrees, and you need valgus vest. So if you're wondering who this knee belongs to, that's the guy sitting just in your audience here. So that knee belongs to this guy. So what you're going to look at this stress x-rays, you're going to look at medial opening, you're going to look at no lateral collapse, and then you're going to look at lateral x-ray also, how far the sclerotic line, I don't know if I have a pointer here, so that sclerotic line you need to see how far it goes. That gives you an indication that how much the Hibernated bone is weight bearing, and that will react. So the sclerotic line is basically a reaction of your bone to weight bearing where there is no cartilage. So if you trace that line, that is how it progresses in different cases. So when it comes to about all the way posterior, you know that your ACL is deficient now, and the whole posterior part is also hibernated, right? And this is now where even the subluxation is happening. So lateral X-ray is also fairly important to us because we actually decipher ACL presence or absence based on X-rays. MRI won't give you a very good idea. On the osteophytes, if you see a bump, the MRI can be misleading. MRI may tell the ACL is there and it still may be deficient. So MRI is misleading. Clinical examinations are also not going to be very good because you have osteophytes, which will give you pseudo-stability, and the ACL may be absent. So clinical examination are also not good. X-rays are the best. When you actually open up the knee, we used to worry a lot about this ACLs. I think gladly we've realized that ACL is not such a huge issue. And that is why it is. So initially when we were worried that ACL is required, we started reconstructing ACLs. And this is the Chris George paper himself about mid-term and long-term studies. Wonderful results, almost the same as the people with ACL. This is the Chinese study, so don't go apprehensive that this is a Chinese study. This is actually a meta-analysis where they have looked at each and every paper available with absent ACL. And look at their conclusions, no difference. So even without the ACL, the results are very good. And this is not single center study, this is meta study. From every literature base they could gather, that's their outcome. So if you suddenly open up a knee thinking you want to do UKR and suddenly the ACL is absent, I would suggest that still go ahead and do it. Don't worry. But yes, if you had preoperatively already decided that everything is fine, I'll go TKR, that's fine. But if you open up for a UKR, now I would not worry about going and doing a UKR if the ACL is absent. Avascular necrosis, again we used to think this is a bugbear. You go look inside it, huge defects, no worries. You still go ahead and do because you can capture from the, it's a C thing, you can capture on the top, capture on the bottom, inside you can fill up with bone graft and mix it with cement. So that you can still go ahead and do them. Results again is in front of you, both with Sonk lesions and normal osteoarthritis, similar results, right? Lateral compartment, again we are bugbear, we never used to think we can do UKRs. Of course, doing a mobile bearing UKR on the lateral side is a bit difficulty, but you can do fixed bearing UKRs. And why can't we do the mobile bearings? You see the medial side moves only this much, medial side if you have. But what happens on the lateral side? That's the amount it moves. So the mobile bearing can actually fall off from behind. So if we are a bit reluctant to do, Oxford of course has modified their own system, but that's still experimental. So for us, if you want to do lateral UKR, it has to be a fixed bearing. So causes for resurgence, that's the second part of my topic. Why are we suddenly seeing this resurgence? So the contraindications which the Oxford was coming, I'm coming to that, and many surgeons are now beginning to take interest, and there is robotics coming in. So robotics are done by high volume surgeons, and they want to show something different also. So now they have forced themselves to learn UKR in a robotic way, and that is how the big spurge is actually happening. So generally accepted contraindications were this, which we used to call Cosin and Scott criteria. So that was the Crozin et al., which was this contraindications. All of them have been debunked by the Oxford group, and the studies have come from Hemant Pandit's group. Okay, so that's been debunked. So if you look at PFJ degeneration, what you're talking about is either anterior knee pain, it has no relevance to your success. Or you're talking about radiological patellofemoral arthritis, has no success, no outcome on your success. Only if you see bone on lateral compartment, that may be the only contraindication for doing a UKR. Otherwise, go ahead and do it. So we were told about the reason to do high tibial osteotomy is you need to have very active persons. They can do. Otherwise, you can't do a UKR. Now look at selectively just looking at Tegner 5. Now that is what we classify activity as. Tegner 5 are the people who are heavy laborers, who jog, who ski. Those are Tegner 5s. If you look at selective 12-year survivors, that's 97%. So even for Tegner 5 UKR, pretty good results. So don't worry about if you have a very high-performing individual. We have a metal-on-metal hip. Andy Murray still winning in Australian Open. So don't worry about replaced patients doing very high level of activity. Right? So now applying Cosin and Scott, the reason is if you apply this, you will only see 5% patients of yours who are suitable for UKR. But if you apply these criteria, you take away Cosin and Scott, almost 50% of your TKR patients, at least this is Western, for us it is about 25 to 30%. That's what we've calculated in our data, that about 1/4 of our patients are suitable for UKR. And who should be doing it? So only an interested surgeon should be doing it, only a trained surgeon should be doing it, preferable by a surgeon who thinks every replacement is a UKR unless proven otherwise. Not like, okay, this guy is very young, I think in this case I should think about UKR. No, if you do that, you will not have enough numbers to become good at it. If you're not good, you will be giving very disastrous results, and the UKR will get a bad name. If you don't believe me, that is the numbers you need to reach. This is not me saying, this is this paper. Even in UK, they had some very bad results from Oxford. When they analyzed, it is exactly what I just told you, that unless you do 20 to 30 UKRs in a year, you will not get good results. The next resurgence is from the robotic surgeries, and I think we have our own share of robotic cases, which we're very happy about. So this is a big outcome for us from looking at robotic cases. I think I'll just skip over it. But I think if you now see all these things, this is what actually has given us an actual resurgence. Thank you very much.
Thank you, Rakashda, for the excellent lecture. Now, Dr. Karthik Shukla, he will speak from JBCH, from the OT. So please switch over to online presentation.
Hello.
Yes, Dr. Shukla.
Got any question? Oh yes. Okay. So we are just going to start.
আমার এখানে সাউন্ড আছে তো
Check 1 2 check check. Dr. Shukla,
Hello.
Dr. Shukla, are you able to hear us?
Yes, I am fine. I can hear.
Okay, sir.
Okay. So this is our experience. You can see the numbers in very less out of this almost 4,500 patients. Stiff knee, one patient RA conversion, two debridements. Now I'm audible or not?
Yes, sir, you are audible, but the screen has changed. Just, it's a technical problem. Just hang on for a second. Now, yes. Now you are audible.
Now everything is fine, I think so. This is just our experience of an Oxford knee. You can see very less number. So overall, if we analyze our data, so it is less than 1% of patients, those who are not happy. So fundamentals of Oxford philosophy is right patient, right position, right execution, right function, and you will have more patients to get unis. This is, we have already demonstrated how simple and precise. This is 2 millimeter, which is loose. 4 millimeters will be tight, and this is exactly the balance you need to achieve. And that's why we called it as a humanics of gap balancing philosophy rather than the robotics. You don't need robotics here. Very simple to remember. The femur size is a confusion. So a very short female you need extra small. All other female you need a small. So color coded already I have shown in this. Medium for male and tall male very large. These are the common sizes. We had witnessed this in a female patient. We have a small femur, B tibia and 3 bearing. Male patient, we usually have medium femur, C or D tibia and 3 or 4 bearing. As I already mentioned, life begins with a color code. Boys are blue and girls are pink, so you can select the right one tray only on your table. You don't need anything else. Oxford knee is a different than the TKR. Your extension gap is 20 degree and your flexion gap is 90 plus 20, so 110, which is a natural ligament tissue tension position. Remove all the osteophyte which is there. That was a question also. So this is known as an Oxford clock. You can follow the guideline as mentioned in the brochure. There are 2 places on the femur, 2 places on the tibia. The tibial jig is a magic. So there are because you have to spend time with the tibia because it's terrible. 48 ways to take tibial cut. You can have a combinations of 3G clamp or 4G clamp, 1, 2, or 3. Spoon, you have a shim, +1, slotted, non-slotted, +2, slotted, non-slotted. So cumulatively, you have 48 ways. Coronal plane is your plane, as I had already mentioned. An instrument will take care of your sagittal plane. This is the most important after cutting tibia. Always never forget to see your flexion gap. And this is most important. I would like to pressurize a lot of time. This is the symbolic presentation of an Oxford. This is the knowledge sign or the Gyan Mudra, what we say. So all the time, this is, you can't cheat yourself. If you cheat yourself from the beginning in a surgery, you will regret at the end. These are the 3 ways you can insert your femoral drill guide, and the same way you will be able to insert your bearing at the end. So strive for this. It is good. Again, femur, we already mentioned, absolute reproducibility. You don't have to apply your mind. It is 10 degree flexion, 7 degrees of valgus. Coronal plane, mediolateral translation is all that you need to do. Wisdom cut, you can play with it, the system. This takes little more understanding, but this is most important thing, that if you are tight, revise it, use a bone file, or in the end, you are in trouble. The simple idea is of the Oxford philosophy is, this is the only system which starts with the flexion gap first and reproduce the extension gap as per the flexion gap, because the disease starts from the extension and starts from the non-disease compartment to the disease compartment. The easiest way to understand, when we travel, we pack our luggage first. We don't choose the bag. So as per luggage, we will select whatever the bag we would like to take. And at the end, we are ready. So let me explain in a simple way. This is my flexion gap, which is my luggage. This is my femur. I will need to put my luggage inside. What I will do, I will just open it without doing anything. That is my 0 spigot. If I'm okay with the flexion minus extension gap, which can be 3, 3, then I'm fine, I'm done. If I'm not fine, like this scenario, which exactly happened today, means you are not okay with the 3, then what? Then you have an additional zip that you just unbox, means one more spigot you are going to use. That is a 4 spigot we have used, and you are okay with this. Never hammer this after you remove a collar, otherwise your extension gap will be large. This is very important step. Never hammer the 3rd spigot. Again, this is what exactly we had mentioned. Perfect, tight, and difficult. So human touch will have a 0.3 millimeter precision all the time in a natural thing. This is what exactly I wanted to show, the impingement. This is my own case. Unfortunately, this has happened. We could not stop it. I don't know how this has happened. Still, the lady has not come, but this is horrible situation on table. You can see the poly is not stable. It is impinging and squeezed. So this is just like the bearing is your child. Give them freedom, but not too much. So just you have to nurture your bearing same way as you nurture your own child. So 4 ways, 4 important thing: Oxford, proper exposure, confirmed diagnosis, precise tibial cut, spigot science is a miracle, and accurate gap balancing. Take home message: results of mobile bearing uni is considered technique dependent. Let us learn it very right. Internal alignment and integrated balancing are 2 important concepts or components of mobile bearing uni, and design against wear and a full range of motion. Both are absolute need of our population, and mobile bearing uni can serve both. This is just to sum up everything what I had told in one slide. This should not happen. Don't squeeze your bearing and tethered soft tissues and stretch your MCL. Thank you all for your attention. Thank you.
Thank you for the excellent presentation. Now we'll switch over to live surgery in the OT.
I would request Dr. Ananda Mandal and Prashant Kumar to please kindly moderate the session.
Hello. Jaideep da. Hello. A 62 years male presented with the bilateral knee pain for last 7 years. He has difficulty in squatting and sitting cross-leg. The left knee, total knee replacement done 2 months back. Now the right knee will be done today. On the right knee, there is swelling, there is joint line tenderness, range of movement is full, the varus deformity is 20 degree and the fixed flexion deformity is 5 degree. Now, this is the standing photograph of the patient. On the left side there is no varus deformity, but on the right side there is varus. Okay. Now, this is the standing X-ray, both AP and lateral view. Now, the plan is total knee arthroplasty, right side. Implant का देर
full screen.
Hello. Hello. Jaydeep da. बोलो तो चलो walking lunch is going on. हाँ की अवस्था होगा जे जे क्या नहीं लगा. समय लगता है. तो बोले तो lunch is working lunch is there, and if you can go, you can take your lunch. Hello.
Check. अच्छा तो.
Hello.
Hello.
हाँ.
Are we audible in the auditorium?
Yes, it is audible, but the voice is not coming properly.
We just have a brief couple of minutes to just setting up the audio. Let's talk about this patient. 40-year-old gentleman who presented to us with bilateral advanced grade 4 tricompartmental osteoarthritis. We are going to do his right side first. He has, I don't know if you can, Tunike on kore dao please. He's got about 5, I don't know if you can see the leg, he's got about 5 to 10 degrees of FFD. There is about, again, 10 degrees of varus deformity. There's a bit of synovitis in the joint. It's a bit swollen, and you can flex it to normal, I would say. If we can zoom on if you can watch it, if you can see the x-rays, he's got tricompartmental osteoarthritis, grade 4, and there is a loose body, I think, in the suprapatellar pouch. We will target that once we open the joint. Now, we'll proceed with the incision now.
Okay. And
I do a camera.
Hello.
I usually do a midline incision with 2 fingers on either side of the patella and my thumb on the tibial tuberosity, and then just go midline with slightly curved so that you don't end on the tibial tuberosity because there is very little fat and there's only skin out there, so there may be some problems with skin healing. So I do this midline longitudinal and then go up to the deep fascia with the same knife. That's the tibial tuberosity. I just end about an inch below that. I usually do it under tourniquet control. So I take an extra couple of minutes just to cauterize all the skin vessels. Otherwise, they might give you some wound problems later on.
Then you always use tourniquet, cautery. Jaydeep?
Sorry?
You always use cautery then?
একটু ওদের অডিওটা ক্লিয়ার করো না, কিছু শুনতে পাচ্ছি না তো। ওদের অডিওটা একটু ক্লিয়ার করো। আনন্দ, সরি আমি কিছু বুঝতে পারলাম না।
No, you always use cautery along with the tourniquet.
Yes, yes. Now, once I've done this, then I lift the paratenon, carefully up to the lateral border of the patellar tendon.
Okay.
It is a bit tight knee, so I think need to extend my incision slightly superiorly. Right. Now, once I'm there, then we go for this incision in the quads, curve it round the medial border of the patella and bring it down along the medial border of the patellar tendon. Try lifting the medial sleeve subperiosteally with the blade. And once I've made enough just scrape it from the tibial surface so that you don't damage the MCL. Okay. The medial sleeve remains intact.
You are going subperiosteally.
Subperiosteally. Yeah. Once I'm there, then I start using the cautery. Shital. Usually in a varus knee, I would release the soft tissue up to about, say for this right knee, we'll go up to about 3 o'clock position and then leave it there. Once when I'm doing my trial reduction and everything, we'll see whether we need to go and release a bit further.
Okay. How much?
Take the medial meniscus out.
How much?
And then whatever of the infrapatellar fat pad.
Okay. How much release of MCL you will do?
How much?
Release of MCL, medial collateral ligament, you will do.
No, it's up to about 3 o'clock we go, not beyond that to start with.
Okay.
This is that loose body we were talking about. It was lying in the suprapatellar pouch.
Yes, yes.
And once we have everted the patella, we take a bit of the fat pad, taking care not to damage the patellar tendon. And since in this case it's a bit tight, the patella will just release a bit from the tendon insertion. And I decompress the suprapatellar pouch with there's a lot of synovium, thickened synovium here. They might cause some stiffness in the joint, so we'll take as much as synovium as possible.
There is a lot of inflammation there.
With the fat pad. Yes. That's why the knee was swollen and there was a lot of fluid in there. Camera chale আসে। You see, it's quite inflamed and thick synovium we are taking out. Right. So once we have done that, we flex the knee. You can see there's quite a bit of damage of the cartilage in the medial femoral side. There's loss of cartilage on the tibial side. ACL is partially degenerate.
So, do you routinely evert the patella, or it can be subluxated also, sir, laterally?
Ananda, sorry, just let me try increasing the volume of.
Sir,
actually, Prashant is with me. He just.
Sir, in this case, you everted the patella, sir. It can be subluxated also, sir, instead of everting.
We've taken the ACL, the PCL off, and we go on the lateral margin of the tibia and take the bit of fat and the lateral meniscus as we can see now.
Yeah, yeah. It is well visualized.
The spike goes on the lateral border, and we put this angle retractor to get the tibia out, to sublux the tibia out from the femur.
Okay.
Hey, Dada,
Lateral meniscus.
yeah, that's it. After that. Take the remnants of the lateral meniscus. Okay. So there we have it, the upper surface of the tibia fully exposed. We see that it's down to bone here on the medial side. This is a relatively healthier side, and this is the depressed side, the damaged side. So we are doing a buccal purpose knee today.
So you will decide the cut on the depending on the damage side. No?
Yes, in this one we aim for the lowest point in the tibia, upper surface. The jig has the stylus, one end is 0, is marked as 0, the other end is 2 millimeters. So if I'm happy with my tibial cut, we'll leave at 0, otherwise you can go back and then take 2 millimeters more.
Yeah.
মাঝখানে একটা দিন। Okay. So you see that our mark now on 0 on the lowest point of the tibia. So this is the level at which we are going to take it off. If you take it. Now if we check that, yes, we are going to take about 2 millimeters from the damaged side. Overall, it comes to around 6 millimeters. So that's what we have taken out. It's 0, 0 on the medial surface, while it's about 6 to 8, 6, 7 millimeters on the lateral border.
What is the thickness of the tibial cut on the lateral side?
Step Yes. Right. So what we need to check at this stage is the size of the femur.
Yeah.
Okay, this is a special jig that you see that it comes in different sizes. You can see 3, 4, and you place it. You take all the osteophytes out
from the margin of the femoral
from
condyle.
the margin of the femur.
Yeah.
And you place it on the lateral side. That gives you a fair idea of what size femur this will be, and all your jigs and cutting blocks will be based on that sizing.
Yeah.
So this is a size 4 I'm trying. We place it beneath the lateral LCL and the superior margin, and I think this is a fair estimation. I don't know if you can appreciate
ask cameraman to come from the lateral side.
Yeah, এদিক থেকে দেখানো যাবে না না এটা না এদিক থেকে দেখানো it will be a bit difficult, Ananda.
Okay.
But trust me, it's a size 4 we are measuring.
Okay.
একটু size 4 ইমপ্লান্টটা দে আমাকে. Now to double check it, you turn it around, place it, size 4 looks too big.
Yeah.
See the mediolateral, it seems too big. So you go back and then try the size 3. Yeah.
Yes,
let's see. Let's check
good.
with size 3. I think this is better. This is more confirming on the mediolateral diameter. So we'll go for a size 3. Right, this is another jig, it's more of an anterior referencing. It goes on the femur. This shaft should
over the anterior
lie
of the
on
femur.
the femoral shaft centrally. And then you can adjust your opening of the central canal. So this goes superiorly. It's sitting on the femoral shaft centrally. And now once we have done that, once we are happy with the positioning, we'll find the central canal.
Okay. And you have to see the parallel to the, whether it is parallel to the upper surface of the tibia or not, no?
Yes, it lies snugly on the femoral shaft. Okay, and you can see that as we drilled it, it went in smoothly. It didn't catch the anterior or posterior cortex. So we have done it central. We are central in the femoral canal.
Okay.
Sir, hello. Sir, are you going to check whether your tibia cut is perpendicular or varus or valgus, sir? Because everything is dependent upon the tibia cut, sir.
Now we put this jig in. And this is the spacer. That is this. So we put the knee in 90 degrees now, and then you can see that it's sitting nicely on the tibial shaft. Let me show you this. So this is my flexion gap, and it's equally balanced on that both the sides. Okay.
Yes,
So my rest of my cuts will Huh? Now the block is sitting there on the distal surface of the femur. We fix this block with the 2 pins. Alignment rod to there. You check for the alignment at this stage. If you can, I hope you can appreciate this, that it is going to centrally through the canal and ending at the second metatarsal. Foot to focus karo na, please.
Foot is not.
Foot focus karo. Eitai.
Yes.
Aro niche. That's it. It is ending centrally in the ankle, and it's ending at this second metatarsal. So our alignment is okay.
Yes.
We are happy with our alignment.
We can see it perfectly from here.
Now we'll do the anterior
cut and the posterior cut.
You
took the.
Oh, yeah, alignment rod ta diye.
No, side right.
Yes. এখানে একটা স্পাইক দাও there you go. Through this jig we'll do the we've done the anterior cut. There is no notching and you can see well the piano sign. Now we go for the condylar cut.
Is there any option of checking whether there will be any notch in the anterior aspect or not? Is there any option of
Sorry,
checking?
Anando, come again.
Is there any option of checking whether there will be any notch at the anterior aspect with the jig?
খুলবো নিবলারটা দাও নিবলারটা দাও Just finishing off, there's a bit of osteophyte on this side. Inferiorly, we are taking it out. Otherwise, our jig is not going to sit properly. Yeah. Okay. Yeah. Now we'll extension. If you come at 90,
this is the
you
flexion
put your
gap, no?
jig in, and then you can see your flexion gap, that it's sitting snugly on the tibia, and it seems quite stable.
Yeah.
Okay.
The
So
knee is
I've
at
got
90 degree, no?
Yes, knee is at 90 degrees. So I've got my flexion gap now corrected. We'll have to match it with our extension gap, but we'll have to do the distal femoral cut first. So I'm happy with my flexion gap.
Yeah.
Okay, they hammerta they okay. Right. Return. Yeah. So once I've done that,
Yeah, you can check
now
the.
now we'll check the extension gap. Okay. So that's it. The FFD has been corrected. It's in full extension and it's stable. If I do this varus valgus stress, there's no opening. So my extension and flexion gap are now equal. So my balancing is done. For this RP knees, the most important step is to get your balancing right. Otherwise, you'll end up in a lot of problems. If you hold this, give me that alignment rod. And see, if you push it down the alignment rod, what we check for is that the anterior superior iliac spine, you need 2 finger breadths, 2 fingers medial to it, the rod should sit down. So that's your ASIS. I don't know if...
Actually, it is not in the, not seen.
এইখানে that's your ASIS where I'm putting my finger in, and the rod is ending about 2 fingers medial to it.
Okay.
So my axis is okay, alignment is okay. If I push it down and you check your alignment again, that it ends through the center of the ankle and it ends in the metatarsal. So my overall alignment seems to be good. So alignment is okay, your balancing is okay. So we'll go ahead and now finish the
distal cut. Okay.
বেশি কাটছে বেশি কাটছে যাবো বেশি কাটছে Now we'll straighten the leg again and then check for our extension gap seems to be slightly tight, so we'll go ahead and do our through the jig, because my initial impression was we were taking a bit too much, but let me see.
Yes. You are gone outside the jig, no?
Yeah. Extension gap to the Yes.
Now it is okay, no?
This seems okay.
Yeah.
So I was overruled with the jigs. Okay, so extension and flexion gaps are okay. অভিষেক একটু হাত চেঞ্জ করে ধর না ঠিক আছে Now this is the finishing jig for the notch as well as the chamfers. We've decided on taking a size 3. We just need to put it centrally, and as you can see that the lateral margin is flush and it's sitting quite snugly. I don't know if you can appreciate it.
Yes,
that
yes.
the
It is.
angles are sort of sitting quite nicely along the bone cuts.
Yes, it is nicely set.
Yeah. So we do the upper chamfer first.
Yeah.
We do the lower chamfers. The lateral one. এখানে notch আছে
Very good instrumentation.
Right, go on. That's the beauty that the little bit of bone you take out from the notch, you hammer it in the canal.
Yes.
At that access your bone block.
Yes, it occlude the canal.
Yeah. Do the peg holes now? এখানটা একটু করতে হবে and then just posteriorly to loosen up your capsule, because in osteoarthritis you might have a bit of tight capsule at the back, both lateral and medial, as well as maybe some osteophytes. Just gentle tapping, don't push too hard.
Is it a carb osteotomy, no? Or state?
This is carved osteotomy. ঠিক আছে we take whatever is left of the bone cuts. The chamfer, the remnant of the whatever bone is there. There is a bit of tightness in the back, so I think we'll take those osteophytes out separately.
Remnant of the meniscus was there, no?
Yeah, remnant of the medial meniscus. কি করছিস Take both picture and we've released the tight capsule, and as you can see that there's a bit of gap now appearing. Thank you, John. We'll trial it. So we'll go for the tibia now, and once we have done the tibia, then we go for the trial. So again, there's a bit of elevation on the lateral margin. So let's see if we just clear this.
Soft tissue, clear the soft tissue on the lateral margin, no?
Yeah. You have to sit it exactly on the lateral margin. Sometimes what happens at this blob of tissue, it sits there and it tends to push your jig medially. Okay, so I think this is our size 3. These are tiny osteophytes. We'll trim it down later on. The tibial jig is really simple, and there is just one drill hole you need to make. That's it.
So the tibial jig, the lateral condyle will determine where it will sit, no?
Yes. So tibia prepared, the femur prepared. Now we'll go for the trial.
Okay.
Equally. Just that's it. That's your tibia which goes in, then the
yes, sir. There's a question from the house. I'm Dr. Manoj Khemani. Sir, basically, how do you check the rotation in this case? Tibia rotation.
Come again, Manoj?
Tibia rotation. How do you determine?
Sorry, I should have showed you that when we put the cutting jig of the tibia, that it's 1/3 of the tibial tuberosity. That's what we check for.
So the implant does not have the wings.
It doesn't have the wings.
That's a very, Joydeep, I'll answer that on your behalf. This is
Yeah.
Rakesh here. So this implant actually rotates 12.5 degrees on both sides. So it actually is very forgiving regarding rotations. So don't get too paranoid about not getting the rotation right. You should attempt to get rotation right, but if you err, there is no problem because it rotates the implant. So it will find its own good suitable place whenever you are flexing and extending. Very forgiving implant.
Sir, how much degree it can compensate?
About 12.5 on both sides. 12.5 degrees, so that's a lot. It has got a peg, central peg inside, so it will not go any more than that.
Yeah.
So you will see when you see the actual implant.
Now that we have put the trial implants, you can appreciate that our FFD is corrected. It's at 0 degrees, it's stable, and without thumb support, the patella is tracking normally, and you can go up to about more than 120 on table. Okay, so we are happy with the implants, we are happy with the tracking, and we are happy with the alignment. So this is the size we are going for. And we'll wash the joint out and then go for the implantation. Usually I don't replace the patella. We'll do We'll circumscribe the patella, the tissues, and then if there are any osteophytes, we'll munch them out. Yeah, not many osteophytes here, so I think we can get away with only the rasping. Animesh, rasp then? So check your tracking again. Without thumb support, it's doing quite well. So that's my size of the implants. We'll just wash the joint out and then spike, Abhishek spike. That's it. Okay. The osteotomy. All right. It's still a. We can feel there is a bit of osteophyte on the lateral side. That's why we struggled a bit in putting our femoral implant in. So we think we'll need to do a bit more of this. Yeah. Now we are happy. Get it. Yeah.
So just a question in mind. The original rotating platform poly had a disrepute of like a spin-off. So what's the difference in design in this to prevent that?
No, it's a more than spin-off. Spin-off happens if your balancing is not right. If you have unequal balancing from the medial MCL and the LCL, then only spin-off will happen. So you have to be careful about that. It is totally clear. There's no wing osteotomies or anything of that sort. It's only one central peg, and the plastic is supposed to rotate on it. So your balancing is the key thing. You have to be very careful about that.
Sir, one question is in my mind. Sir, is the mobile bearing implant will give you extra advantage over PS and CR implants, sir?
So there's a question, what is an added advantage of mobile bearing platform rather than fixed bearing?
See, there is two school of thoughts, and you will have 100 papers on either side supporting their ideas. But in mobile bearing, it is more confirming to your movement, because in a normal scenario, when the knee goes in full extension, you have this screw home movement where it locks. In a fixed bearing knee, there is no such locking mechanism, but because the concept is that because here the insert is supposed to rotate, that will mimic your normal screw mechanism and locking mechanism, and that gives a more better subjective feeling. If you look into the papers, they have all said that whatever we do and however well we do our knee replacements, it is never 100%. It's short of 100. So this concept is that you're going or trying to mimic the natural sort of your anatomy and physiology, whatever you call it. Your dynamics will improve so that you have a better feeling. Or I inject the cocktail in the posterior capsule. It's got morphine, sensorcaine, and ketorolac. There are a lot of combinations you will find. People are using it. Some use steroids, some use antibiotics, tranexamic acid. But I'm happy with these three, and it has really made a lot of difference in the post-operative pain management. Use of opioids has really gone down in my practice.
So you use femoral block also with this?
We use a femoral block and this. We don't have an ultrasound available in the OT, otherwise our anesthetist would have given either a saphenous block or a medial superior inferior genicular block and all those things. But I think you need to have a dedicated USG machine in your OR. Tibia goes in first. It's to Manoj's question. If you see this answer to Manoj's question, that if you see the implant, there is no mark or any real sort of marking or any edge to give you the sort of alignment, rotational thing. You have this peg inbuilt in the tray, which will help for the insert to rotate.
Yeah. So yeah, can you show the rotation of the insert, sir? Yeah, I get it.
This way. Okay. Either way, it's about 30 degrees. Cool. Really wait. That's it. It's handy because it's got the pegs. Ah, to go. Very good. Take that extra bit of cement out. Yeah. Right. Now we extend the knee. You can see, I don't know if to niche nabao ekটু এটা পাটা সোজাটা দেখো, zoom out করো. There's no FFD. Your varus valgus seems to be corrected and it's stable at 0, at 30, at 90, and the patella is tracking without any thumb support.
It looks
So,
beautiful.
Yeah, looks all right.
Yes, yes, absolutely beautiful, sir.
We'll let the cement set in and we'll do a final washout, and then closure is standard, and antibiotic protocol again 1.5 grams of cefuroxime at induction, and then 2 shots of 750 grams IV. After that they go on to oral for 3 days. Analgesic wise, these the intraarticular block and everything works well. They would be on paracetamol only, and SOS basis we will give them pethidine. And they start walking from tomorrow. We take the drain out tomorrow and they start walking from tomorrow. And in 3 days time, they should be able to do their, go to the bathroom, toilet, walking, and climb 1 flight of stairs. Once they can do that, they are discharged home. I hope you've enjoyed the surgery.
Yeah, thank you, sir. It was an excellent demonstration.
Thank you, Manoj. Any questions or?
Yeah.
Do we?
Thank you, Dr. Joydeep Banerjee Chaudhary. So we are taking the lecture, and big thanks to you and your hospital for taking all the pain for 13 live surgeries for last 3 days.
My pleasure, my pleasure.
It's
Thank
big,
you.
I think it's a big clap for JBCH and his team.
Thank you very much. Thank you.
Yeah, for the next session, difficult primary TKR, I'll call Dr. Sanjay Kumar and Dr. Ayan Ray to please come on the dais.
Good afternoon. It's post-lunch, and to keep you awake, what more than a nightmare? Infection after total knee surgery. And who other can deliver it better than Dr. Indrajit Sardar? May I now call Dr. Sardar to enlighten us on how to prevent this nightmare. Good afternoon, everybody. I'm blessed that you all had lunch and you're not waiting for it. So this is a situation where we are talking about infection prevention in TKR. And as he said, is the worst nightmare, which can destroy everything. So if there is infection after TKR, you miss the bus. And you have to face all the consequences that can happen due to that, all the consequences to yourself, to your practice, to the patient principally, and to most of your associates. We have to control the patient, obviously. Prepare the patient, control diabetes, eliminate sources of infection, bleeding disorders, anemia. Note the rheumatoid diseases, and there's some controversy about stopping the DMARDs appropriately. The rheumatologists sometimes say you don't have to stop it, but we do. The cardiac anticoagulants, and beware of brand names. They've come out in bewildering varieties of combinations, and sometimes you are left with one, and it's there, and you're in the middle of it. Skin cleaning. Skin cleaning preparation is the knee in maximal flexion. And the reason is that you provide some method for achieving the skin coverage even in obese patients with large soft tissue folds. You can see over there, there are folds there. It's only when you flex the knee that these folds are obliterated, and when you clean it manually, you do get there. So start the preparation in flexion, anterior folds are stretched and cleared. Actually, the reason why I'm saying all this is because there's been a tendency nowadays of TKR being a very easy operation. And there are countless areas where proper precautions are not being taken, thanks to our over-enthusiastic industry guys. And many untrained persons are starting to do it with the severe consequences of infection. So next, this I think is superfluous in this audience, but I hope there are some people who will learn from it. And this is the way that we are doing it. And having an audit, we still have our infection rate as less than 1% over more than 5,000 to 6,000 cases. So hold foot, straighten the knee for the posterior cleaning. The isolation draping of the perineum, all of this seems superfluous to you all, but this is the way you isolate the perineum, the most dangerous part of the anatomy of the patient from the rest of the thing. Then you hold the leg with sterile disposable drape for the foot, as you can see over there. And then over here, a piece of that IO-band that you have cut out for this. Then the stockinette goes in right over, and then the proximal disposable drapes, and also the distal tapes. So you give a second layer held by the towel clips, third layer, and the foot piece. We use a foot piece over there to eliminate the use of one assistant. And then the IO-band, the knee is flexed, and you can see over there on that portion there are rods in this foot piece which slot into this, which helps you with doing away with one assistant. And finally, the incision through the IO-band, and of course the cyclocapron, which is there. Hemostasis after skin incision, I think that was demonstrated by Joydeep, even with a tourniquet and obviously without a tourniquet, and again before closure. And all of these little things helps in preventing hematoma, which is a real source of infection, a nice area for bacteria to thrive. So the closure in 3 layers, muscle capsule, subcutaneous, skin staples, in 40 degree of flexion to allow more flexion later on, and then the use of brains. After the analysis of literature performed, these people found in 2020 that there are no significant advantages related with the use of wound drains following TKR in terms of pain, transfusion rate, blood loss, swelling, post-op range of motion, wound complications, deep infection, hospital stay, while no drains meant a significant cost saving compared to drainage use. So thus the use of drainage after TKA cannot be justified on the basis of results of this study. But the problem is that over here, we all have to make our own rules and own things and do what you're comfortable with or what you're trained with. So we do in all cases, we put drains. Sometimes in obese patients, we put 2 drains, and we have found that both drain. We always use a tourniquet, of course. The post-operative splint at night, do you use it or do you not use it? And again, there's another paper here which suggests that there is a difference. More blood loss in no splint, but more knee flexion by 5 days and 6 weeks. And in conclusion, these authors did not find any evidence to advocate the use of knee splints following total knee arthroplasty. But we do. Many of our elderly patients have restlessness, they have metabolic imbalance, CKD patients, and if the ward management is not that good, they tend to take off everything, and we have found a couple of patients getting up in the night and walking. Advantages of knee flexion, now that we use night splints, we got all the advantages of keeping in preventing knee flexion, and we also have less blood loss. Is HbA1c a reliable test for TJA in diabetic patients? We do know that patients with diabetes have a high incidence of infection after TJA, but this paper, which is a good one, 2011, they had 4,241 cases, and they found that there were 46 infections, 12 were diabetic, 34 were non-diabetic. And in non-infected diabetic patients, HbA1c was 6.92. In infected diabetic patients, HbA1c 7.2%, which is almost the same. So the average hemoglobin HbA1c level was 6.93, which means that hemoglobin A1c levels are not reliable for predicting the risk of infections after TJA. The present meta-analysis came out in 2022, who else but the Chinese, showed that a high HbA1c and perioperative hyperglycemia are associated with a higher risk of periprosthetic joint infections following TJA. So what we do is to look at the hyperglycemia, we look at the HbA1c, take care of both as much as possible. Symptomatic UTI and asymptomatic bacteria, this is one of great interest to us for various reasons. Symptomatic UTI is a risk factor for PJI and should be treated before proceeding. However, the asymptomatic bacteria is common in patients undergoing TJAs and should not be considered as a cause for PJI. So in these ASP patients, neither preoperative urine culture nor preoperative treatment is necessary before TIA of TJA. In 2018, an international consensus on orthopedic infections had this question, that symptomatic UTI must be treated with appropriate antibiotics before proceeding with the surgery in ASP. Treatment should be discontinued as it does not increase the risk of subsequent surgical site infection in ASP. This was agreed by 96% of the votes, which shows it was a near unanimous consensus. And this was a paper by Parvezi et al., published in 2019. Sorry, we're going back, I think. Clopidogrel stoppage before the TKR. This is another issue. The manufacturers say stop it 5 days before surgery. But here is another paper which says that results of our study suggested from Taiwan that clopidogrel continuation should be safe and advisable for patients at thrombotic risk undergoing primary major joint replacements. Funnily enough, they gave the second line. However, well-designed and adequately powered studies, including a patient risk stratification algorithm on thrombosis and hemorrhage, are required to prove this suggestion for the future. So what do? We also stop 5 days before the surgery. We check the INR value. Aspirin, we do not stop. DMARD before the TKR. Continue or stop before surgery. The rheumatologists say that you can, but we do. And minimize the steroids, that's what we go on. Does it affect wound healing in the high risk of PJI? No clear-cut definition of papers or the literature on it. Interestingly, the JAKs have come about. These are the Janus activating kinase 2 inhibitors like the baricitinib and the tofacitinib and upadacitinib, which are approved by the FDA to treat rheumatoid. And over this year, the same thing happens. You stop it before, and then 14 days later, you restart it again. Same for the biologicals. You have to do the surgery in the interval. Antibiotics in TKR, we know we use cephalosporins with ticaplanin, but using intraoperative vancomycin lavage was associated with a decrease in the incidence of SSI post-TKR, but the difference was not statistically significant. The take-home message, adequate weight-adjusted cephalosporin dosing reduces the risk of surgical site infection. So antibiotic prophylaxis longer than 60 days, 60 minutes started, was associated with a greater reduction in SSI risk than commencing within 60 minutes. So give that antibiotic before 60 minutes. And the duration of antibiotic prophylaxis does not appear to be associated with the risk of SSI. So the big debate, 2 days, 5 days, 14 days, not there. We use it for 5 days. The laminar airflow system for TCAR was a big study which went on, and there were 6,497 patients. Again, Wang and Parvezi in JAMA in 2020, they said there was no difference between OTA, which had the laminar airflow system, and OTB, which didn't have it. So where is the evidence? And Carl Sagan said a great thing, absence of evidence is not evidence of absence. So what is the evidence and what is recommended now? Abandon the preoperative removal of hair, testing of urine for bacteria, use of plastic adhesive drapes, and pre-warming of the operating theater. You also may stop intraoperative use of a tourniquet. We use a tourniquet, many don't. Use of a space suit is out. Use of a urinary catheter is out. And closure of the knee in extension is now, we do the closure in flexion. No evidence to support postponement of showering post-op, postponement of changing of dressing to 48 hours, no evidence to recommend routine dental antibiotic prophylaxis, no continuous passive motion, no use of compression stockings, no cooling for pain control or reduction of swelling, and flexion of at least 90 degrees as a discharge criteria following TK is not valid. The infection after TKR is the first line it happens. You look at the plain X-rays for radiolucent lines, osteolytic lines, and periaortical ossifications, blood tests, of course, D-dimer procalcitonin, joint aspiration, sterile conditions, antibiotic holiday, 2 milliliters at least, not fixed with blood, and 2 tests, bedside tests, which have come in, the leukocyte ester dip test of the LET, and the alpha defensin lateral flow test, which is very specific. The aspirated fluid is centrifuged. Look at the WBC count. If you have a polymorphonuclear percentage after TKR 16, 80, and 60%, that indicates infection. Sorry. No. Anyway. No, pulse me. Oh God. Nah. So over this, as you see, these are the new tests that have come in and which indicates that the whole thing can, you can see it even on the bedside. There's no single test, always a battery of tests. And the gold standard, you do the bacterial culture for 14 days, one from urine culture, one from operative biopsy. You need a MDT or a multidisciplinary team approach, and not available everywhere, but in most hospitals, yes. And look at the Philadelphia Declaration 2018 for hip and knee infections. If it is 6 or higher, the score, then it's positive. 0 to 1, no PGI. But 2 to 5, you have to get more investigations. So this is the real bottom line. Knee replacement is serious stuff. Now that everyone has to realize, and most of us do, some don't. And it actually could have made me worse. Thank you. Thank you, Dr. Sardar. I now invite questions from the House, if any. We move on to the next lecture. May I now call upon Dr. Chandan Pathak to speak on TKR in valgus knees. Eidike.
Good afternoon. And throughout the last 2 days, 2.5 days, we are all talking about correcting deformities, going for U-care, T-care, but most of the time we are addressing the single deformity, that is varus. Hardly any lecture or any talk regarding the other way around, that is valgus. That is less common, but one of the most complicated deformities to tackle. So my job is to take you round in T-care, in valgus knee. So if you consider valgus knee, we have 3 types of classification that I can get. Type 1 is a valgus knee, mostly due to extra-articular deformity of femur. So you get no medial laxity. It's basically femoral deformity. Type 2 is a classical valgus deformity that we all talk about. It's medial laxity, lateral tightness, and there is a classical valgus deformity we are concerned mostly. And type 3, it's extra-articular tibial deformity that is leading to valgus. H2O falls in them. So this is according to the severity. Mild, it is less than 15. 15 to 30 degree valgus is moderate, and more than 30 degrees severe. So let us have some information about what changes we expect in the bones. In femur, we have a smaller lateral condyle of femur, and comparatively medial condyle is larger. In tibia is grossly externally rotated, and tibial tubercle is much more lateralized. Patella is small. You get patella alta, patella baja position, and many of the cases we get lateral subluxation or dislocated patella. And what happens to the soft tissues? What are the major offenders? These 3: iliotibial band, posterolateral complex, and popliteus. These are apart from the posterolateral capsule. These are the major offenders in soft tissues. So let us go around the valgus knee. This is a mild valgus, less than 15 degree. Just do not do anything. Take it as a standard primary T-care. Now, when we deal about severe valgus, moderate to severe valgus, bilateral valgus, almost incapable to walk, stand unaided. This is the X-ray, standing view X-ray of both knees. Now, how to go about it? First thing is that we have a medial structure. These are deficient. Medial soft tissue, medial collateral ligament. So do not do any medial release, or it should be minimum medial release. And most of these cases are rheumatoid patients who have a least subcutaneous fat. So while making an incision, make sure that you go up to the quadriceps in one go. Next is minimum proximal tibial cut. It may be 5 to 6. So because you have a gross medial laxity, so the less the bone you remove, you can compensate with the laxity with minimum insert. Now we have a lateral condyle of femur that is hypoplastic. So whenever we are going for the distal femoral cut, one part of the jig, it will be floating on the lateral condyle. Do not force it down to touch the lateral condyle. Always think that you have to replace it with a distal femoral augment or a graft. And most important is that avoid internal rotation of femoral implant. And most of the time we perform this mistake while sizing the femur. This femoral jig, we try to push it against all the condyles, and always there is a deficient posterior condyle or distal condyle. So the foot of that jig will always be in a floating mode. So try to put a spacer in between so that you do not internally rotate it, like this. Now remember that in genu valgum there is no deformity in flexion. All the deformities are pronounced in extension. So evaluate the flexion gap with a lamina spreader, but do not attempt for flexion gap balance immediately. First, go for the extension gap balance, and that has to be balanced properly. So this is the Ranawat balancing technique. Tibia cut first, extension gap balancing next, soft tissue releases. Once you are satisfied with the extension balancing, then go for the flexion gap balancing. So we have done all the cuts. Now see the lateral aspect is still, the lateral joint is still not accepting the insert. So need for further lateral release. Then comes the pie casting of the iliotibial band. It was described by Ranawat and Insal, and the technique is extend the knee, spread, use lamina spreader so that the lateral structures are visible. Use 15 mm blade, start below the popliteus, multiple stab incisions through the lateral capsule and ITB, and always remember that peroneal nerve is sitting very close, just 6 mm or within 10 mm around your fibular head. So this is the pie casting I generally prefer with a 18 gauge needle. You can pie cast LCL, you can pie cast popliteus like this. And after you finish, check the gap balance in extension. If you are satisfied, then go for the flexion balance. Now after ITB pie casting, if still the lateral structures are tight, this is a Brad technique of osteotomy, and it's a lateral sliding wedge, or sliding osteotomy of the femoral condyle, and it's a very easy technique. Now, finally you go for the patellar tracking. Patellar tracking, it's almost always abnormal in moderate to severe valgus. So inside out retinacular release, and once you are satisfied with the retinacular release, check it without thumb pressure technique that it's absolutely patellar tracking is normal. Now go for the final balancing with varus valgus stress. Do not leave much of flexion deformity there. Now there is another technique of addressing the lax medial collateral, that is Krakow's technique. So that is advancement, proximalization, and anterior placement of the attachment of medial collateral, taking a piece of bone and fixing it anteriorly and superiorly. So that is the result. What you want, the initial patient is the same patient. You need a balanced, painless gait and unsupported gait. Now post HTO valgus knee, this is original Coventry type of osteotomy done by someone else. See the situation with flexion deformity. This is the range of movement possible. So badly done osteotomy can lead to this. The problem is you are dealing with a reverse slope with a gross lateral fibrosis, infrapatellar fibrosis. So this 6 degrees is a reverse slope. Now the problem in post-HTO, femur is typically like a varus knee, but there is a patella bar or infrapatellar fibrosis due to old maltreated or malperformed surgery. And tibia is like a valgus knee because you have done a valgus, HTO. So there is no need for any medial release here also. And this is the post-op X-ray, we could manage it quite well. And how the perfectly done HTO can lead. So 10 years down the line, HTO done, it can be revised in one go. Just remove the implant and go for the TKR. Severe valgus, there is hardly any medial collateral existent. So go for a constant knee. Sometimes difficult exposures, you need a tibial tuberosity osteotomy and fix it with encerclage wires. And this is a complication. It will happen to any of the surgeons who are doing valgus knee quite frequently. So this is a foot drop, just post-op foot drop, drain is still in. So this is a nightmare, but you have to counsel the patient, you have to explain it beforehand to the patient and patient party. I'm not going into the extra-articular deformity Dr. Rajput will be dealing with, just a glimpse. If the tibial valgus deformity is responsible for valgus, then femur is intact. Femur is absolutely pristine. So go for femur cut first, and then tibia cut parallel to the femur. And before final preparation of tibia, go for corrective osteotomy, fix it with a locking plate, unicortical, and straightforward go for TKR. Something like that. If the femur extraarticular deformity we are dealing, then cut tibia first and based on that tibial cut, go for the femoral cut and perform TKR, and then correct the extra-articular deformity. So take home is soft tissue release is needed both on femoral and tibial sides. Posterolateral corner release is critical, and take care to prevent neural damage, to prevent the lateral popliteal nerve injury. Thank you.
Thank you, Dr. Pathak. Do we have any questions for him?
To be very frank, I'm not a very proponent of CR-knee. To me, CR-knee is particularly in those cases, at least for me, which are relatively simpler, be it a valgus or be it a varus. In any gross deformity, be it valgus or varus or FFD, I would never do CR-knee.
You actually open up more of medial side. So there is a role for CR-knee. In mild cases, CR-knee may be the way to go because you don't want to open up any more medially. But if you have severe deformities, I agree that you need to go one level higher constraint.
Yes, in mild
so there's
to
never
moderate.
a no for it, but there is a reason for doing CRs actually in these cases.
No, in gross deformities.
Yeah, gross I am agree that you have to do.
Moving on, may I now call upon Dr. Rakesh Rajput to speak on management of extra-articular deformities in primary TKR.
Right. So Chandan has asked me to take over for the extra-articular deformities. And we have it on here. Right, okay, anyway, so the extra-articular deformities can either be in, we'll limit ourselves to actually, just around the knee. So it could be either in the femur, it's come, okay. So we're talking about this topic basically. So if you want, you are assuming there is arthritis, you want to do a TKR, how do you tackle if you have deformity around it? And they come in variety of ways. It's not just like you will have very close to the joint, it could be far away from the joint, and it could be not only in a coronal plane, but could be in a sagittal plane. So, you could have multiplanar deformities also. So rotational element could also be there. So probably keep an eye open whenever you see a deformity, is there another level or another way the deformity is actually showing up. So when you look at these deformities and you look at the studies which have been done, you'll probably realize that when you look for it, there are very few studies you will actually come across. And when we began tackling these deformities, we realized that I could only find 2 articles at that time. So this is way back, about 14 years ago. I actually couldn't find studies during that time. There was just case reports. But now we have good evidence coming up forward. So most of these results from previous malunions, you could even have from the iatrogenic. If you do lots of osteotomies, some of them may not do very well. And some of these cases are either congenital or trauma or from Paget disease or hypophysis. So a lot of things can happen. Metabolic causes are also there. So we have 2 schools of thoughts how we tackle this. One school of thought tells us that you do intra-articular correction and subsequently decide whether you need to do something on the outside the joint. The other one is that you correct the osteotomy and then think what you're going to do in the joint. If you are going to do intra-articular correction with you have deformity extra-articular, and if you have to do lots of changes inside the way you're going to cut, then perhaps your conventional jigs are not going to be enough. You might need to rely on either navigation or patient-specific or even robotics. Right? So I won't bother you with these axes. You've been doing this osteotomy course. But the reason I want to show this picture is that sometimes the head, most of the cases you have heads, so it's easy to calculate deformity, but there might be cases where the head is not there. So either it's dislocated, for some reason it's absent, or you just don't have the X-ray and you manage to actually end up on the OT table. Shouldn't be happening, but it does happen not so infrequently. In those cases, you can actually define from the valgus deformity, just from the anatomical axis, assuming that 6 degrees, what normal valgus deformity on these axes are. And then you can minus the deformity from that. So the lower extremity, again, you've done the London osteotomy course, I won't bother you from that. But we need to measure the extra-articular deformity and get into some sort of algorithm as to how much I need to correct. For an example, if you have, let's say, a 10-degree valgus deformity or varus deformity, and you find this is entirely in femur. So how much do I need correction? Then you actually need to know where the deformity is, how far, or what percentage is it away from you. So let's say you have 20% away from the knee joint. So in that case, the deformity you calculate is, let's say, 10 degrees, you need to minus 20 degrees from that, because you're going to correct at the joint. So the closer the deformity will be to the joint, the more relevant it is. Suppose you are 80% away from the knee joint, then you need to minus 80%. So 80% of 10 degree would be 8 mm. So you're only going to correct 2 degrees, residual 2 degrees at the joint. So, so that is what the deformity is there away from the joint will not matter much. So proportional amount of deformity correction will be required at the joint level. So look at this case. I mean, it's more of a views in oblique, sort of abduction. But when you adduct, this deformity is fairly away from the joint. And there is also a deformity in the tibia. So you could have actually multi-level deformities. So when you try to correct this, you probably want to tackle it at one stage at some place away. So you don't want to tackle in both femur and this thing if you're going to do a TKR. So do your conventional way you're going to do your femur. So it helps if you do actually analysis beforehand with either CT scans or with your navigation. So once you've done that, you've done your femur the way you think you should want to be. If it all looks when you open up correctly, do your femur. Once you do your femur, see whether your box is looking good or not. And here the box is looking pretty good. So everything looked fine, except when you try to do the actual correction here. So the foot is quite rotated, if you see. So now what you need to do, all you need to do is to derotate that foot. So you derotate the foot and you fix the osteotomy in that place. Okay, so it's difficult deformity, but easy correction in the end. So this is now coming to 9 years, looks good. This also looks deformity, extra-articular deformity. Do I need to change something in my joint? And the answer is no. So if you actually look at the axis, it's not too bad. So you don't need to keep on tackling everything actually at the joint just because something looked deformed and was thing, because overall it comes back to the thing. But there are some which are very close to the joint. So these ones you can't leave. As I said, it has an effect onto the interarticular. So those ones you need to do osteotomy and correct them. So some of them, as I said, could be actually in the sagittal plane. So those ones also you need to correct. And you can do interarticular correction, fix it with a nail, and then come back and do your TKRs, right? So what are we aiming for when we do these extra-articular corrections? One, you want to have almost like a neutral alignment. You want to have femur and tibia with good sizing because you will have to have match your flexion extension gaps also. And you need these things to be stable and you need the joint to be mobile from day one. So whatever you do, you fix it in such a way that you're not going to immobilize it anymore. You're going to move these joints. Now, once we start looking at tibia and femur in a composite way, what is it limiting me to do all correction inside? And the answer is that limiting factor is the collateral ligament. So now if I think that into account, I make a box just under the collateral ligaments and the tibial cuts. And this is what we actually call a box. Okay, so this joint box, as we call it, if you can correct everything inside this box, which means below the collateral ligaments, you can go ahead and do many of these corrections inside. But perhaps the way we are going now is that you need to have regular cuts at the femur and don't cut any more. Rest you probably correct somewhere else, either by sliding osteotomy on the condyles like what Chandan was saying, or you do the extra-articular correction itself. So our threshold for going extra-articular is a bit less now because we have become fairly good at it. And this is how the deformities actually happen in case. Sometimes it's very confusing. Which one is varus, which one is valgus? So have a look at this diagram. It will tell you what is varus, what is valgus. So choices are three. Am I going to do ligament release? Am I going to do sliding medial or lateral condylar osteotomy, or am I going to go outside and actually correct extra-articular? So that is what we are going to do. Now if you, let's say you have a huge medial tightness. Let's assume you have a huge medial tightness. So what do? Sports people have told us by various dissections that you need to open up medial side. So capsule, you're going to open up, you're going to release capsule, you're going to release, you cut ACL, you're going to cut PCL, and in the end, you're going to cut MCL or release MCL. Now, for bigger release, you're going to release a lot of MCL. What is left with you? You really can't weaken MCL so much. So MCL is a sacrosanct ligament inside a TKR. So please don't go around releasing MCL too much. Do something else. Either you can correct deformity or you can slide the MCL insertion. Both don't go on releasing the actual MCL too much. For 1 or 2 mm gaps, I can assume that you can do this, but don't go on trying to correct 4 mm, 5 mm differences in gap. Okay? Most osteotomies are done very well, but some are not. So when you face these sort of situations, you need to correct it. Chandan showed you that you can correct the minor ones. But if you try and correct the major deformities, what happens is you will end up with a very big box of correction. And what other things are happening? You are stretching all the soft tissues, which is not a good thing to do. Because if you do that, the common peroneal nerve palsy will also kick in. And we'll just show you how much degree correction will cause how much of millimeters of stretching on the thing. So when you're looking at the X-rays and 3D scans, what you're trying to do, you're looking at the severity of deformity, you're looking at the amount of correction which is needed, the site of correction which is needed, the stems if you need, and you look at the skin conditions also because of the previous surgeries which might have happened. So look at this case. If you actually have an actual case deformed like this, these are the cases you might either want to do a sliding osteotomy or actually extra-articular corrections. If you try and correct intra-articularly the whole of it, you might be in trouble with a very big insert and then stretching of soft tissues. So you have a limit of a ligament release. Ligament I have just described. What I want to say is if you do a correction of 20 degrees, this will correspond to almost a 30 mm release. So you really don't want to do that because you're going to stretch tissues, you're going to stretch the nerve, and you may have a sciatic nerve palsy. Now, the question is if you have deformities like this, what are we going to do? Are we going to do first decorrection that whatever wrong has happened, we take away implants, do another corrective osteotomy, fix it, and then come back and do a TCAR later? Or we do all this together, that we do an osteotomy and we do a TCAR. So this has been a time-honored question what to do. So if you do 2 operations with space, and if you have 2 knees, then you actually do too many operations. So it makes there's an advantage of doing single operation, and a single line and joint lines are also preserved, but disadvantage is that it's technically more difficult, demands more amount of hardware, and also more amount of planning. So Chandan has already shown you this case, so I'll skip this one. But even for the medial side, sometimes you can correct. And when I was doing these cases, these are John Brad's slides, and I had written to him that what do you do for these cases? And he had sent me this. I was very skeptical about actually just using staples to correct that. So this is the areas where we learn this, how to do this. So you go at corrective osteotomy, do a staple. This is again a case. After seeing that it can be done, we decided that we'll go ahead and do, but we'll do a stem. So for me, it's actually a stem with all these corrections, whether you have severe or even mild, but I will do stems. I will not just rely on staples. So this is how we devised. In summary, what I would like to say is, these are extreme cases, and these are not very common cases. So you need to spend a lot of time planning in these cases. Also the steps, even if now you look at the literature, the steps are not very well defined, though we have devised our own way of actually going stepwise how to correct this deformity. But even now, it's a bit difficult to find in literature as to how you go about correcting this deformity. So next time when you see a case like this, I think just think about doing an osteotomy and TCAR in one go. And if that's going to happen, then I think the message is delivered. Thank you.
Any questions for Dr. Rajput? Yeah.
So it's a question which keeps getting asked time and again. As I said, if your deformity is same degree of deformity, let's say if you have 20 degrees, but it is just very close to the joint, you need to correct that. You can't correct all of that in the joint. But if 20 degrees is somewhere in the mid shaft, then you can accept that. You can correct that in the joint. Same thing in tibia. The more proximal deformities you have, so in tibia it's very actually easy. So if your mechanical axis and the anatomical axis is same in tibia, so if you draw a vertical down and if it is falling between half of your midpoint and the lateral condyle, you can actually correct in the joint. But if it is going away that, then you got to start thinking about extra-articular correction. If it is actually outside the lateral condyle, so that much amount of varus you have that your joint line which you are projecting is actually falling outside the lateral condyle, you need to correct that one. You definitely need to correct that one. So if you want to read Wang's paper on this one, okay?
Thank you, Dr. Rajput. May I now call upon Dr. Vikas Kapoor to speak on TKR in flexion deformity.
Good afternoon. A lot of things written in this lecture may not be what I do regularly, but this is more of a recommendation for most of the fixed flexion deformities. So most of these are mechanical blocks which prevent full knee extension. And there are various factors which lead to it: previous trauma, end-stage arthritis, rheumatoid. Actually, recurrent effusions lead to kind of position of ease. And after that, the patient relaxes the posterior capsule, has a slight flexion to reduce the pain, and it becomes a vicious cycle which leads to a flexion deformity. And the most of these deformities are because of soft tissue contractures at the back, and has a lot of osteophytes at the back and prevents full extension. Sometimes patellofemoral arthritis also is one of the reasons. A very cauliflower-like patella kind of prevents extension of the bone and therefore of the knee joint. So the gait in fixed flexion deformity, it can be in varus or valgus or whatever you see. The ambulation pattern needs a lot of more energy to move and limits their ambulation, and therefore they kind of attain a seating position. And they always tend to sleep with the pillow under the knee and fetal position, which aggravates the deformity. And the principles of correction is that they stand and walk on flexed knee, requires increased quadriceps activity. Each flexion contracture should be treated completely during TKR, and full correction should be aimed. So most of these get corrected under anesthesia a lot of times, and you try to get the full correction after the surgery. So patients with the flexion contracture have narrow extension gap in flexion than the flexion gap, and this needs to be corrected by soft tissue contracture release, and resecting more bone has been recommended in distal femur, to which I usually do not agree. Sometimes you can actually change the tibial slope slightly and get away with correcting the flexion deformity. And because resecting extra bone on distal femur has a disadvantage of elevating the joint line. But 2 millimeter or 3 millimeter here and there of cheating is always allowed. So mild, moderate, severe, in my opinion, is all the same. Between 50 to 30 degrees, I think all of these deformities exist. And more than 30 degrees, which is like 60, 70, 90 degree deformities, need some kind of preoperative intervention, stretching. Sometimes there is a unique method I have used. Sometimes I have seen we give an epidural injection or some kind of a regular femoral block, and we keep pumping so that we make the knee pain-free, then stretch it out for a day or two. And a lot of patients I have seen who, because of pain, have had a flexion deformity of 70, 80 degrees, stretch out to 40 degrees or 30 degrees within 2 days, because most of it is because of the pain. And once you take away the pain component in the ward with a constant epidural line or a femoral line, these guys actually tend to show much lesser deformity, which you can correct. So assessment after anesthesia, just as I said, very severe deformity can be corrected quite surprisingly after the disappearance of pain and muscle spasm. Of course, the choice of component is absolutely lost on me, because all the surgeries I do is with a CR component, and I don't think PS component is actually required for any of these flexion deformities, or even for the 70, 80 degree deformities. The PCL integrity, I would have spoken about it in the last discussion, but I resisted because I have never found PCL to be the real culprit. It is just like a medial or lateral collateral ligament. You've got one extra synovial ligament. It is never contracted. And you don't have to release it from the femur. You just have to recess it exactly at the level of the tibial articular surface. Once you take out the tibial bone, if you take it out in a slope of 6 to 7 degrees also, your PCL still has about 1.5 centimeter of attachment back in the tibia. And PCL, what you see is actually hanging out loose when you do a PCL retaining surgery. A lot more PCL is still left at the back, and that already gets stretched out and cleared. So therefore, it is rarely a reason for any flexion deformity. What is important in PCL is that there is a tenting of PCL with by the tibial osteophyte, which gets corrected once you take out the tibia. And there are small osteophytes or small loose bodies behind the PCL, which you should diligently take out between the PCL and the capsule, and your PCL will be fine. So therefore, I don't think any of these deformities need any PCL resection. So grade 1, femoral and tibial cuts taken in usual manner. Flexion contracture occurs due to osteophytes, and all osteophytes should be removed. As you can see, you need to clear the posterior side with your hand and absolutely be sure that there is nothing at the back. And you can see I was going behind the PCL with the help of artery forceps, and the PCL, as you can see, there is a small amount of PCL hanging ahead, but the large chunk of PCL is still behind on the tibia. And you remove such big osteophytes from the back and try to take it out, tease it out from the side of the PCL, and then eventually do this maneuver which everybody does to recess the gastrocnemius a little bit if you want to get a good flexion balance and extension gap. The tibia should be pulled forward and remove the posterior osteophyte. Soft tissue attachments are carefully dissected with diathermy. Remove the loose osteophytes with artery forceps. And then leg is lifted, and this is a test basically by Laskin. Ankle joint is passively dorsiflexed, axial pressure is put to the sole of the foot. If residual FFD is there, the knee will suddenly flex. It will not hold straight. Therefore, if there is full correction, there is no movement of the knee. Grade 2, as I said, people do the lengthening of PCL, which I have never done. The subperiosteal release with the help of an osteotome of gastrocnemius is what I do. And I rarely recess PCL, which has been shown in this slide. Establishment of posterior recess, as I said, posterior capsule is lifted off. I showed you that in one of these, as you can see this in this video. And once you do this, most of it actually, and after this maneuver also, if you are not getting full correction, you can slightly increase the tibial slope, cheat your way through, but it will work. And grade 3, as I said, extensive, people tend to use constraint prosthesis, but the maximum constraint which I have been using is an extender. I don't think we need to do any extra constraints for doing flexion deformities up to 30 to 60 degrees. People would be conveniently using PS design, but again, as you do more and more of one philosophy of joint replacement, you probably get used to understanding what you need to release and what not. I'm open to questions for this at any point of time. Excessive distal femur resection is something which I usually don't do. I would only do when I am absolutely hard pressed to make sure that I get some kind of, I am dealing with something very, very difficult. The trick is that while you are doing the first distal femoral cut, you must mark with a cautery the pinholes and go deep down, or put in methylene blue ink so that you can identify the pinhole again, and then go back after your chamfer cuts also to cut the distal femur if you are not getting your actual correction. So during closure, most of these deformities are associated with greater anterior capsular stretching and quadriceps elongation, and you should be careful during the closure and do a tight closure. Distal and lateral advancement of vastus medialis and medial capsule may be necessary. Post-op physiotherapy should aim at counteracting the natural tendency, so a brace may be useful, which is usually given. Understand the pathogenesis and be very, very sure of your own experiences. Always, everything does not work for everybody. Pre-op measures, casting are useful in inflammatory arthritis. As I said, instead of casting, I do a pre-operative in a very resistant flexion deformity. I try stretching them out with the help of a continuous anesthesia, which for 48 hours, which works. Don't consider distal femoral resection first, but I always do a distal femoral resection no matter what, because of my philosophy of surgery. Identify and remove the adequate osteophytes and posterior release. Distal advancement of medial flap to reduce the quad's lag, which I don't think really helps, but a tight closure is always welcome. Thank you very much.
Thank you. Any questions? I have a question for you. Suppose there is a severe flexion deformity, fixed flexion deformity. Is there any role for preoperative traction while we are waiting for surgery?
So that's what I said. Traction we have abandoned long time back, ever since very few cases are there which are really needing that level of that difficulty level. But if they are there, the first thing is that if you have a lot of X-ray evidence of extreme amount of bony patellofemoral cauliflower-like growth, which is restricting the extension, as well as the posterior large osteophytes, then you don't need to worry. Traction is not going to help. If you don't have any evidence of bony issues, that means, and severe rheumatoid pain-like situation, you relieve the pain of this patient, and most of them will stretch out with a continuous pain management system in the ward itself, and within 2 days' time you will be able to actually deal with those knees.
Thank you. So moving on, we have the next session of a panel discussion in difficult primary TKR. May I call upon the moderator, Dr. Nirmal Jajodia, to please carry on the proceedings. The panelists will be Dr. Ritik Ganguly, Dr. Chandan Pathak, Dr. Jitendra Maheshwari, Dr. Karthik Shukla, and Dr. Nikhilesh Das. Could we all have them on the podium, please? Thank you.
Dr. Ganguly, Dr. Pathak, Dr. Maheshwari, Dr. Shukla, Nikhilesh, is he here? Okay. Dr. Chandan Pathak? Okay. Dr. Rajput sir, can I have you on the stage when we are missing others? Rajput sir? To participate, because Chandan is not there, Nikhilesh is not. Idhar. Okay, so we'll go through a few cases and bring forward few questions which are important to address and to provoke the thought process while we analyze these difficult primary needs. So the case one, let me just begin with the very common deformity, the varus deformity. So we have this 69-year-old gentleman who has this bilateral knee pain and swelling, has difficulty in walking, has an instability in the gait, and has a bilateral varus deformity when he walks into the OPD. And these are the clinical pictures that we have. We are concerning about the left knee at the present, and this is his gait. So my question to anybody, one of you, is that when you see a patient walking like that, presenting to your OPD in the left side, what are the thoughts that come to your mind? What are the concerns that come to your mind?
So this would be a combination of bony as well as soft tissue situation. Most of the time this needs something to work as a hinge on this. That may be the bony defect on the medial side of a tibia, most probably like a scalloping, which works as a fulcrum, and then the lateral, collateral, posterolateral corner, everything gets stretched out. So this is classically not FFD knees. They are good in extension, but in mediolateral, means coronal plane, they are unstable.
Right. So you're bang on point. So you are looking at a...
May I? So one point, whenever there is a severe deformity and patient has not much pain, I always look at neurological background.
Right, sir.
I would examine that patient from neurological view.
Yes, yes. We did so. There was no neuropathy in his case. No proprioception was intact, no sensory loss.
So just one more point. If somebody is not seen a varus thrust gait, this is what it is, okay? So it invariably means there is a defect on the middle side. And what you need to now see is whether the lateral structures are stretched out or not.
Right. So you're looking at an issue of a medial bony defect, a lateral stretching out. You're probably also looking at a neuropathic joint. And mind you, most of the knees, varus knees, are usually into flexion, but this guy's got an hyperextension deformity. So probably you're looking at a defect which is medial completely up to the anteromedial. So this is what we found on the X-rays. Again, as we discussed, that we have a defect on the medial side, as you can clearly see on the lateral view. And that's a weight-bearing X-ray, non-weight-bearing X-ray, unfortunately. That's why that deformity is not so manifest here. So the crucial point to bring forward is to have weight-bearing X-rays when you planning for these joints. So along with that, we went under evaluation under anesthesia, and there was a varus subluxation and the knee was hyperextending. And this knee was correcting up to the midline on a valgus thrust. So at this point, what are your concerns in planning your cut? What are the precautions that you'll have at planning your cut and planning your surgery?
So first of all, you have to correct the soft tissue contracture, the medial tight soft tissue contracture, the after medial parapatellar incision, the medial, the MCL, the some if necessary biclasting after that, and the bone cut should be minimum as possible because there is a laxity, and we start from the femur, then we go to the tibia, and if after the we have to check for the extension gap and flexion gap. If it is tight in extension, then some PCL may be erased, and in that case we may require a PS.
Okay, so your concern is that you will probably go for a higher degree of constraint. You will cut less tibia bone. But one of the things that you have here is also the knee is hyperextending. So,
yes, so cut less femur as well.
Right, right. So would you be prepared with more constrained implants or any special bone build-up armamentarium like wedges in your planning for the case?
Yes, if in the tibial side, if it is a defect in the tibial side, then we may use the bone graft in that defect, and in that case we fix it with the help of the screws and check the balance after placing the tibial tray. And that's why.
So any severe deformity like this, you should be prepared with both augments as well as constraints. And that's a big problem in our country, because when you tell the company guys I'm going to do a TKR, he brings you ABC, that's it, nothing more. So if you have to specially tell him that you may need these extra implants, otherwise they don't get it.
So as discussed, we cut the tibia less, 6 millimeter referencing from the lateral side, and that was the tibia cut. We also cut less of the femur, an 8 mm cut on the femur to compensate for the slight capsular stretching. And that was the extension and the alignment, because with very minimal release, because most of the varus deformity was primarily because of the defect, and it was correctable under anesthesia. So with very minimal medial release, we could actually attain a good alignment. Now the question was the defect. After the primary tibia cut, we are left with about a 6 millimeter of defect here. What would be your preferred method for building up this defect? Rajput sir?
So 6 mm for me is bone graft. So because it looks like an uncontained defect. So for me it's a bone graft which I'll screw up and then a stem to bypass that.
You would use a bone graft. Anybody would go for just a cement augmentation or a cement with a screw augmentation? Anybody for that?
Well, if I use stem, I would do away with bone graft. I'll just use a cement. 6 mm is little less for even a stem for me. So I'll probably use a bone graft and 2 screws and just put it. It all depends whether it is anterior to posterior 6 mm or is it just 1/4.
It's so most of it is posteromedial here.
Posteromedial is something not very worrisome. If it is all the way anterior to posterior, then I tend to use stem, otherwise not.
It depends on the thickness of a poly what you have right now. If
that's a minimum poly. We had
you can, if you have to do thought process, either you build it or just go for 2 millimeter thicker poly. It's up to the choice.
Right, sir. So one of the points to take is that you can actually increase your tibia cut and go for a higher size poly so that you have a lesser problem to handle. So these were the management options that we wanted to discuss.
If you come, let's say, poly of 9, which is what most companies would be, or 10, this is a message I would say: don't cut any more tibias, please.
In a primary.
That's not a message I think we should give. Stay with that poly. Do something with the defect. Yeah. There is nothing harm putting a stem, but don't cut any more tibias.
So we managed it with a screw and a cement augmentation. Only we didn't think the defect was big enough to warrant a stem, and that's the stability of the knee with minimal release and a primary knee essentially. Right. So let's go to the second case now. Now this is an interesting case. It's a 63-year-old lady. She had an acute exacerbation of the knee pain and inability to walk for the last few days. Now she's a very obese lady. Her BMI is more than 40. She's morbidly obese, and she has seen me multiple times in the past for a knee pain where I have been recommending her surgeries, but she has not been undergoing the procedure. And now she suddenly comes to me with severe worsening of the pain. Now, with that kind of a clinical history, sir, what comes to your mind as the reason for the patient coming in suddenly? That was the X-ray from the previous consultations.
Stress fracture.
Stress fracture.
So you must think of a patient who has been running away from surgery and suddenly agrees to come in for a surgery, and you shouldn't be very happy because you probably have more problems which you cannot see. So I didn't depend on the previous X-ray which was taken 4 months back. I asked for a new X-ray. On the left side, do you see anything different from that X-ray and this X-ray taken at 3 months apart? This is the X-ray.
There is a stress fracture there.
Yeah, so you could see a dense line on the medial side and there is a stress fracture there. So just to bring home the point that when you have a sudden change in the history and a sudden change in the presentation, we did an MRI just to confirm, and this was the MR finding, though that was clear, but because she was a doctor's mother, I wanted to be more clear about what I was dealing with. So it was a stress fracture. So if you have this patient and you are planning for a surgery now, or what is the management you're offering?
One formula I have for my patients is, any patient who comes on a wheelchair must stand and take 4 steps in front of me. If they cannot take 4 steps, something is wrong. I don't operate on that patient. Worst of osteoarthritis, patient should be able to take a few steps, even with pain. If they cannot, some neurological, some fracture, something else on the hip or wherever. Otherwise, I don't operate on them because I know there is something else apart from the knee. So 4-step walk test is a must before patient goes to the OT.
For me, it is the night before the surgery.
Even night before in the OPD?
Yes, OPD and also the night before. You may have seen the patient 1.5 months back and advised a surgery, and they walk in and then they have developed something new. So the same protocol on the night before the surgery.
A lot of patients will walk 4 steps even with this.
Oh, they will have too much pain and you will know suddenly something is wrong.
Right. So what is the treatment you'll offer this patient? Would you offer a conservative treatment? Would you offer a plaster cast? Would you offer a total knee?
So,
total knee.
See, the whole reason for this is the deformity. They've had a deformity, that's the cause of it. Unless you take out the cause, this is not going to heal. Occasionally they have healed, but they have taken long time to heal. There were times when we treated this conservatively like 10 years, 12 years ago. We now realize that you need to do a TKR, you need to bypass, and it's one surgery, one treatment. Done.
Even if it heals with plaster, its purpose is not served.
Going to come back again, yeah.
She anyway needs surgery. She needed surgery. Right. Thanks to God that He has forced surgery on her, which is good for her.
So this is what we did. We bypassed the stress fracture with a stem and a primary total knee. Another one with a worsen variety, a more worse variety of a stress fracture, a rheumatoid patient. And when you see that, what are the issues that you will be concerned in planning for the surgery?
So number one is the bone quality. Number one, that's very crucial, rheumatoid patient. Femur is not a problem. Number two is a tibia. So you need to provisionally fix this tibia before, if you do anything else. Either you just put a tibial rod first and then leave it, fix provisionally with your two screws proximally distally. Otherwise, this will be angulation. This is a difficult surgery, and the stability as well of the collaterals as well. Mostly stability should not be an issue with the PS or gap balancing is like other systems, but tibia needs a lot of attention here. That's very important.
So would you ask for an intramedullary jig for cutting the tibia in this case, or would you still depend on an extramedullary jig?
No, I will go for intramedullary for sure. 100%, 100%.
Okay. So you're also concerned about the bone quality, as you said. You have a big defect. So would you like to graft this defect or do something else for this defect?
I will keep augment ready for sure in this case. Medial tibial augment for sure.
Right, sir. So these are the points that I wanted to bring up, that when you have a deformity, you need to have an intramedullary jig. Unfortunately, I didn't have an intramedullary jig for me, so referencing was a problem. I did an extramedullary cut, and then that was the problem. My stem was getting, because of an extramedullary cut, and then I was having difficulty in aligning my tibia to the lateral surface. I'm having some lateral overhang. And this design doesn't have an offset stem. So again, one more point.
So something you can do normally in this thing is you can start using a locking plate with a unicortical screws, 2 up and 2 below, just to hold your thing before you start cutting it. The other thing is you can do a freehand cut on the proximal tibia let's say about 4 mm or something, just to get the cortical bone out. Start centrally actually putting your the drill first. Get into the distal fragment. So that gives you now an intermedullary alignment, even if you didn't have the jig.
Right. The problem is if you don't have an offset stem, then to find out the entry point on the cut tibia is a tricky thing.
True.
So you have to align your medullary cavity and see where it goes and touches your tibia. That's the point you start your entry point. Otherwise, like here you were too lateral. So you can actually create deformity, number one. You can cause fracture while entering you can cause end stem pain. If your tibial plate rod is not aligned to the medullary cavity, it's a problem.
Let me answer this question. So if you've taken away the cortical part of the tibia out, and once you start entering, because it's cancellous, it will actually take its own shape. It will bring you back. Once you've aligned distally, proximally also it will align it, because you now got soft bone on top. That's why I said you take away 4 mm bone on top. If you do that, the alignment will come automatically.
Yeah, if it is very osteoporotic, yes.
Yeah. In this case, it did not come.
But he didn't do that technique. He did something else.
Okay. So that lateral overhand remained, and as we discussed, we put in a wedge for building up because we were afraid that the poor quality of bone may not take up the graft. So I think Chandan sir had a good discussion. He's not here. This was a valgus knee in a patient who was on long-term rheumatoid arthritis on DMRDs, and this was an MCL laxity. So the discussion of the classification has already been done. So this is the kind of knee that we have. Where would you grade it, sir? What kind of a valgus deformity we have here now? What is the status of the medial collaterals, and what are the other challenges that you have?
I don't think medial collateral will be much affected here. It's more of a lateral defect, which is causing pseudo opening of the medial condyle.
Right, sir.
Medial side. So it's more of a defect issue.
Is the grade 2 actually, which is subdivided into 2A and 2B. So 2A has reasonable amount of MCL. It may be stressed out, but it is still functional. And in 2B, you don't actually have an MCL functioning. So this probably is 2A, I think. But yeah, again, you might get surprises. So be prepared for 2B also.
Yeah, and it is not correctable at all on valgus stress, on varus stress. So obviously total knee, but what is the approach that you would choose? Would anybody pick up parapatellar, lateral parapatellar approach for this knee, or is that debate settled?
I think even people who do lateral patellar say grade 3. So for 2, they will remain with medial parapatellar.
So
even people who do Keblish will actually do it only for 3.
Any special considerations regarding the rotation of the femoral component and the amount of valgus that will dial into your femoral component from the anatomical axis?
Those are standard valgus knee issues, I think. Anything specific?
I would go for gap balancing knee.
Sorry, sir?
I would go for gap balancing knee,
right,
not a measured resection knee.
Okay, okay. So you'll cut very, very less from the referencing from the medial side then?
No, I think because there are a lot of people listening to this, they should at least hear this out a bit. So these are very difficult cases to get your femoral rotation right. So here use all techniques which you know. So use wide side line, use transepicondylar axis. Posteriorly, probably you will not get a very good reference because you've lost the posterior lateral condyle. So use your cut tibia also as a reference. So 3 things you should use reference: cut tibia, transepicondylar, and wide side. So don't neglect in this one, otherwise you'll go wrong.
You'll go wrong with your rotation. So these are the structures which are tight in extension, tight in flexion, and tight in both. And after doing the releases of the IT band, the posterolateral corner, we were still struggling with getting both tight in flexion and in extension. So obviously the lateral collateral ligament was tight. We followed the gap balancing technique, which I usually do for most of my knee. We did the lateral epicondylar osteotomy here. So marking it and then sliding osteotomy of the epicondyles, so just run it fast in interest of time. After we do that, the important thing to bring out here is how do you identify the isometric point for fixation back? Why am I stuck now?
So I think was that a question, Nirmal, or you were just murmuring?
No, I was just trying to show you why.
Said very softly, so I wasn't sure. So I think you do the osteotomy.
Right.
And you bring it down, and generally what you need to do is bring it down, and then you see whether you have laxity only in flexion or you have laxity in flexion and extension. So if it is extension also, you need to bring it forward also, and if it's only in flexion, you just need to bring it down. So once you do that, you put a K-wire and just hold it temporarily and then see how you feel about it. So you shouldn't fix it at this moment, you should just temporarily hold it. Once you are sure about that, then you can actually put your spacers around everything and then go ahead and do that.
Right, so that is what we are trying to demonstrate, exactly what he said. So get the trial into position, do not fix the osteotomy, let the knee run through the whole trial, range of motion, and at one particular point, you'll find it to be really stable without displacing during flexion and extension. That is where you put it temporarily with the K-wire, then you finish your fixation with screws. So that is what a very basic primary knee with just a sliding osteotomy, no constraint, simple knee. And that's a post-operative, the right knee that we operated, straight. The left knee is still to be addressed. So this is interesting surgery because many MCL reconstructions have been discussed in the last 2 days. This is a 56-year-old lady who had a history of trauma to her right knee and has undergone 2 surgeries, one for the repair of the MCL, then the second one was for a reconstruction of the MCL, both failed. She has difficulty in walking without support and a lot of instability in gait. She cannot walk without a walker. She has a previous history of long-standing knee pain in the same knee because of osteoarthritis. For the other knee, she has already undergone a closing high tibial wedge osteotomy 13 years back, and it has served her well at the age of 43. On examination of the right knee, we had a serious instability of the MCL and the ACL. These are radiographs. So, sir, anybody, would you like to consider a reconstruction procedure for the right knee? After having undergone 2 failures.
This is arthritic anyway.
Yeah, 59.
Yeah, she needs replacement.
She needs a replacement.
And the question is which replacement?
Right.
Right?
How are you going to plan
For me, MCL is gone, it is only hinge at any age. Once MCL is not there, it has been reconstructed twice. MCL is the key ligament of survival of knee. So I'm not hesitant about using a hinge. Some people might use TC3 or kind of a limited. In my hands, it fails. So MCL is gone means it is a hinge replacement.
Rajput sir, are you still committed to a hinge or would you still give it a try?
Open mind. The reason is because somebody has tried to do an MCL. Maybe it's lax, but it's there, some amount of it is there. So what you do is you open up with a good mind, but you have to go for semi-constrained at least. In that case, if you find MCL, some part is there, some is deficient, you can reconstruct and augment it. But if it is completely deficient, then I will straightforward go for hinge. Because MCL is the only retaining part in the middle. So if it's not there, you are almost veering off towards a hinge.
Karthik sir, any other input, sir? Hinge. Even at the age of 59, considering hinge will require a lot of bone distal sacrifice. Right. Oh, well, so as we were prepared with a hinge, but during the surgery we found we could get a reasonable stability with her TC3. So both femur and tibia went in for stemming, obviously, because of the instability and the stresses, and then we could manage with her TC3. Her MCL still is some part of it is still functional and giving it stability.
I think would have been better to even augment that rotary table. Because
graft?
you were always doubtful. Yeah,
with
put another graft in.
Okay.
Whichever, I think.
So I think the issue is, what is your alignment on the table in this knee? If this is even 1 degree of valgus, it may be stable on the table, it may be stable for 1 year, it will become unstable after 1 year. Okay? So that is the reason. If at all you are trying to not use a hinge, you have to ensure that on the table alignment has to be 2 degree varus. Okay. And then also reinforce it with some graft. Even that, to my mind, when you walk, and especially if the lady is fat, it doesn't work. Because MCL stretches out late, not immediately. On the table, everything is fine. But when 80 kg or 70 kg weight goes on it, goes for 1 year, it opens up again. So I think MCL is a very tricky, and if at all you are confident about, as I repeat again, that this is little good enough, I want to avoid hinge, make sure at trial stage it is in varus, or make it varus at that stage.
Okay, point well taken. So we have a 6 months follow-up. She is doing well, at least till now. We'll still wait longer, of course. So one of the reasons why I wanted Rajput sir to be here, this is an extra-articular deformity, sir, and the deformity is way ahead out of the joint. He's a gentleman, 57-year-old, who had a femur fracture 25 years back, and it was treated without any surgery, conservatively managed. And now he has developed gross osteoarthritis because of the varus knee, and is having severe pain in the knee and wants to get a knee replacement done. On examination, there is no effusion. The limb is shortened by 3 centimeters. The knee is going through the full range. His hip spine are okay. That is the X-ray that we have. So Rajput sir, your take on this? What else information you'll want?
We need long axis.
You want a long
axis?
axis
For this.
So that's your long axis weight-bearing X-ray.
Yeah, so we need to calculate how much it is, but it looks like it's quite a significant amount of varus on the femur. So you have, the other trouble with this femur is that there is shortening. So you can't, lengthen anything out of the knee. So this is probably if he's actually coming ahead for surgery, this is the chance for us to lengthen this femur also. So that will only happen if you do a valgus osteotomy on that. So question is now, do you in one go or do you do all together? Because it is really far away from joint, I would do it in 2 goes.
So if you do it in 2 stages, what is the fixation that will have for your femur, sir?
Sorry, it will be a nail.
And then how will you plan the knee after you've done the nail,
Yeah.
considering you don't have navigation with you?
You have handheld navigations now, so I don't think that's an excuse now.
Right.
You have handheld, but you could do nail and correction in one go also. If our patient is head pressed that you have to do it in one go, you can go in one go. For me, a healing of femur will be required probably before I think about another surgery. Otherwise, if I have problems with healing of femur, then I'm really stuffed. So I would stage if this guy is okay with that. But you need to gain length in this one. 3 centimeters is unacceptable shortening.
Sir, your take on this?
So I'll definitely correct the femur separately. He's a young guy. I'm not very fond of correcting bony deformity intra-articularly as far as possible, particularly in young people, because I'm trying to fool myself. Ligaments are not my friend. Bone is my friend. Bone I can do whatever. Once you have a trapezoidal space and you balance it on the table, you are leaving it for future problem of instability. So I have a more tendency to correct bone by bone, and I always do it in one stage, whatever it may happen. I'm a good trauma surgeon as well, so I can fix any bone very well. I know it may go into delayed union, I can always graft it, but for a patient, one surgery and intra-articular, you don't need navigation, you just need a rod on the table, because you can always use an extra-articular jig. Prepare yourself so that you can have image intensifier, hip, knee, ankle, X-ray on the table with a rod, and that gives you reasonable alignment. So rod the femur, do a standard TKR, be sure, because you can't use the intramedullary rod now, you can use the extramedullary for femur also, use hip, knee, ankle, and job is done.
So both of you agree for a 2-stage procedure for it?
Same stage. I would do same
you're for the same stage?
No, I'm not saying that. I said that's what I would do if patient agrees. If patient doesn't agree, I would do it in one stage also.
Right.
But I think, Jiten, I would say that extra-articular jigging is very inaccurate at the best of the time. So where you are now trying to get as close to normal as possible.
If you have navigation, no issue. But generally people will not.
But they will have handheld navigation. It's available.
So these were our concerns too, and
he's a friend of mine. I can fight with him. Don't use high-tech things occasionally. So not that one patient, tricky patient, you'll use handheld. Actually, we are more used to using image intensifier better than even handheld. It may fool you. So don't use Mercedes car on day one because you'll have an accident.
So we were just planning and thinking if we could do an intra-articular correction. Obviously we couldn't, because that osteotomy line would go way beyond the lateral epicondyle, making the lateral collateral insufficient. So we had no option but to do an extra-articular osteotomy for him. And that was the CORA, and that was where the osteotomy was planned at the apex of the deformity at 25 degrees, so at 2.5. We thought of a closing wedge because of an opening wedge would have instability issues, and we were planning the surgery in the same stage. So that was the intra-operative identification of the apex of angulation, and then osteotomy, and then stabilized primarily by a plate. After we stabilized it with the plate, we went on with the handheld navigation and also the intramedullary guide, short guide, and did the distal femur resection, and that is the final endpoint of correction of the alignment and a totally straightforward totally.
Only issue I have with this one, as I said beforehand, in case you have a non-union, now you have a rod of the stem which is gone in, and your whole knee will have to come out then. Well, how will you treat this non-unions?
Yeah, so we grafted, you can see a lot of graft laterally, the same tibia.
I
We
fully
are hoping
agree.
for union, and at 7 months, the posteromedial corner was already uniting. And that's the longest
You
follow-up.
could even put a nail down there and still put a CR knee. You still have a chance to take out that nail in case something happens.
That's a CR knee.
So you put a rod, or is that a stem? Which
No, it's
on
not a
rod?
stem, it's a different, it's a DFN and then a CR knee. So the last case, hurriedly, over 62-year-old lady, history of fall down, fracture which was missed initially, 9 months down the line, comes with a medial Hoffa ununited fracture and an osteoarthritis which is painful and inability to walk. So sir, what are your considerations at this stage? Are you going in to offer a knee replacement, or are you going to go in and do a fixation of the Hoffa fracture, the medial Hoffa fracture?
How long it's been there?
9 months from the trauma. So these are the CT images.
I missed the history. How old was this patient?
She's a 62-year-old lady, painful knee, history of fall 9 months back, undiagnosed, had a medial Hoffa fracture and an osteoarthritis. Now she's unable to walk without support.
Okay, so I'll just make it short. Even if you try and fix this Hoffa, you can actually fix it. But if you see it's not going to be congruent joint after that. So I'm going to suffer incongruency, and again, she's at an age where I don't think we need 2-3 surgeries. So you want to fix it and then actually go ahead with the TKR. So you need to fix with such an implant which buries in so that it doesn't stop your cut.
Right, sir.
So what we've done is we've actually done multiple K wires, and turn by turn we've cut and taken out those wires.
And would it be a standard TKR for you, or would you need some special stem? You'll stem it.
Because you don't have zone 1 fixation, you either need zone 2 or zone 3. Zone 2 means you're going to in a sleeve and all that. So better to put a stem. Zone 1 and zone 3.
So in interest of time, we've just finished. So we did a TKR with a metaphyseal sleeve. We didn't think a stem was necessary because we get a good distal metaphyseal fit here.
It's an expensive way of doing it.
Yeah. Thank you.
So another comment after Rajput, of course. There is nothing expensive in knee replacement surgery. Use the best, don't bother about the expense. To my mind, this sleeve is a better fixation method in metaphysis than the rod. Rod has problems. If you're depending on rod and stem pain, fracture later on is a problem. So don't worry about the money.
Moving forward to our final session, early failure after routine TKRS. I would like to call the chairpersons, Shubhodno Mishra sir and Vikash Kapoor sir, to please join us on the stage.
So we are almost towards the end of this 3-day course, knee 360. So it is the last session today. May I request Dr. Suresh Kejriwal for his talk on TKR in stiff knees.
Good afternoon, everyone. My topic of discussion is TKR in stiff knee. So, stiff knee is basically the restriction in the range of motion of knee, usually associated with pain. And in literature, there is no general consensus regarding definition of stiff knee, which knee is called stiff or which is not. But in many literature, it is defined in different way. So etiology, it is primary or idiopathic and secondary due to trauma, previous surgery and inflammatory arthritis like rheumatoid arthritis. There is also functional classification. One is flexion stiffness, that is flexion deficit, restriction of flexion, and there is flexion contraction, there is extension deficit. The causes of flexion deficit usually are quadriceps contracture, heterotopic calcification, patella baja, postoperative osteoarthritis, and soft tissue adhesions. Before counseling the patient for knee replacement, patient should be counseled regarding the possible outcome that in this patient usually we don't get movement as in patient with normal TKR, and chances of complication in these patients are higher. Examination under anesthesia is an important part before starting an operation to assess the passive range of motion. Now, there is no formula for is exact for the treatment of the problem in every patient. In different patient, it has to be individualized differently, and one should consider a balance between soft tissue release and bony resection. Now, there are different situations like during operation, if you get a cut tight in extension and tight in flexion, then it's called symmetrical gap, and you have to think of cutting more tibia. If the cut is tight in extension but loose in flexion, this is an asymmetrical gap. You should consider releasing PCL, posterior capsule, may consider PCL substituting prosthesis, and at the last, resection of distal femur. When the cut is good in extension but tight in flexion, it is also an asymmetric gap, and resection of additional tibia may be considered, may release PCL, and one must ensure the posterior slope of tibia. And when cut is good in extension but loose in flexion, it is also an asymmetrical gap, and it needs femoral augmentation, and one has to think about the adjustment of larger femoral component. So what are the options to increase flexion? One is a pie casting, quadriceps snip, quadriceps viviplasty, and tibial tubercle osteotomy. So pie casting of quadriceps, here the multiple stabs are made in the quadriceps tendon. It is very easy to perform. It causes less damage to quadriceps, and there is no change in the postoperative protocol. Quadriceps snip, here a snip is made at the apex of the quadriceps tendon, passing obliquely across the tendon at an angle of 45 degrees into the vastus lateralis. And advantage is there is no change in the postoperative protocol, and complication if there, it is not long-term consequences. And disadvantage is the exposure is not as extensive as turn down or tibial tubercle osteotomy. Now quadriceps viviplasty, or it is here straight parapatellar middle parapatellar arthrotomy is done, and along with that a diverging incision is made into the vastus lateralis tendon towards the lateral retinaculum. And advantage is it gives very good exposure and lengthening of quadriceps tendon, and it protects the patellar tendon and tibial tubercle. But the disadvantage is there is extensor lag. It may affect quadriceps length, and knee may need to be immobilized postoperatively. Now tibial tubercle osteotomy. Here the 6 to 10 centimeter of bony fragment cut from medial to lateral and fixed with either wire or screws. It gives excellent exposure, avoids extensor lag with VY turn down, and avoids quadriceps weakness. But disadvantage is it may require immobilization or delayed weight bearing, and there could be non-union avulsion fracture and wound healing problem. Now flexion contracture, it is very well dealt by Dr. Vikas Kapoor sir. Here we should consider the posterior capsular release, may need gastrocnemius origin release, PCL release, and at the last distal femur release. At times epicondylar osteotomy of large flexion contracture may be needed, and one may need lateral release of good lateral release and gutter release for patellar reversion. So these surgeries have many complications. The common complications are distal neurovascular deficit and fracture. So conclusion is, there is varying degree of stiffness is common in patient planned for knee replacement. Proper patient counseling is very important. Examination under anesthesia is an important tool before starting OT. Adequate soft tissue release and removal of osteophyte is the key. And if needed, pie casting of quadriceps snip, tibial tubercle osteotomy are helpful procedures. Thank you.
Thank you, Dr. Kejriwal. Is there any question? Okay. So may I request Dr. Anandu Mondol for this topic on managing MCL injuries.
Good afternoon, everybody. Now, my talk is on the managing MCL injury in the total knee arthroplasty. Now, if we see in this paper, why are total knee arthroplasties failing today? In this 10 years follow-up study of 780 revision total knee arthroplasty, the main cause was loosening in 40%, infection in 27%, and instability of the knee in 7.5% of cases. So we can see that the instability has a great role in the functional performance of the total knee arthroplasty. Now, in the previous debate, previous panel discussion, we have many times heard the role of MCL in performance of the total knee arthroplasty. The MCL injuries during the total knee arthroplasty are rare, but the incidence is less than 0.3% of all complications of total knee arthroplasty. The MCL crucial for valgus stress and the MCL deficiency in the total knee arthroplasty increases the risk of failure. If we see the chronology, the MCL injury may be occur in the preoperative period, like primary MCL deficiency due to the excessive valgus, or the previous injury to the medial collateral ligament, or during the previous tibial, high tibial osteotomy. It may occur in the intraoperative period, 2.7% of the intra-op injuries during the total knee arthroplasty. It often occurs during the medial release, because the medial release is a standard step to correct the varus knee. And other procedures are sometimes condylar osteotomy, pie casting technique, or the subperiosteal sleeve release from the medial aspect of the proximal knee, tibia. The MCL ruptured at the joint line during the femoral saw cut, or osteophyte removal, or the deep MCL release. The MCL release may occur during the postoperative period also. Now, what are the management of the MCL injury in the total knee arthroplasty? It can be managed with non-operative way, like cast or the knee brace, increasing prosthetic constraint, increasing thickness of the poly-insert, and repair of the medial collateral ligament, or the reconstruction. But the algorithm is based on the location of the injury. The major difficulties occur when injury is at the joint line, and if we do conservative treatment in this case, most of the times it fails. Now, in this paper, like you can see that conservative treatment for the intraoperative detachment of the medial collateral ligament from the tibial attachment site during primary total knee arthroplasty. It is showed that solely the non-operative conservative treatment for intraoperative injuries of the MCL during primary total knee arthroplasty is expected not only to be effective, but with satisfactory results, but also to decrease the complications of other sophisticated procedures like the repair of the ligament or the reconstructions of the ligament. Now, MCL reconstruction is the best reliable procedures for the management of the MCL injury in the total knee arthroplasty. It is here the peripheral graft is the semitendinous tendon. because of its reliability of the graft. It is instantly accessible because it is very close to the site of the incision. Low morbidity of the donor site, and insertion can be left intact if we use the semitendinous tendon. The technique is extend the incision little bit and incise the sartorius fossa along the fibers, harvest semitendinous tendon without detaching it from its insertion. The graft is then double-stranded and the proximal end is sutured. Pass the graft underneath the sartorius fossa and the deep initial is reconstructed using a 3.5 millimeter suture anchor just below the tibial plateau, slightly posterior, because the course of the MCL is different on the distal aspect with the attachment of the semitendinous tendon. And the graft is fixed with flexion of 15 degree and with slight varus. Then the medial epicondyle is identified. A guide wire is passed at 20 degree shaft head on the AP plane, and the graft is fixed at 15 degree flexion and with varus trace. Now, if we see in this patient was presented with osteoarthritis of the knee with a malunited distal femur fractures. What we have done, we have removed the interlocking nail and primary total knee arthroplasty done, but during the trial prosthesis, what we have seen that there was a pop sound, and after that we can see that the knee was opening on varus trace on the medial aspect. What we can do now? In this knee, what we have done, after total knee arthroplasty, we harvest the semitendinous tendon and then we reconstruct the MCL with the semitendinous tendon, and after reconstruction of the MCL, I have stitched the remnant of the previous MCL with the reconstructed ligament also. This is another one case. It was a varus knee, and at the same time during trial we have seen the MCL is come out from the a bone of piece with a bone of piece from the medial epicondyle of the femur. So what we have done, we have repaired the MCL with a screw. Now, if the MCL injury occurs at the postoperative period, from this case report, this is a case report which shows traumatic lateral knee dislocation of a well-functioning total knee arthroplasty. Here, a case of medial collateral ligament rupture. The authors have treated the patient with cylinder cast 6 weeks and followed by the hinge knee brace for 9 weeks. And this was the X-ray after the treatment, and there was no medial opening on the X-ray in weight-bearing X-ray. So they concluded that it can be treated with conservative way also. This is another one case from a paper. Here we can see the knee was well functioning, but after few years there was more gap on the medial side and it was opening up on valgus stress. So on exposure, what is seen that the MCL is almost absent on the medial aspect. So the knee was revised with more constant prosthesis and the medial collateral ligament was reconstructed with the semitendinous tendon. This was the postoperative X-ray after revision of the knee. So in conclusion, we can say that MCL injury can be managed by different options like conservative way, increasing polythickness, using constant prosthesis, repair with staple or anchor, and it also can be reconstructed by other graft also. Thank you all.
Thank you, Dr. Anandamundra, for your elaborate discussion on MCL injury in TKR. So, is there any question from the podium? Dr. Mondal, I have one question. So, what is your indication for primary MCL reconstruction in TKR, operatively?
If the MCL injury occurs at the joint line during the saw cut, especially during the femoral cut on the medial side, then you have to reconstruct the ligament. Usually the repair is not possible, and it usually not healed with conservative means.
Thank you, Dr. Mondal. Now may I request Dr. Manoj Khemani for presenting on managing bone loss in TKR.
Good evening, everyone. Nice to see so many people still there in Sunday evening listening to all these talks. So it's a very, very short presentation. So just if there is a defect, it has to be addressed. Very simple. Like every pothole which is filled before elections, we have to fill all the defects. Whatever there is left before the TKR, it has to be filled, and before closure, all the defects must be addressed. So why you are thinking about defect? It's very simple. Types of defects are only femoral or tibial. So we are looking at a primary scenario. In a revision scenario, there can be patellar defects also. So talking of the primary scenario, we have femoral or tibial defects, and then the defects can be contained or not contained. So it's a very, very simple thing. So let's see about the contained defects. The contained defects are cavitary defects. It may be medial or lateral. So these defects have a very clear-cut rim around them. And non-contained defects are segmental defects, in where the defects are lying at the periphery and there is no rim covering the whole of the defect. So coming to the femoral side, in the femoral side, usually we don't find large defects in the primary knee like we have in tibial sides, but in valgus knee, definitely we can have a hypoplastic femoral condyle, and when we are doing the bony cuts, we will find that the area is deficient or a defect is there. So this diagram beautifully depicts how you can cover up that defect using the bone which is available from the medial femoral condyle to cover the lateral femoral condyle. Or sometimes you can use the medial tibial bone also to cover the lateral femoral condyle. And of course, there are other modalities which I'll come later. And sometimes you can have bone cyst also. If you can see, if you can appreciate on this X-ray, there are very small subchondral cysts which sometimes can give you problems if they are large in number or large in size. So tibial defects, primary knees, varus or valgus, usually will have tibial defects. It can be minor tibial defects, it can be major, it can be very severe tibial defects depending on the bone quality, bone condition of the patient and how late the patient has presented to you. Posteromedial tibial defect is the most common defect which you will find, because obviously we deal much more in the varus knees, and then there can be posterolateral defects. These posterolateral defects can also be constrained, like you can see in this diagram. This defect, if you cut the tibia slightly, then you will find a well constrained defect there, well contained. So coming to the management, overcutting of the healthy bone, undersizing of the implant. This used to be a well-taught thing for many years, but nowadays it is losing its popularity. But still I have shown in one very special case where this is important to do. If you take a 2 millimeter cut, you can see on the medial side, it is taking away the sclerotic bone. This 2 millimeter extra cut takes away a lot of sclerotic bone, because this is not a deep defect. It's a wide defect, but it is not very deep. So you can just manage this defect by taking an extra bone cut. Then next you can do a cement only technique, where you just put a cement on the defect and forget it. That cement can be augmented with 1 or 2 screws. Sometimes you put screws into the bone, and on top of that you put the cement and then put the implant. That is end of the day. If the defect is even larger, you may think of doing a bone graft, that is autograft or allograft. Then even if you think that it will not be well managed with all those things, you have blocks, wedges, stems, metaphyseal sleeves, all those things to cover up with, give you a backup of everything. So let's see, the first one is cement only. You had a very small medial defect, and the sclerotic bone, multiple drill holes were done, and this sclerotic bones, and there was small cyst-like defects in the posterior aspect also. So this only cement will do, nothing else to be done there. The next one is the cement with screws. This defect was only 3 to 4 millimeter defects, less than 5 millimeter defect. So this defect can easily be managed with screws, but make sure that the screws do not touch the plate itself. Third one is the bone graft. If you can appreciate, there is a chunk of bone which has been put on the medial side with 2 parallel screws which is holding the bone together. And the fourth one is the metal block. You can see a metal block being used for the medial tibial condyle. Bone grafting technique. I wanted to show this because it is very important for youngsters to know this bone grafting technique. Any day you can find a chunk of posterior medial condyle missing, and you should be aware that a simple bone graft from where tibia or femur cuts can do your job perfectly. So it can be a distal femoral cut graft, or it can be a proximal tibial cut graft. The portion which was defective, you just take away, make it flat, make sure you have some healthy bone there, try to take away the sclerotic bone. Then you put that bone graft which you had taken from the distal femoral proximal tibia and put there in oblique fashion, and you can hold it with the temporary K-wires. Then you can cut away the top of the bone graft, and then you can put the definitive screws. One trick there is when you are putting the definitive screws, make sure that it will not come in the way of the tibial tray. Okay. You can actually put a trial stem inside or something so that you can see that the screws are in good position and it will not impinge with the tray. So this is an X-ray showing a bone grafted done in the medial tibial condyle. So management summary. Small defects less than 5 millimeter, you do cement. Contained defects, you do impacted cancellous bone grafting or cement only. Non-contained defects, you could do screw with cement, structural bone grafts, auto or allografts, or you can use modular implants. And just see the tips. Remove the cartilage completely, that's very important. If you are trying to address that bone defect, you have to remove the cartilage from there. Remove or roughen the surface of the sclerotic bone. You don't need to completely remove the sclerotic bone. If you are only using cement, you can do multiple drillings, but you need to roughen that surface. And make multiple drill holes in the sclerotic bone. Avoid cement seeping into the bone graft and the host interface. This is a very common problem you will find. You have put a bone graft nicely and everything, and when you try to cement it, the cement, part of that cement goes into the bone graft and the host bone. And this will not let your bone graft integrate. Avoid screw touching the implant. This can have detrimental effects later on. And blocks and wedges must sit perfectly. If you are using a block or wedge, you have to have a very accurate measurement so that you get a very good fit. So ultimate aim is to treat and prevent disaster. Okay? Thank you.
Thank you, Dr. Manoj Khemani. Is there any question for him? Is there any question? Okay, thank you. Okay. So, this is our last speaker, Dr. Orijit Ghosh, for managing extension apparatus engineering in TKR.
The risk factors are surgical technique. Meticulous surgical technique is essential, as in all cases. Poor patellar alignment, the patellar over resection, prior surgical procedures, patella baja, obesity, and previous surgical procedures and inflammatory arthritis. The symptoms are knee pain and swelling, new extensor lag or weakness, difficulty in performing straight leg raise, and inability to stand from sitting position and using stairs. On examination, tendon ruptures are often associated with a palpable gap. Diagnosis is mostly straightforward, clinical, as well as on a plain X-ray, AP and lateral and skyline views, ultrasound assessment of the tendons, and sometimes MRI imaging will help to delineate the fracture, the tear pattern. So what are the reconstruction options? Is it always surgical? There are a variety of surgical options based on the quality of the host tissue, the level of the disruption, whether it's the quads, patella, or the patellar tendon, degree of functional loss, acute or chronic, and the availability of host autograft and allograft, and patient's functional demands. So the methods are direct primary repair with biologic or synthetic augments, allograft tissue augmentation, and salvage techniques like fusion or knee arthrodesis or above knee amputation. So the patellar tendon rupture is one of the commonest, and the treatment depends on the timing, location of the injury, quality of the remaining tissue, and age and daily demands. It can be either direct repair, bracing, arthrodesis for infected cases, or augmentation. Augmentation technique in presence of poor tissue quality should be used. And primary repair without augmentation leads to high rate of deep infection, tendon re-rupture, and extensor lag. So what are the options? We have hamstring allograft, fresh frozen or freeze-dried Achilles tendon bone block, extensor mechanism allograft, and synthetic graft. So this is a clinical picture showing the patellar tendon repair and augmented with hamstrings. And on the right hand side we can see that the repair has been augmented with a Dacron mesh. On the left hand side we can see extensor mechanism allograft again, and on the right hand side you can see the fixation to the tibial tuberosity. So the algorithm according to AOS is if it's a direct repair, then we go for a direct repair, for a primary repair with or without augmentation. If it's not, then there's options of autograft augmentation, synthetic graft augmentation, and allograft augmentation. Next is the quadriceps tendon rupture. The risk factors are systemic disorders, excessive patellar resection, or prior quadriceps snips or VY-plasty. The options are conservative treatment with knee immobilization in full extension for partial tears, and surgical direct repair for complete tears. They have limited success, re-rupture, and overall complications including infection. Augmentation is strongly recommended in all cases of complete rupture. Options again are autologous semi-T or gracilis autograft, synthetic graft, and extensor mechanism allograft. Synthetic graft like Dacron, Gore-Tex, and lead skew artificial ligament. I'm not going into the details, but they all say that we need to augment with an artificial ligament in case of quadriceps. So this is an example of synthetic augmentation of the quadriceps. Allograft, there are concerns in allograft like immune reaction, disease transmission, graft strength, and freeze-dried grafts are weaker than fresh frozen and have a greater risk of generating a host immune response. The advantages are unlimited supply, variety of tissue types, and absence of donor site morbidity. In some cases, we need to do the gastro rotation flap. The rotation flap provides a vascularized muscle bed that promotes healing of the reconstruction extensor mechanism and does not rely on the bone quality. And the range of motion average is 3 to 93 degree and average extensor lag of 13.5. So again, the algorithm is if it's a complete rupture, then go for direct repair and then you augment. And for partial, that is extensor lag less than 20 degree, you can treat it non-operatively either with a cast or a brace. But for all cases, you have to augment, whether it's a mid-substance or an insertional tear. Periprosthetic patellar fractures, again, risk factors are excessive patellar resection, patellar implant with a large central plug, high BMI, osteoporosis, combined femoral and tibial malrotation, and component malalignment. Classification type 1 is stable implant, intact extensor mechanism, type 2 stable implant, extensor mechanism disruption, type 3A loose implant, good bone stock, and 3B loose implant, poor bone stock. So treatment considerations are location and depends on the location and pattern of the fracture, whether it's a vertical fracture or a horizontal fracture, integrity of the extensor mechanism, implant stability and quality of the remaining bone stock. Options like conservative like brace or cast, extension mechanism repair, and revision of loose patellar component or patelectomy. This is the algorithm for patellar fracture. It can be treated with a stable implant, it can be treated with a closed treatment, and for unstable implants, either it's a patelectomy or a revision of the patellar prosthesis. So the take-home message is complication involving the extensor mechanism can be difficult to manage. Most patients with complete disruption of extensor mechanism will require surgical intervention, and patients should be counseled regarding the severity of the problem, and their expectations should be managed appropriately. Thank you.
Thank you, Dr. Rijit Ghosh. So, is there any question for him? Thank you.
Thank you.
So, I conclude the session. Dr. Biplab Dolai, it is yes. Now we'll start valedictory session. It's a big clap. We should give a big clap for Dr. Biplab Dolai. It is a grand success, a 3 days course.
It's been wonderful last 3 days, and all good things come to an end at the end. It is indeed a pleasure and honor to organize this annual conference of Kolkata Arthroscopy and Sports Surgery Society. The organization of this conference has been made possible with the guidance and help from our senior like Dr. Kanchan Bhattacharya sir, Devashish Chatterjee sir, Rajput sir, and Vikas Kapoor sir. Also help from my esteemed colleagues, friends, and efforts from junior, all helped in lots of ways. With their help, we made this conference successful. All my colleagues did all the groundwork. I just coordinated this, and thanks to all of them. My special thanks to our co-chairperson, Dr. Sonnandu Samantu sir, M.N. Basu Mallik sir, and Sunit was always there. Academic content, we all know, was fantastic, and it was appreciated by all the delegates. This scientific content was basically came from Digicot sir. Some fine-tuning was done by Sunit and Manovendra, and we all know how fantastic it was. We also conducted 13 live surgery. Rajiv took all the pain to conduct it. JV sir was always there. He not only helped with the logistic, but he was there for consecutive 3 days. He monitored each and every step, and at the end he did a live surgery also. We learned from it in many ways. We need to give a special thanks to London Osteotomy Group. It was basically Sunit's dream which came true. He first watched their lecture and videos. He proposed it. This group was initially little reluctant to come over here, but Sunit constantly interacted with them. At the end, they agreed, and we all know how successful it was at the end. I would like to extend my gratitude to all other international and national faculty who took a lot of pain by traveling such a great distance for being with us. Our association in general and myself in particular are grateful to them. I also give thanks to all delegates. Without their presence or active participation, this conference would not be possible. And special thanks to Arnav. He organized the high-spirited cultural program, also created YouTube channel through which a lot of participants watched this program from a distance. Sanjay Da, Ritik, Gautam, Amrish, Anando, Moinak all played their role. They organized, arranged all the live surgery cases and participated in day-to-day activity. Organizing such a conference is not possible without the participation of trade people, industry like Conmed, Brussels Papa, Arthex, Biotech, Johnson & Johnson, Smith Nephew, Stryker participated in big way. There were some pharma company also like Torrent, Intas, Sun, Zydus. They also helped us to organize this conference. I must give special thanks to audiovisual Rajkumar Da. It was fantastic. We all saw how flawlessly this live surgery were conducted and transmitted here. I also give thanks to Vishwa Bangla Convention Center and John By Park. This venue all appreciated, including our international faculty. They all praised this venue. We all liked it, and in future also we'll like to come here again and again. Also, I need to give thanks to Rueda people. For quite a long time we are associated with them. All the beautiful, colorful things you are watching around you, it's their creation. Whenever we are in trouble, we just rang them, they managed it, they helped it, and tirelessly they carried out their work, and at the end they made it successful. But it's not the end. We have already started preparation for our next year. Next year it will be Somodip's turn. We will work along with him as a foot soldier. I think next year also we will be more successful. And during this course, if I do any mistake unintentionally, just forgive me, and all the healthy criticism are welcome so that we can make our future program more successful. Thank you.